Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market.
Elizabeth ma'am, Shilpa here. Unmute. Ma'am, unmute. Yeah. Good morning, ma'am.
Are we first session speakers and chairpersons in?
First one, sir.
Dr. Raj, Dr. Ekta, Dr. Rakesh, Dr. Rebecca, and
So person joined J, that is Dr. Ekta. We'll rename it. We'll rename it.
Dr. Rebecca.
Elizabeth, I have joined with Dr. Raj, so we both on same.
Yeah. What about Rebecca, ma'am? Has Rebecca, ma'am, joined?
I can't see her.
Yeah, let me just call her and see.
Another thing to remember is don't log into the the main stage at the same time. That can cause echo and other issues. So it is okay. She only needs to be there at the end for the discussion anyway. So we should start on time.
Hello. Dr. Sajay, Shilpa here.
Hello?
Yeah.
We okay to start?
Yeah, I think we can start because our first speaker is there and chairperson's also there.
Okay.
Yeah.
So ma'am will be Elizabeth ma'am, you are ready?
Yeah, I'm ready.
Yeah. So we can go ahead, right?
Yeah.
Yes,
Sure.
good to go.
Good morning. On behalf of Airway Society Kochi, I welcome you to Kaamcon 2021, which is being held as a virtual event. Airway Society Kochi was created in 2016 by a group of anesthetists with a passion for difficult airway management and teaching. We have organized Kaamcon for 3 successive years. The conference and workshops are approved by the Difficult Airway Society UK and endorsed by the All India Difficult Airway Association and Airway Management Foundation of India. They have been very well received, the highlights being national and international experts in advanced airway management teaching at the hands-on workshop and sharing their knowledge and views in the highly interactive CME. The COVID-19 pandemic has brought the world to a standstill. But with our human resilience, we are bouncing back. Advances in technology has made it possible for us to hold Kaamcon 2021 on a virtual platform. Our technical support team, A1 Logics, and my friends from Kerala and UK, Sam, Sajay, Jay, and Sajid, have worked hard to bring together an excellent program. We are truly humbled by the response we received, with over 2,000 delegates from 41 countries registering for Kaamcon 2021. We have an impressive lineup of faculty who are airway experts from different parts of the world, from UK, India, Switzerland, and Netherlands, who have agreed to join us in spite of their busy schedule on a Sunday. A special mention of thanks to our sponsors, especially the Intersurgicals, for their continued support over the years. Even though we miss the hands-on experience and the real-life meeting, we hope it will be a fantastic learning experience for all of you. And we hope that next year we will be able to have Kaamcon at Kochi itself without masks and hand sanitizers. We will now move on to the first session. I shall introduce the speakers. I shall introduce the chairpersons. Dr. Raj Sahajanandan is a professor and head of the Department of Anesthesia at Christian Medical College, Vellore. He has recently set up a state-of-the-art anesthesia skills lab and is faculty at national and international conferences with a special interest in cardiac anesthesia, simulation, and airway management. Welcome, Raj. Dr. Ekta Rai is professor in anesthesia at CMC Vellore. She is WFSA course coordinator for pediatric anesthesia fellowship at CMC. She has several publications in national and international journals and is a faculty at national and international conferences. Welcome, Raj and Ekta.
Good morning. Welcome to Kaamcon 2021. We'll start our first session, which is Back to Basics, for which we have an eminent teacher, Dr. Ramkumar Venkateshwaran. He has been the head of Manipal Hospital for the last so many years, and he has been the founder, chairman of All India Difficult Airway Association, and he currently is the editor-in-chief of Airway, which is the journal of AADA. Over to you, sir, for your talk.
A very good morning to all our delegates. At the very beginning, I would like to thank the organizers of Kaamcon 2021 for having given me this topic on back to basics as the starting lecture for the day's sessions. When I was asked to speak on this topic, I initially started wondering what I should be speaking. And then as I pondered over the topic for a little while, I realized that most of the time, things go wrong in medicine, in anesthesiology also, because we don't pay adequate attention to the basics. And therefore, I thought that, we can address the various basic issues in airway management during an anesthetic in a sequential manner, starting from a pre-operative assessment of the patient with a special focused airway assessment, and go on to the intraoperative management of the airway, and finally end up with the warding of the patient in the post-operative ward. So all these steps that we shall go through, I will try and address the basic issues that might go wrong. And of course, I will present evidence from literature, and I'll also present evidence from my own personal experiences as well as experiences from my colleagues, so that it will be more of a session that will be relevant. With this introduction, I'll go straight away to the first step of airway management, which is the pre-operative evaluation. Now, if you're working in a teaching department, very often the team that does the first pre-anesthetic evaluation will be the team of the residents, the trainees, who will probably do the evaluation of the patient on the day before surgery. And on the day of surgery, we get another chance. And what I would like to call that is a second look evaluation, which is usually done on the day of surgery in the preoperative holding area by a more senior person. And this can be used as an opportunity to re-evaluate the patient's airway and also to educate the trainee on any point that might have been missed. There's something that I've learned in my own practice from my colleagues mistakes was that airway evaluation should be essentially done both in the supine position as well as in the sitting position. And the reason for this is on one occasion, when I went to examine a patient in the ward, the patient was sitting up. And then when I asked the patient to look up and look down to evaluate the range of movement of the neck, what the patient did was the patient arched the shoulder backwards and created an artificial extension of the neck. And this fooled me. And needless to say, very next day, we had a problem in achieving adequate positioning of this patient for intubation. And from that point onwards, I decided that I should examine every patient not only in the sitting position, but also in the supine position. A lesson that I learned more than 35 years ago from one professor, Valerie Major from Vellore, was the 1-2-3 rule for a quick evaluation of the airway, as is often required in an emergency when you don't have time to do a complete evaluation of the airway. And this 1-2-3 rule is nothing but placing a finger in front of the tragus and opening the mouth and feeling your finger go into the temporomandibular joint. That's one finger. Two fingers between the incisor teeth when the mouth is open tells you that you have adequate space for introducing either a laryngoscope blade or a supraglottic airway. And three fingers from the chin up to the thyroid notch tells you that you have enough space in the submandibular region to displace the tongue during the process of laryngoscopy. A very elegant paper by Dr. Kodali and his colleagues in anesthesiology in 2008 brings out the importance of the changes that can happen in a lady's airway anatomy, not only during pregnancy, but also during active labor. So we know that we examine the airway in the first trimester. As we move through second and third trimester, airway changes do happen, and we need to keep that in mind. And when a lady goes into labor, because she strains to push the baby out, and there is also sometimes when inadequate pain relief is given, she may be also shouting in pain. And for all these reasons, you find that the airway anatomy changes and the airway becomes more edematous. Now, coming to the second part, that is after evaluating the airway, we now look at positioning of the patient for intubation. And for this, there is various recommendations in literature, starting with a pillow of a height of around 8 to 10 centimeters to a pillow that is non-existent, a no pillow situation. And all these recommendations are probably appropriate because when you look at an adult who needs to be positioned for intubation, an 8 to 10 centimeter high non-compressible pillow is placed under the occiput. And this results in a flexion of the cervical spine of about 35 degrees, which is one of the steps required to attain a line of vision to see the glottis. Going to the other extreme in an infant, you find that the infant's head is very large in comparison to the chest of the infant. And here you may need to place the pillow not under the head, but under the thorax or maybe a shoulder roll in order to elevate the thorax and make the head fall backwards in order for you to be able to attain the proper position for intubation. As the child grows, maybe to 2 or 3 years of age, then you may not need a pillow at all, either under the head or under the thorax. So the use of the pillow and the position of the pillow changes as the child grows. Now in an adult, we get the classical sniffing position by placing a 10 centimeter pillow under the occiput. This results in a 35-degree neck flexion, as has been seen here. And with extension of the face plane by 15 degrees, you get the final classical sniffing position for intubation. And this picture courtesy is from Dr. Maurya Indubala's paper in Airway 2020. Now, other than using the pillow for positioning the head, the other issue that we need to keep in mind is the relative height of the table. At what position is the patient's forehead in relation to specific surface markings on the operator's body is another issue that helps or comes in the way of intubation. So there is this elegant paper by Lee et al. In the British Journal of Anesthesia 2014 titled Higher Operating Tables Provide Better Laryngeal Views for Tracheal Intubation. And to the right, you have 4 diagrams, A, B, C, and D. A and B have the patient's head positioned at the level of the xiphoid process of the intubator. And C and D have the patient's head located at the umbilicus of the operator or the intubator. In A and C, the operator is providing mask ventilation, and in B and D, the operator is performing intubation. And the result of this paper indicated that when the head of the patient is at the xiphoid process of the intubator, as is seen in B, the intubation was much easier. So the table needs to be raised for proper, comfortable intubation to occur. And the table needs to be at the level, the head of the patient at the level of the umbilicus of the patient in order to be able to perform face mask ventilation comfortably. So that completes the use of the pillow or use of no pillow, the positioning of the patient's forehead at a specific surface landmark on the operator's body. And then we have special positioning for certain groups of patients. And one of these groups is what we know, the obese patients. Now, in the obese patient, again, the picture courtesy from Dr. Maurya Adubala's article from Airway 2020, we use what is called the HELP or the ramp position, standing for the head elevated laryngoscopy position or the rapid airway management position, which is achieved by placing several pillows or blankets under the upper thorax of the patient and the occiput of the patient, such that the tragus and the suprasternal notch of the patient come to fall in one straight line. So this is the objective of the HELP or the ramp position, where we get the tragus and the suprasternal notch in the same horizontal level, giving us enough room for introduction of the laryngoscope and preventing the laryngoscope handle from hitting the chest at the time of laryngoscopy. This is just another picture showing how several black blankets can be placed both under the head and under the upper thorax in order to achieve this ramp position. Or we can just make use of the troop elevation pillow, which is a ready-made available pillow, in order to achieve this position in the obese individuals. So now we have assessed the airway and we have seen how we best position the patient with or without a pillow, and how special positions like the HELP or the ramp position are required in obese individuals. And the next step that anesthesiologists would do is to oxygenate the patient prior to anesthetizing the patient prior to intubation. So oxygenation can be done either by one of these three techniques: the pre-oxygenation technique, the re-oxygenation technique, and the continuous oxygenation technique. And I shall explain each of these terms. The bottom line in all of these three techniques is the administration of oxygen to the patient at the start of an anesthetic or during the process of intubation, by which the functional residual capacity of the patient's lungs are filled with adequate oxygen, so that should the intubation or should the placement of a definitive airway take a little longer than expected, the patient will not desaturate to unsafe levels. Now, pre-oxygenation is possibly what all of us started with, when we were trained in anesthesia. And this is nothing but administering either 100% oxygen or various combinations of oxygen and air. There are several views expressed in literature, but you give an oxygen-containing mixture in order to build up the oxygen reserves in the FRC, and that's what is called pre-oxygenation. And we do this for a period of 3 to 5 minutes. Re-oxygenation is nothing but taking advantage of a situation when in between intubation attempts, when let's say you failed to intubate the patient in the first attempt, you take advantage of that break by re-oxygenating your patient and building up the oxygen reserves in the lung once again. And the third term here, continuous oxygenation, is probably the safest, where we administer oxygen continuously at a rate of around 10 to 15 liters per minute through nasal prongs. The oxygen goes in through the nasopharynx and oropharynx, and even in an apneic individual, it results in what we call apneic oxygenation. So these are the three basic methods by which we oxygenate. The bottom line is give oxygen. Oxygenate, oxygenate, oxygenate. Never miss an opportunity to oxygenate your patient during the anesthetic. Now, I just mentioned that we can use different gas flows to oxygenate and for different durations of 3 to 5 minutes. We also must remember that if you choose to oxygenate your patient, to pre-oxygenate your patient through the closed circuit system, the circle system has got a dead space volume, which needs to be flushed with oxygen. And this is what we call priming of the closed circuit. We must ensure that we get a good mask fit. If there is a loose fitting mask, then there may be gaps present between the face of the patient and the mask, and the patient may not breathe the oxygen mixture or the 100% oxygen that you are giving to the patient, but may dilute that by breathing air in the spaces that are there between the face and the loose fitting mask. Another point that we must remember is that we should not lose the opportunity of oxygenation during transport. Let's say you're transporting a critically ill patient from an ICU to the operation theater for surgery, or the other classical example is transporting a lady who has been in labor and now the decision has been taken to move her to the operating room for a cesarean delivery. All along during transport, and also while the lady is waiting outside the operating room for the anesthetist to get the operating room ready for surgery, we must make use of two important facts. One, we must keep the lady on her lateral position so that we avoid aortocaval compression, and we must administer oxygen continuously so that even before the anesthesiologist comes into the picture, adequate oxygen reserves are built up in the mother's lungs, and this will benefit both the mother and the baby. So despite whether you use pre-oxygenation or reoxygenation or continuous oxygenation, the safe saturation level would be more than 95%. And this is what has been emphasized in the All India Difficult Airway Association guidelines, where we have said that if the saturation remains above 95%, we are safe. But the moment it drops below 95%, it is time to escalate our airway interventions. Now, coming to the next step, that is introduction of the blade. And this can be done by one of two methods. And the important thing is, as we are introducing the laryngoscope blade into the mouth, one must look into the mouth to see the structures that are being displaced. Look at the soft tissues that are being displaced so that we don't inadvertently damage any of the soft tissues while the laryngoscope blade is being advanced until we reach the larynx. So the classical method of opening the mouth is shown here, where the operator's right hand is placed on the forehead of the patient and you tilt the head back so that the occiput is tucked under the shoulder, so to say, and this results in the mouth falling open automatically. And you're creating a cervical flexion of around 35 degrees, which is essential for getting the proper line of sight to intubate. The left hand of the person who's performing the intubation is now holding the laryngoscope, and the ulnar border of the palm and the little finger are now being used to further open the mouth. And this is more clearly demonstrated here in this artist's impression of opening the mouth by the classical method of tilting the head back and using your ulnar border of the hand or the palm and the little finger to open the mouth further. The second technique of opening the mouth is by what is called the cross scissor maneuver, wherein you place the index finger on the upper incisors, as is shown here, and the thumb is placed on the lower incisors, and by just crossing your fingers like that, you can open the mouth and create the space necessary to introduce the laryngoscope blade. So now that you've opened the mouth by one of two methods and you've been careful to look into the mouth to see the structures as they are being displaced, the operator who's performing the intubation now needs to announce the Cook's modification in 1, 2A, 2B, 3A, 3B, and 4. 1, you see most of the vocal cords. In 2A, you see the posterior cords. In 2B, only the arytenoids are visible. In 3A, epiglottis is visible and liftable. In 3B, epiglottis is adherent to the pharynx. And in 4, no laryngeal structures are seen. And accordingly, 1 and 2A are classified as easy, 2B and 3A as restricted, and 3B and 4 as difficult. Now, why is this important? It's important because when you look at easy grades of 1 and 2A, most airway managers can intubate with conventional view of 2B and 3A. Experienced airway managers, and when you go on to the difficult scenarios of 3B and 4, Cook's modification of Cormack-Lehane grade, even skilled airway managers may or may not be able to intubate, and you may require the help of an ENT surgeon in order to perform a tracheostomy. So depending on the grade of laryngoscopy that is seen and declared by the primary operator, we can plan our airway management accordingly. What airway equipment do we need to keep ready? We need to keep a stillet, a bougie, and a tube exchanger ready. The supraglottic airway device is always a rescue device, a savior in most situations. Though it's ideal to have a difficult airway cart in readiness at all times in a predetermined place, uh, it may not be possible in every operative situation. It's always wise to not only have appropriate equipment available, but also to have an appropriate assistant available. It is wise to have a trained assistant for every anesthetic, especially when dealing with extremes of age, obese patients, or identified difficult airways. And ego has no place in medicine. No matter how senior you may be, always make sure that you call for help in time. Once a difficult airway is identified, get an experienced assistant in the loop, preferably available in the OR. And if an emergency cricothyroidotomy or a tracheostomy seems to be a possibility, have an ENT surgeon also alerted and preferably present in the operating room. What equipment should I use? Ideally, we use whatever equipment we are familiar with. Do not use equipment for the first time when the situation becomes demanding. You know, it's not a great idea to learn driving on a crowded street. Once you've intubated your patient or you place an airway device, you need to auscultate for bilateral air entry and look at the waveform capnography for seeing at least 3 consecutive capnographs to ensure that the tracheal tube is in the right place. The supraglottic airway position is likewise good when there's free ingress and egress of gas is noted. There's no leak at 20 centimeters of water, and there are no sounds of gas entering the stomach. Once the airway device is in place, ensure that proper fixation of the endotracheal tube or the supraglottic airway device is done by yourself. Then you have only yourself to blame. And if the position of the head is changed to facilitate surgery, check the correct position of the device once surgical positioning is complete. And this is especially important for prone position, double lumen tubes, and RAE tubes for cleft surgery. We need to watch the capnograph and the pulse oximeter continuously like a hawk because monitors never lie, so human beings may sometimes lie. Now, any fool can intubate, and one needs intelligence to extubate is a famous adage. And we need to have an extubation strategy plan, which is known to the entire team. Extreme vigilance needs to be exercised at intubation as well as during extubation. And if intubation has been difficult, you should have additional help and equipment ready at extubation. If the decision is to retain the endotracheal tube and shift the patient to an HTU or an ICU for overnight observation, consider extubating in the operating room for a small subgroup of patients, though the majority of patients may be safely extubated in the high dependency unit or the ICU. Now, you must prepare a difficult airway alert whenever you had an airway management problem so that future anesthesiologists managing this patient may be physically, mentally, and equipmentally prepared for the occasion. Now, in summary, I'd like to say that we should make airway examination an important part of our preoperative evaluation. We should never be overconfident when the airway evaluation raises a red flag. One should insist that the primary operator announces the grade of glottic visualization as it acts as an alert for the rest of the team as to what is in store as far as the airway is concerned. Be confident in at least one other technique of securing the airway should your primary intubation attempt fail. And remember, a supraglottic airway device often saves the day, and always have one appropriate sized supraglottic airway device on your anesthetic trolley all the time. If a difficult airway is anticipated, be prepared with assistance and equipment. Never hesitate to call for help. Call for help early. There is no ego involved when patient's life is at stake. Never miss an opportunity to administer oxygen to maintain an SpO2 more than 95%. And go back to the drawing board following management of a difficult airway. Ensure an educative debriefing is done for everybody's benefit. And remember, finally, no matter who you are and how experienced you might be, no airway is safely secured by you until the capnograph declares it to be so. So once again, I end by thanking Sam, Elizabeth, and Sajjan for this wonderful opportunity and the entire team, Kaamcon 2021, for giving me this wonderful opportunity to share my experience. Thank you.
Thank you, sir, for that wonderful lecture. Now it's my pleasure to introduce the second speaker, who is Dr. Rakesh Kumar, who is my teacher from Maulana Azad Medical College. He's a dynamic anesthetist and has been an inspiration and role model for many of us. He's the founder chairman of Airway Management Foundation, and he was the director and professor of Maulana Azad Medical College, Delhi for many years. Over to you, sir. He will talk to us about safe extubation in difficult airway.
Thank you very much, Team Kaamcon, for this great opportunity. Bring greetings from Ambedkar Medical College, which I have joined. I'll be joining on 16th of January. And from my previous institutions, MAMC, where I worked for 40 years, and SGT University, where I worked for nearly 6 months. I'll be talking to you about safe extubation in difficult airway. And it is known that respiratory complications after tracheal extubation are associated with significant morbidity and mortality. And on top of that, although the death and brain damage because of problems at intubation have been decreasing in the past few years, the same is not true about problems related to extubation. And we know that there are preventable human factors at play. So there is all the more reason that we should know and give serious consideration to extubation. Extubation, we know because it is an elective process wherein we leave the controlled environment of a safely secured airway into an uncontrolled area wherein we are losing the control on the airway. So it should be absolutely at our disposal as to when we extubate the patient. Although the Vortex implementation tool is not meant to address this per se, but if you look at it, we do it is really applicable to extubation situations. So that we have to reoxygenate the patient, we have to assemble all our resources to the best of our capability, make a proper plan to extubate, and remember that it is never an urgency to extubate the patient, and we must stabilize the patient's general condition and oxygen saturation. And the best person should be doing the job. Do we have the experience to extubate when we are trying to extubate a patient? My first exposure to extubation was in 2003 when I went through the ASA guidelines and heard about the use of something like an airway exchange catheter at that time. And taking a cue from there, we did something which I'll talk to you a little later. But organized guidelines for tracheal extubation were published by DAS in 2012, which prompted a strategic stepwise approach to extubation and emphasized on post-extubation care as well. So as I said, we created our own indigenous airway exchange catheter. It used to be called a tube changer at that point of time. First a pedestrian one, and then a more sturdy one, which we have been using right up till now as well. And at the same time, around the same time, 2003, I went full scale into airway workshops and CMEs, initially as a part of MAMC and later on as a part of Airway Management Foundation. And we have kept ourselves busy and at the same time dealt with extubation with greatest respect. And we have a whole lot of wonderful instructors from all over the country which are party to it. along with the support from wonderful sets of patients that we undertake, and devices and gadgets and simulators and mannequins, which make it easier for us to transfer the knowledge, whatever little we have. And our last workshop was in late February, just before the pandemic hit the whole world. And it was in end of February last year. Coming to safe extubation of difficult airway, the first thing to make it safe will be to at least identify whether we are dealing with a difficult extubation or not. And for once we have done that, then only we can think of optimizing if there are some reversible factors which are making it difficult. And if we are able to optimize, if we are not able to optimize them by the end of the surgery, there is no point extubating the patient till we have optimized them. And if it is going to take a few hours, wait till that time. If it is going to take longer, or if it is surgical requirement, then tracheostomy is the answer. If, however, we can optimize the reversible factors by the end of the surgery, then we must answer the question whether it will be easier to re-intubate in case we need it or difficult. If it is going to be easy, then if the patient can tolerate awake extubation, we should go for awake extubation. But if the patient can't tolerate awake extubation, then we have to choose between supraglottic airway device extubation or remifentanil extubation. If the re-intubation is going to be difficult, then the way out is airway exchange catheter extubation. How do we identify difficult extubation? Well, the difficulty can be due to general risk factors as well as airway risk factors. And we should try to identify these at the time of free anesthetic checkup itself, or during the course of surgery if we feel that something is going on which is going to make the airway difficult, and near the end of the surgery, because things might happen like halo fixation right at the end of the surgery, which can make the airway difficult. So there are predictors which really stare at our face, and it is very easy to identify. However, it is not very simple to identify the subtle changes which can happen because of edema or bleeding, etc. And the best way is to always have a high index of suspicion. You keep looking at the surgical site again and again, and the supraglottic changes in the airway dimensions can be diagnosed with the help of a direct laryngoscope or a video laryngoscope. But for subglottic changes, two rather rough tests are available, which is the cuff leak test and the ultrasonography, wherein we look for the airway column around the endotracheal tube after cuff deflation. But for the lower airway factor, you have to depend upon fibroscopy or chest X-ray. You know, just a word about cuff leak test. What we mean by cuff leak is that the expired tidal volume or expiratory tidal volume with the cuff inflated minus the expiratory tidal volume with the cuff deflated. And if it is expressed as a percentage of expiratory tidal volume with the cuff inflated, then it is any value more than 10 to 25%, or for an adult more than 110 to 130 ml of leak is reassuring that the likelihood of difficult extubation are less. So once we have found that the airway is difficult and we have some optimizable factors which are there, try to optimize these reversible factors. And by that, I mean that not only those general and airway related factors, but also optimize the location and the type of or the kind of assistance that you need at the time of extubation. We all optimize in most of our extubations, even in normal patients, the oxygen stores, the patient position, and pharyngeal secretions. However, when we are suspecting airway edema to be there, then we must do something to manage it. And because we know that even IV hydrocortisone takes about 30 to 45 minutes to start acting, it is a good idea that we preempt and use these steroids well in advance of the time that the edema is likely to come up. Epinephrine nebulization is another wonderful way of doing it, as we did in this case of a large vocal polyp which was there, and we not only gave steroids to this patient right in the beginning of the surgery, but we also nebulized the part which was likely to have edema, that is the vocal cords, by using the supraglottic airway device exchange technique, wherein we put the supraglottic device alongside the endotracheal tube and then use this supraglottic device to direct the nebulization onto the vocal cords through this nebulizer, which has epinephrine in it, directly onto the site where the likelihood of edema is there. However, if you cannot optimize the reversible causes by the end of the surgery, there is no point in going for removal of the tube. We must wait for the optimization to be completed. If it is going to take a lot of time, or there are surgical reasons to do tracheostomy, go for tracheostomy. But if few hours only are needed to settle it out, then extubate this person in the ICU or HDU after you have optimized the reversible causes fully. On the other hand, if optimization is complete by the end of the surgery, then we must consider on-table extubation. But again, we have to ensure that in a difficult extubation scenario, whether reintubation will be easy or difficult. If it is going to be easy, then we choose any of these three choices. But if it is not going to be easy, then the only way out is to use an airway exchange catheter extubation. If the reintubation is easy and the patient can tolerate awake extubation, then these patients must go through the steps of awake intubation, which we do regularly in our routine practice. So I'll not go into the detail of that. The only thing I like to put on record is that you switch off the nitrous oxide and volatile agents even 5 or 10 minutes more in advance as compared to a normal airway situation. But you suction the pharyngeal secretions before you switch off the volatile agents. And once you have antagonized the neuromuscular block, you wait till the patient has clear-cut eye opening and the person is obeying commands. Only then, with the lung at near vital capacity, by applying positive pressure, will you remove the endotracheal tube. And after the endotracheal tube has been taken out, then it is a good idea to keep the airway clear, open, and not allow the secretions to go anywhere near the periglottic area. And for that, you can keep the patient's head tilted and to the side. That achieves both these objectives. However, if the patient has such conditions that make it difficult for him to tolerate awake extubation, that the patient cannot tolerate hemodynamic instability, or the surgical thing is at risk if the patient is extubated awake, then you try one of these two methods. And these two methods have very similar indications if you look at it. Because we don't have ramifentanil extubation technique, what we use in our setup is LMA exchange extubation, or the Bailey maneuver. And both these techniques are inappropriate alone if there is difficulty in reintubation, which I have already talked about. So where do we use LMA extubation or LMA exchange extubation? One of such indications that we use it regularly for is for post-thyroidectomy cases, especially where we are suspecting that there is likelihood of tracheomalacia or vocal cord paralysis is likely to be there. So in these cases, we see the vocal cords and we remove the tube under vision. Our scope has gone through the supraglottic airway device, as you can see here, and the tube has been taken out after suctioning the pharyngeal secretions. And once we have done that, we wait for the vocal cord action to start. Remember that the patient is still in deep vein of anesthesia, but we have reversed the neuromuscular blocking agent effect by giving reversal to this patient. But what we do is we also introduce this fibroscope all the way down to carina, and while drawing it back, patient is breathing spontaneously. We can also look for the tracheomalacia, whether the tracheal wall is collapsing against the other wall. And if reintubation is difficult, although the optimization is complete, the answer is to use an airway exchange catheter-assisted extubation. An airway exchange catheter is around 80 centimeter long, blunt-ended, hollow, semi-rigid, thermostable tubing, which has graduations on it, and it is radio opaque, and it also has a 15 millimeters connector supplied with it. So the first thing that we have to do is to ensure that when we introduce this airway exchange catheter into the endotracheal tube, it should not jut beyond the patient end of the endotracheal tube, because that way it can injure the walls of the trachea. And to ensure that, what we do is that we measure the distance of the length, the complete length of the endotracheal tube, and the connection, the length of the connectors which are there, and we add these to find out, say, about 30 and another 5 centimeters, 35 centimeters is the depth to which we should introduce the airway exchange catheter. Also, we should look at the centimeter mark of the endotracheal tube at the patient's lip or the nose, whichever the case may be, so that we know that when we are positioning or fixing the AEC, we should know that it is at the same depth to which the endotracheal tube had been introduced. Now, what we do is that we have, like here, we have noticed that the tube was at 19 centimeter, and we have sucked out and and suctioning has been done, and we are ready to extubate, and we have deflated the cuff of the endotracheal tube as well. Now, the measured length which we have marked on the airway exchange catheter, we introduce the airway exchange catheter to that marking that we have noted, and once we have reached there, we pull out the endotracheal tube. We pull out the endotracheal tube, but holding the airway exchange catheter so that it is not pushed inside while we are pulling the tube out. And we also look that the depth to which the endotracheal tube was there, the AEC is only at that level and not gone any further. We can see it again in this patient of flap repair, where we had put in an airway exchange catheter. And if you look at it, the vitals of the patients are maintained. We are about to extubate this patient sorry. So we do here is that, okay. So we introduce the required length into the endotracheal tube, and then we start pulling out the endotracheal tube. Please look at the way this is maintained nicely, right? And we ensure that the airway exchange catheter is not pushed inside while we are pulling out the tube. And the mark which we had put is there at the nasal opening. These airway exchange catheters are tolerated very well. This is 36 hours after we had put in an airway exchange catheter. And this is because the AEC takes only a very small part of the glottic chink as against the endotracheal tube, right? And there is a slight improvement in the airway exchange catheter extubation, which is called the staged extubation, wherein we do not put an airway exchange catheter, but rather put a extubation wire, which is a soft malleable tip wire, which is pretty long, and not the AEC. And whenever we have to intubate the patient, we slide this airway exchange reintubation catheter over this wire. And this wire is even better tolerated by the patient because it takes even a smaller part of the glottic chink as against the airway exchange catheter. Post-extubation care of difficult extubation is also important, and these patients should be transferred under close monitoring and oxygenation. And the orders and instructions for the HDU staff should be very clear and written instructions, and the monitoring should also be of high level. If reintubation ever is needed, you just have to disconnect, recheck that the airway exchange catheter is inside the trachea by connecting it to end-tidal CO2 connector, and thereafter you lubricate and the end of the airway exchange catheter and slide the tube over it all the way into the trachea. And while you are doing it, while it is going into the oral cavity, it is a good idea to use a laryngoscope or a video laryngoscope to facilitate the entry of the endotracheal tube. So to summarize, friends, extubation is a totally elective process. So take your time and execute it well. The goal of every extubation should be to ensure uninterrupted oxygen delivery to patient's lung and avoid airway stimulation. And as I told you earlier, for that, it's a good idea after extubation to keep the patient's head nicely extended and rotated to one side, which keeps the secretions away and keeps the airway open. But if you anticipate difficult extubation, either during PAC, during surgery, or near the end of the surgery, try to optimize if there is anything which is optimizable. If you are not able to optimize it, defer it till you can optimize or tracheostomize the patient. So when in doubt, keep the tube inside. When in doubt, leave it inside. You know, it is something different from what we used to be taught during intubation. So during intubation, when we did not have end-tidal and other things, we were told, when in doubt, take it out. But when it comes to extubation, when in doubt, leave it in. And choose extubation technique based on the ease of reintubation and the patient's ability to tolerate awake intubation. And learn various techniques through workshops and practice in normal airway cases as well. You know, that is the way you will, because you might not be using them day in, day out. So to remain in touch, it is a good idea to do that. Thank you very much for your kind attention. Thanks a lot.
Thank you so much for your talk, sir. You have very clearly demonstrated that you believe in seeing and believing, not only in operation theaters, but also in your presentation. Thank you so much for all the videos, sir. Now we'll move on to our third speaker, Dr. Rebecca Jacob. It is an honor for me to introduce ma'am here. She is my teacher and mentor. Ma'am is our ex-head of department anesthesia, Christian Medical College, Vellore, and she was with us for 41 years plus. The word pediatric anesthesia and ma'am goes hand in hand. To give her current, achievements, ma'am is currently member of Medical Advisory Board, Council and Smile Train, and enjoying with her grandchildren. Ma'am, over to you.
Good morning, everybody. Today I've been asked to speak on the tips and tricks of managing the pediatric airway. Now, infants are children up to 1 year of age and toddlers between 1 and 2 years. I will be concentrating on this age group rather than on the older child. Now, their size, weight, anatomy, and physiology vary greatly from the adult. Failure to account for this can easily lead to complications like loss of airway and thus oxygenation. As the child grows, you have to consider factors such as loose teeth and enlarged lymphoid tissue. Now, why is it important to manage the airway efficiently? It's because these little babies have a high metabolic rate and a high oxygen consumption. They have very little reserve capacity and a large dead space, which gives rise to hypoxia and carbon dioxide retention. Thus, an infant cannot hold his breath or remain unventilated as long as an adult can. Why am I worried? Because the hypoxia can lead to bradycardia, a decreased cardiac output, which means less oxygen delivery to the tissues, hypoxia and hypercarbia, acidosis and myocardial depression, and cardiac arrest. So I must ensure good ventilation to avoid hypoxia. I minimize apneic periods. I pre-oxygenate all patients if possible. But can I still run into problems? Of course, because their upper airway is prone to obstruction. They have a large occiput, which increases neck flexion and kinks the airway, a larynx, which is anterior with a large floppy epiglottis, and a large tongue relative to the size of the oropharynx. Look at this baby. If I have him lying supine or a pillow under the head, he kinks his airway because his chin is touching his chest. If, on the other hand, I extend his head, then I open up the airway. In the adult, we know that to align the oral, pharyngeal, and laryngeal axes, I have to put a pillow under the adult's head and extend his neck on his thorax. In a baby, it is different. I have to use a roll under the shoulder to get these axes in a straight line. And that is what I mean, a roll under the shoulder with a neck extension. Where else can I expect problems? In the oral cavity, at the temporomandibular joint, the maxilla, the mandible, and in the cervical spine. Now, to assess the pediatric airway, we use the Kaamcon scale, which was first described by Lane. In the older child, we could use the Malampati scale. Now, the Kaamcon scale gets us to look at the chin, C for chin, O for the opening of the mouth, P for previous intubation or obstructive sleep apnea, U for uvula, and R for the range of extension of the neck. So each of these factors is given a number. The more difficult it is a higher number. This helps us decide whether the intubation is going to be easy or going to be difficult. 16 would be a dangerous airway. What other problems can you expect during induction? It will be very difficult to separate the baby from the parents. If there is any probability of a difficult airway or hemodynamic instability, do not have the parents present during induction. You know that a crying child has increased secretions. Check your suction before starting. A laryngospasm can occur at any time. Have expert help, drugs ready, your crash cart and difficult airway cart available. If there's a difficult IV access, which you have noted in a plump child or a child who's been poked many times before, ask for expert help early because someone needs to look after the airway and someone else has to start the IV access. If you are planning an IV induction, check the IV patency before induction to prevent unexpected extravasation before you give any drugs. Calculate the drug dosages carefully for each patient and stick to your calculations. If you're going for an inhalation induction, decide on the agent early. Now these two babies will have a difficult mask ventilation. You have to keep your equipment ready and get help early. What equipment? If I have all these masks, I still won't be able to induce this baby. I must think earlier and have an adult mask available for this baby. If you are inexperienced or unsure, do not give a muscle relaxant until you are sure that you can ventilate adequately. The position for intubation plays a role under the shoulders for the mask holding and for intubation. A head ring helps to stabilize the head, and you won't need people to come and hold the head for you. In older children, use a folded sheet under the head. Have all your equipment available. Make sure that the suction is working and ask for additional help. Now, the technique of direct laryngoscopy depends on being able to see the glottis properly, because light travels in straight lines from the eye to the glottis. Now, this is important because the control in a baby is the problem with the tongue. A big tongue and a small chin, especially in a child who has a syndrome like the Pierre-Robin syndrome, would mean that it would be difficult to see the glottis. As the larynx is anterior, a little anterior pressure may be required to visualize the glottis. A cricoid pressure must be gentle and light, because otherwise you squash the trachea and you will not be able to intubate. It is helpful to angulate the tube to the anteriorly placed trachea, and you could make a J-shaped curve to the tip of the tube, which can be provided by a stillet. Now, if the baby has a cleft, the tendency for your scope is to slip into the cleft. So use a gauze roll or a blade with a higher flange in a child with a cleft. Try the paraglossal approach if you're familiar with that. If the child has a prominent premaxilla, be aware that you crack that premaxilla and there's an end artery there, and you will lose tissue in the long run. Now, there is difficulty even after you view the cords. You may be able to see the cords, but the space in the mouth is limited. So consider a two-person intubation as is demonstrated here. One person does the scopy and helps with the positioning of the trachea, and the other person will intubate. Have a rough idea of the depth you need to insert the tube before you intubate. Beware of inserting the blade too deep. If the tube hitches on the arytenoids, gently withdraw and rotate to right or left and try insertion again. Choose a laryngoscopy blade you are familiar with, one that helps provide space and light to view the glottis while moving the tongue out of the way. If there is difficulty in lifting and controlling the epiglottis with the blade anterior to the epiglottis, just put the blade posteriorly and lift the epiglottis directly with the blade. The only problem would come if your patient is under light, spontaneous ventilation, then a laryngospasm could occur. But under muscle relaxant and deep anesthesia, lifting the epiglottis will not give you any trouble. If bradycardia occurs, ventilate adequately before reattempting intubation. Consider pre-treatment with atropine. If you're using a neurovascular blockade or sedation, consider a nasogastric or orogastric tube if excessive gastric distension was created by bag mask ventilation. Now, the complications are dislodgement, obstruction, tension pneumothorax, equipment failure. You must keep reassessing frequently to make sure the tube is in the right place. Remember that tubes migrate with head movement. Secure the tube well. Immobilize the head in neutral position and never let go of the tube until it is secured. A little movement is required to inadvertently extubate the pediatric patient. And while you're holding on tight, don't forget to ventilate. Now consider this baby. He's all ready for a cleft palate repair. A tube that has been used is an RAE oral tube. It is a tube which has been designed for the West. So it's a pre-configured tube, and the length of the tube from the tip to where it sits on the gum is a standard length. Now, you'll find that this tube was a bit too long for the child, though the size seems all right for his trachea. So the anesthetist has put a rolled up gauze there and has fixed it properly. Now, his head, though it's in a head ring, the surgeon tends to keep extending the head. And what would happen? The tube could slip out. Or if the surgeon has got a gag in and he's removing the gag or readjusting the gag, the tube can come out. Do you think you can re-intubate the patient in this position? I don't think so. I don't think you'll be able to see the glottis in this position. So always have a pillow ready to put it again and under the child's head and bring the child to the position he was in when you intubated. A roll under the shoulder should also be kept ready and available. If you're planning to use a specialized tube like an RAE or a flexometallic tube, ensure that you have a regular endotracheal tube with a stillet available in case intubation proves difficult. If you think there's going to be airway obstruction, ask the surgeon to put in a tongue stitch or place a nasopharyngeal airway. Always know your equipment and drugs, your basic equipment as well as your advanced equipment. But do not use equipment you're unfamiliar with, especially on a difficult airway. Practice on a regular patient. Now, you may have another problem when you use a video scope. Now, this is just a true scope I've taken as an example. Usually, the focal length is from the tip of the blade to a mark on the blade. Now, this mark should be near the teeth or the gums, while the tip sits at the glottis, and that is a standard length for a particular age. But if you have this baby come in, you know that there is no gum there, and you will not be able to place this line at the gum. So choose a smaller scope. Always think laterally, think ahead. LMAs tend to malposition in infants and toddlers due to a small glottis and large mouth and tongue because they tend to rotate. Therefore, I tend to use an eye gel which has a broader stem, or I intubate the babies. Now, to summarize, prepare the patient, ensure the fasting guidelines, secure IV awake in anticipated difficult intubation. It is your lifeline. If multiple attempts at intubation have been done, use steroids. If you're planning a nasal intubation, use nasal vasoconstrictors early. Anti-sialagogues are required in certain situations, and topical lignocaine is useful. Always have an assistant. Explain to the assistant the positioning, how to assist in a procedure, and monitor vital signs. It is important, I keep repeating, always have an assistant, have expert help if you need, call them early. Be familiar with algorithms, help formulate a reasonable plan. And regardless of what technique you use, you must have an alternate plan. Always be ready, because in the event of failure, you must know what you're going to do. So don't fail to plan for failure. Have a difficult airway cart available. Have rescue devices available, both supraglottic and infraglottic. For the infraglottic, have your surgeons on your side. Always ensure good ventilation in between your attempts at intubation so as to avoid hypoxia. Extubation can be more difficult than intubation, and be ready for that.
Though this is a 2011 audit from the UK, it summarizes why major complications of airway management occur. This includes poor airway assessment, poor planning, failure to plan for failure, failure to use awake fiber optic intubation or even videoscopy, repeated multiple attempts, which is failure to stop, failure to change approach, and all this can deteriorate to cannot intubate, cannot ventilate scenario. To this list, I would like to add a failure to call for help early is also an important factor. Thank you.
Thank you so much, ma'am. Now I would request all the three speakers, Dr. Ramkumar, Dr. Rakesh, and Dr. Rebecca, to come online with your videos. There are a couple of questions. I'll take up the first question. First question is for Dr. Ramkumar. And question says, why 95% saturation is set as a trigger for action? And the second part of the question is saturation SpO2 a good marker of oxygenation? For you, sir.
Right. Am I heard, Ekta?
Yes.
Am I heard?
Yes, sir.
Okay. Right. Yeah. So 95% saturation is taken as the cutoff because we know that 95% saturation is still at the flat upper portion of the oxygen dissociation curve. Obviously, 100% or 99% is taken as being really good. But when you start seeing a drop in saturation and it reaches 95, it indicates that there is some kind of a problem with the oxygenation. And if you were to wait further, it's possible that it might drop to 92%. And 92% is the point at which rapid desaturation starts. 92% on the oxygen dissociation curve also corresponds to 60 millimeters of mercury, which is the cutoff everyone takes as the point below which anaerobic metabolism happens. So there are two reasons for 95% being taken as the trigger. One, it gives us an early warning that there is a process that is set in, which if unattended on time may lead to a very rapid desaturation. And two, we don't really want our patients going into anaerobic metabolism. And if you can help it, you can take recourse to corrective measures before that. I don't know. Questions asked. I think by the person who asked the question is happy with the answer. I'm okay. You can go on to the next question.
Yeah. So I have one question for Dr. Ramkumar.
Yes, Raj. Yeah.
Yeah. So there was an interesting article by Yentis in 2002 about the utility of preoperative predictive tests for difficult intubation. And what he said proved statistically was most of the tests had a poor positive predictive value. So as a teacher with so many years of experience, what would be the advice to the trainees about how which test or a combination of tests should be the routine for preoperative airway assessment?
Yeah. Well, thanks, Raj, for bringing up that point. Honestly, I don't have an answer to that because the very fact that we are still searching for the right bullet or the right test to identify a problem means that all the tests available alone or in combination do not rightly predict a difficult intubation. There are times when all the pointers of an airway assessment look normal, and then something in your mind, because of experience, 25, 30, 40 years of experience in your career tells you that there's something wrong with this patient. I'm going to have a problem. That's intuition. Now, intuition can never be quantitated or qualitated, right? So I think there is no answer to that. I'm sorry, I don't have a definite answer. It's a combination, and and over and above that, I think it's also your past experience that comes in. You might have dealt with this kind of a combination before, and you might have certain tricks up your sleeve to overcome that. So I think a number of tests give you an idea. Intuition plays an important role, and then overall experience comes in. So I have no answer, Raj. No answer is which test to go for. Yeah.
Thank you, sir. I have a question for Dr. Rebecca. The question says, can we use curved blades for neonate, or is it mandatory to use only straight blade and the question is by Dr. Muthukumar. So ma'am, it's between McIntosh and Miller. Which one is your preference and why?
There is no hard and fast rule as to which blade to use. Use what you are most comfortable with. A straight blade would be fine in some cases, and especially if you're using the paraglottic approach, the straight blade is useful. But if you're familiar with a curved blade, remember curved blade gives you more space in the mouth. So if you're happy with that, go ahead and use it. If you need to pick up the epiglottis, do so. Once you're under muscle relaxant, do so. But there is no hard and fast rule. Stick to what you're familiar with and what you're comfortable with. Can I just answer another question that has come up, which keeps coming up all the time, about use of cuffed tubes in children?
Sure, ma'am.
Please remember that not all cuffed tubes are designed properly. Most of the pediatric cuffed tubes, the portion of the tube beyond the cuff is quite long, and there can be endobronchial intubation, and the pressure, the cuff itself is a high pressure cuff. I use uncuffed tubes most of the time, but if I'm going to do a laparoscopy, a thoracoscopy, or send the child to the ICU, I would use a low pressure, high volume cuff with a small part of the tube beyond it. Always monitor the pressures in the cuff and keep doing continuous monitoring. Thank you.
The next question is to Dr. Rakesh. How do you decide on extubation in a neuro patient where you find it difficult to assess the GCS after anesthesia?
As I told you, whenever we are not sure about extubation timing and you are not really sure about whether you have been able to optimize the optimizable factors, it is best to defer it till we can, because we all know that the intubation cutoffs are about 7 to 8 GCS. So if you are not sure about the GCS, we'll wait till the GCS actually reaches that value wherein it is safe to extubate. So my answer will be to defer extubation in those patients where I can't assess the GCS and neurosurgical patients, because I think that was the question. So my very simple answer would be that whenever I feel it will be safe for the patient and he or she will be able to nicely hold his or her airway and also prevent secretions from going in. So till I am sure that the patient has reached the GCS, cutoff GCS, I'll keep the patient intubated.
Thank you, sir. I have one more question for you. Like both DAS and already difficult airway talk about remifentanil extubation, and you have mentioned the Bailey's maneuver as an alternative. But is there a role for dexmedetomidine as an alternative to remifentanil for extubation of high-risk patient?
Thanks, Raj, for that question. Personally, I don't have personal experience with Dexmed to be used in place of remifentanil. Seems to be promising. Maybe you have tried it. I haven't. So, but much before remifentanil thing was even written about, we had started using the Bailey, and we found that was very effective and as good as the remifentanil is claimed to be. So keeping that in mind, we started doing this, and we could take out the tube with the patient in a deep plane of anesthesia, so could prevent the hemodynamic part of it. And at the same time, we had the added benefit of peeping inside the airway and look at the periglottic area, the glottis, and even for tracheomalacia. In fact, a lot of people say that they have never seen tracheomalacia. And it is only in the last 3 years of my 42 years that I saw 2 cases, in which one of them we caught it later on. But the second one we were able to find out very beautifully. I actually have a video of that also, wherein the right wall was collapsing over the left wall. But for that, the patient has to be breathing spontaneously. You can't diagnose tracheomalacia with the patient still being ventilated. So we got added benefit. But Dexmed, yes, maybe it has some role. But if you have, please do share right away.
I have a question for Dr. Rebecca. Ma'am, a question comes up is paraglossal approach. How do you do it? At the same time, there's another talking about rapid sequence intubation in children. What tube?
First, the paraglossal approach is like you would use a rigid bronchoscope. You go laterally and you go diagonally. So from the outer aspect of the mouth, you go towards the glottis. So that you avoid this, we use in clefts. And so we make sure that we are going to avoid the cleft and go across. That is the way we do a paraglossal approach. Rapid sequence intubation in pediatrics, we don't do rapid sequence like we would do in adults. We do not advise the cricoid pressure because in these little babies, the cricoid is very I would say very soft, and the trachea would get squashed or deviated. So you pre-oxygenate, you would use a regular endotracheal tube, and I would use a stillet in that regular endotracheal tube because in this case, I don't want to fail. I don't want to have to ventilate. Does that answer the question?
Yeah, there is one more question. Is there a role of apneic oxygenation in difficult airway? Any of you can take that question.
I didn't get the question. Your mask.
Sorry. Is there a role of apneic oxygenation in difficult airways?
Can I take that, Raj? Okay, Raj. Okay, Rakesh, please go ahead. Rakesh, started.
I think it has role in all kinds of airway management. For us, it has become a regulation that all my postgraduates have a binasal cannula launched, and over that they do the pre-oxygenation. And as soon as they pick off their mask, the oxygen at 10 liters, which Dr. Ram nicely elaborated on, is on. Whatever the highest amount of auxiliary flow is available, 10 or 15. Some machines have 10, some have 15. That is my way of looking at it. And we call it para-oxygenation. Or I think Dr. Ramkumar used a continuous oxygenation.
So however way you describe, even a simple thing like nasal cannula and 10 or 15 liters is good enough. And as long as you maintain a patent upper airway, it can do wonders.
Absolutely.
I think in the interest of time, we will...
Raj, can I just say one last comment?
Yeah, sure.
Most modern anesthesia workstations have an auxiliary oxygen flow meter. And this can be used for that purpose. You can use your main flow meters for the breathing circuit that you're going to use. And the auxiliary oxygen supply can be used for the additional oxygenation through nasal prongs.
So there are 4 to 5 more questions. I think we have to answer them online. Maybe you can just
I have
answer
answered
them.
one of them, Ekta, online.
Yeah.
I've already answered one online.
Yeah.
The chat can be saved. My answer is there. And in interest of time, I will stop talking. Yeah.
Thank you very much.
Thank you so much, sir.
Thank you, Dr. Rebecca, Ramkumar. Thank you.
Thanks.
Nice seeing you.
Thank you.
Thanks to everyone again. Okay.
Thank you, sir. Thank you, ma'am.
Yeah.
Over to you, Elizabeth.
Thank you very much, Raj, Ekta, Ramkumar sir, Dr. Rakesh and Rebecca ma'am for the very interesting sessions and the active discussions. We shall now move on to the next session. The chairpersons for this session are Dr. Jacob John, who is a graduate from Trivandrum Medical College and a postgraduate from Kottayam. He has done his fellowship from the Royal College of Anesthesiologists at Dublin. He's a senior consultant and group coordinator in anesthesiology at KIMS Healthcare Trivandrum. He's a very cool and collected anesthetist and has always been a very beloved senior to me. His areas of interest are difficult airway and ultrasound guided nerve blocks. He's a speaker at various national and international conferences. Dr. Jaya Susan Jacob is a graduate from Trivandrum Medical College and did her post-graduation from CMC Vellore, where she was the best outgoing postgraduate. She won the Valerie Major Gold Medal. She's a senior consultant anesthesiologist and very much at VPS Lakeshore Global Life Care, Kochi. She's a very respected and sought after anesthesiologist by her colleagues as well as the surgeons in Lakeshore Hospital. Over to you, Jaya and Jacob.
Thank you. Thank you, Elizabeth, for the introduction. The first talk for this session is high flow nasal oxygen in COVID, a global perspective. The talk is given by Dr. Ragesh Garg, who is an additional professor at All India Institute of Medical Sciences, New Delhi. He is an associate editor of the Journal of Anesthesiology and Clinical Pharmacology and the Indian Journal of Anesthesia. He has over 260 publications to his credit and is a prolific speaker at various national and international conferences. Over to you, Dr. Rakesh.
Namaskar. Today we'll be talking about a very important topic of high flow nasal oxygen in COVID-19. I bring greetings from my institute, All India Institute of Medical Sciences, wherein I work at Institute Rotary Cancer Hospital of this prestigious institute. Now, COVID-19 has brought many insights into the management of this pandemic of COVID-19. Though the conventional oxygen therapy was primarily restricted to the oxygen delivery devices, the non-invasive ventilation, the invasive ventilation with tracheal intubation, but the understanding of COVID-19 has given many new technology, tools, techniques, and thought as how we can bring the outcome in a positive way in patients who are suffering from COVID-19 and require oxygen therapy. When we talk of COVID-19, the clinical symptomatology is not just restricted to the lungs, it is to the other organs also, but primarily concerns would be the involvement of the respiratory system, the lung pathology leading to hypoxemia and requiring the oxygen supplementation and other respiratory support system. But the deterioration in the lung functions is not as similar to the other respiratory dysfunction which we have normally thought of conventionally. In COVID-19, it is a thrombotic phenomena, which is leading to the ventilation perfusion mismatch leading to respiratory dysfunction, in addition to the infection leading to consolidation of the lungs. And hence the management is not similar as the conventional oxygen therapy. And that is why we need to look for something new technology which can deliver oxygen in patients with having some respiratory dysfunction due to COVID-19. The conventional oxygen therapy was starting from oxygen therapy using various devices, then shifting them to NIV if not controlled, and then to mechanical ventilation requiring for those patients who are not maintaining oxygenation on NIV. But this use of newer tool of high flow nasal oxygen has found its role in COVID-19 because of its beneficial effect. And if you see the summary of recommendation for managing these patients who are hypoxic, the HFNC is one of the important tools for maintaining oxygenation prior to the mechanical ventilatory support. And the time of initiation for oxygen therapy would depend upon the stage of infection. Once the viremia is on the peak and then settling down, the inflammatory response is starting. This is the time when the pulmonary phase is involving and the patient have some respiratory dysfunction wherein you need to start the oxygen therapy. And the timing of this oxygen therapy is important because once the hypoxic episode starts, it further exaggerates the inflammatory response and the outcome. And that's why the oxygen therapy should be started timely so that the hypoxic injury is not happening. Now, this is the conventional use of various available conventional oxygen delivery devices, depending upon how much oxygen and FI is required by the patient for maintaining the target oxygenation. But in case if these are not being managed with these conventional devices, the tracheal intubation or an NIV is one of the conventional options. But in COVID, it is always a big issue of various concerns, including the aerosol generation and the infection to healthcare worker. And that is why the HFNC is one of the bridge that has been used for these patients. The advantages are many for using this technique because this heated humidification of inhaled gases, it wash out the upper airways, it has high nasal inspiratory flow. It also has positive airway pressures and it decreases the entrainment of ambient air, leading to increase of FiO2. And all those benefits leads to the improved clinical outcomes, which has been very well seen in COVID-19 patients. And to start with the HFNC, when we take on the use of HFNC for COVID-19, there was some dilemma. Many of the effects has come up with the evidence, and they are being used in present management scenario. If you see the initial era of somewhere in February, March 2020, there was a concern that whether this needs to be used or not, because they were not very sure. There were concerns of aerosolization. And subsequently, people have other views also, and they were just looking for whether high flow nasal oxygen is a safe, efficient treatment for COVID patients or not in an ICU. This means they were thinking of, but not for patients who are critically ill, where mechanical ventilation was a concern. And the reasons were that it's an aerosol formation, the equipment was not available, intensivists were not using it. It was primarily the anesthesiologists which were using them, and the severe respiratory stress, it was one of the indications for mechanical ventilation. But subsequent understanding and published literature, the availability of good quality PPE, negative pressure rooms, and the invasive ventilation had a poorer outcome. The pathophysiology of COVID-19 on respiratory dysfunctions was elucidated, and that is why the HFNO has come into picture, and it has better acceptability now. We have good quality PPE. The understanding has become much better. We have understand that how the aerosol spreads and it can be taken care of. And it has also been found that the high flow nasal cannula for COVID-19 patients, there is low risk of bioaerosol dispersion. So such type of studies which has come up has given a reassurance that even this therapy will not increase the chances of a healthcare worker who are well equipped with the PPE. Now they have just summarized that the bioaerosol dispersion via high flow nasal cannula shows a similar risk to standard oxygen mask, and high flow nasal mask with a surgical mask on patient face might be benefiting these patients, and that's why it has come into picture. Now this is another interesting study which reassures that this is one of the important aspects. This is a retrospective observational study, and they have used HFNC to look for the response. They have found that the patients with certain parameters have shown a good response of HFNC, and they have identified few parameters, which was primarily the ROX index, which they elucidated as an indicator for the success or the failure of HFNC. But they found that the high flow therapy is useful in patients with COVID-19, and it has decreased the mortality, and the ROX index below 4.94 predicts the need for intubation. And that's how they have come up with the ROX ratio, which has been found to be a good indicator for looking for the success or the failure of HFNC vis-a-vis the mechanical ventilation. And that is why it has come into the algorithm in subsequent communications also, wherein when a patient comes with respiratory dysfunction, HFNC trial can be given, look for the response. If patient maintains saturation of HFNC, this can be continued. And other patients who are not responding to them, they may require other type of respiratory support. And they also reported that the outcome parameters in patients who were requiring HFNC, there were a significant improvement in multiple respiratory parameters, those who were requiring HFNC in patients suffering from COVID-19. And hence it was very reassuring from this this study that HFNC could be one of the important tools for patients suffering from HFNC, not only for mild, but also for moderate and even severe category. But the limitation why some of the patients had a failure in the earlier studies was that the management of COVID, we have to use other modalities like conscious proning or pharmacological agents which improve the lung functions, decrease the chances of infection, antiviral therapy. So these agents were also required. So the overall perception was it does not be oxygen therapy, but a multimodal approach. So if you want to improve the oxygenation, it is just not the HFNC or oxygen therapy or mechanical ventilation, but we have to use multimodal pharmacological and non-pharmacological modalities. You optimize the patient using vasopressors, antibiotic fluids, have a good chest physiotherapy, and simultaneously think of prone positioning, which has been found very useful. So HFNC with proning has an improvement in the outcome, and it has been very well proven in this study that those patients who are prone, their saturation improvement was very seen. The PO2 improved very nicely. PSO2 also came down. So this means it's a combination that can improve the patients further on. This is further proved in another study where they found that prone positioning combined with high flow or conventional oxygen therapy in severe COVID-19 patients, and there was a significant improvement. Now, even then, the additional things like covering it with surgical mask on the top of high flow nasal cannula further improves the oxygenation in a critical ill. And this is another important issue because it will obviously decrease the aerosol and hence the decrease of infection, which is well proven in this case, wherein when the HFNC with surgical mask, there was further improvement in the PO2, the saturation improved, the PA-FA ratio also improved much better, and the POC2 was more or less similar but acceptable. So this is how they have found that even when they continued HFNC after test with removal of surgical mask, there was in deterioration. So this confirmed that covering with surgical mask on the top of high flow nasal cannula improves oxygenation. Wearing of medical mask over high flow improves. This was shown in another study also, and which is well confirmed. Now, with regards to the dispersion of the aerosol, this is very well confirmed from this study that if you use a HFNC and cover the medical mask, the chances of aerosol formation is much more reduced, and hence the risk of infection to healthcare workers is much lesser. So we can go ahead and use HFNO for these patients. This is a very important article which has surprised so many things. The advantages of HFNC is more reliable oxygen therapy in COVID-19. It is very comfortable and well tolerated. When people believe that 60 liters may not be comfortable for patients, but this study has proven it, that it is comfortable to patients. It can have various physiological changes. It reduces the dead space, increase the end expiratory lung volumes, and this beneficial physiological effect of HFNC has been found to recruit the lung. The positive pressures delivered by the HFNC makes the lung more ventilated, and the efficiency of breathing and improving the end expiratory lung volume forms the basis of the beneficial effect of HFNC. It improves the compliance of the lung, the work of breathing in patients with respiratory failure, and hence the outcome of patients would increase with the clinical use of HFNC in hypoxic respiratory failure, with improve in the overall outcome with decreased mortality and morbidity. Concerns with HFNC related to the aerosolization or the tracheal intubation and mechanical ventilation need or excessive respiratory drive leading to more self-sustained lung injury in the patient is not of a concern now, and it has been proven. The high flow nasal cannula for acute hypoxic respiratory failure in patients with COVID-19, the systematic reviews has been done, and it has been well proven even in a last review of 12 studies, including around 2,000 patients, and they have confirmed that the HFNC has a better outcome profile as compared to patients who are not receiving HFNC. So that is, HFNC becomes one of the important tools in management of patients with COVID-19 by reducing the need for invasive ventilations as compared to the conventional oxygen therapy. The high flow nasal oxygen therapy, how to initiate, it has various components, a flow meter, cannula, heated equipment for delivery of the humidified oxygen. The healthcare worker should be wearing a good amount of appropriate PPE, and the patient face can be covered with a mask over it. The settings can be from up to 60 liters per minute with FI up to 100%, so it needs to be titrated as per the target oxygen saturation, which may be around, say, 90 to 92%, depending upon whether patient has previously underlying COPD or non-COPD. And the target should not be 99-100%. A 94-95% is acceptable for these patients. You need to monitor these patients for baseline status, ensure the patient is always on continuous pulse oximetry, and try to titrate the oxygen flow and FiO2 accordingly. Also take care of the patients who are at high risk, like older age and comorbidities, because in these the patients may be having more disease severity. So always think of optimization of the other parts also. And when to change the strategy, HFNC, it requires interdisciplinary monitoring. If the work of breathing is increasing, saturation is not being maintained despite the full HFNC, this is a time you should think of other modalities. And for this reason, various professional bodies had recommended the use of high flow nasal oxygen therapy for patients with COVID-19. So to summarize, COVID-19 is a novel disease. We know little about the respiratory physiology. We are learning more, but the evidence is being generated for oxygen therapy in COVID-19 patients. And the HFNC has been found to be a very important tool, but we need to keep ourselves updated so that we can use it more effectively so as to have good patients outcome. So this is what we have learned about the HFNC now. And together we will be able to manage the patient saturation much better and win over the COVID-19. Thank you so much.
Thank you, sir. I am privileged to introduce to you an airway expert of national and international repute, Professor Sheila Nayanan Maitra, Senior Faculty in the Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital, Mumbai. She has many feathers in her cap. She is the president of the AIDAA, one of the chief architects of the AIDAA guidelines. She is also Vice Chancellor of the Indian College of Critical Care Medicine. She's been appointed the chair of Intensive and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiology. And more importantly, she is one among the 14 international experts working on ASA difficult airway guidelines and the PUMA guidelines, which is the topic of discussion today. She's on the editorial board of the many journals, including Anesthesia, Journal of Critical Care, Trends in Anesthesia and Critical Care Medicine, and Airway. Over to you, Professor Sheila.
Hello, friends. Greetings from Tata Memorial Hospital and the All India Difficult Airway Association. At the outset, I'd like to thank the organizing committee of Kaamcon 2021, especially Dr. Elizabeth Joseph, Dr. Sam Phillip, and Dr. Sajayan for inviting me. It's always a pleasure and a great honor to speak at Kaamcon. I will be speaking about Universal Airway Management Guideline, and that is the PUMA guideline. And what does PUMA stand for? It's the project for the universal management of the airways. I'm sure most of you have heard of it at several meetings. Unfortunately, this guideline was to be published in September 2020, but the publication has been delayed to February 2021. So what I'm going to do over the next 20 minutes is to give you an overview of what the PUMA Universal Airway Management Guideline is all about. So in this talk, I'm going to speak about the concept of PUMA, what is the rationale, the logistics, the methods, the format that we use, a little about the content, and also some details of the publication of the PUMA guidelines. Now, this is the PUMA team, and we are a group of 14 members. And this is Dr. Karen Hagberg. She's from the United States, and she is the chair of the guideline committee. And we have Dr. Nicholas Crimes, who is from Australia, and he is the project lead of the PUMA guidelines. And as you can see, we are many familiar faces, and many of you might know these people. They are all experts and authorities in the field of airway management, and most of them have been involved with guideline development in airway management. So it's a working group of 14 members, and in this 14-member group, we have 11 anesthesiologists, 3 of whom are intensivists, and we also have 3 emergency physicians. Now, you may have all seen this review that was recently published in Anesthesia, Difficult Airway Management Algorithms, a directed review. And this is a very interesting review that was published because this looked at all the published airway management guidelines over time. And what you see, the bars in blue are the new airway management guidelines that come over time. And the orange bars are the cumulative number of guidelines over time. And these are the different specialities in subspecialties for which the airway management guidelines have been developed. And as you can see, a majority of them have been adult airway management guidelines. So interestingly, we have 38 published airway management algorithms in the last 20 years. And that's really a big number. Now, when you have a victim of cardiac arrest and you're giving CPR, by and large, we follow the same sequence and the same steps. Of course, there are regional variations and there are, area-specific guidelines, but by and large, we do the same things. We give CPR in the same way. We just give chest compression in the same way. The drugs we use are the same. And this is all possible because organizations like the ILCO work together with different societies that form cardiac arrest guidelines. We also have the Indian guidelines for CPR, and they liaise with them and make sure that there is a uniform kind of way in which we deal with cardiac arrest. Now, if you take the same analogy of cardiac arrest to airway management, that is exactly what Puma is trying to do. If you look at the airway management algorithm, now look at the different algorithms across the globe. We have so many algorithms, and we don't have a single unifying document that is accepted and endorsed universally across the globe, and that applies to all contexts. Different guidelines followed by different society. And this is what Puma is trying to do. It's trying to use the application of the principles of cardiac arrest, training and clinical practice into airway management. So like we have a universal algorithm for the management of cardiac arrest, we are looking at a universal algorithm for airway management principles for the management of difficult airway across different boundaries. So is it that there are 100 algorithms and Puma project is trying to create the 101st algorithm? No, this is not the case. In fact, it is not a difficult airway guideline at all. So what it is a unifying document. So what we've done is that we've taken all the guidelines on airway management from across the globe. We have looked at the commonalities in these guidelines. We've looked at the important, useful points in these guidelines, and we've tried to put them together and make a unifying document. So it's universal. It's not another difficult airway guidelines. And it talks about difficult airway. We're dealing with difficult airway principle. And most importantly, it's independent of context. So it doesn't matter where you are in the world, who the provider is, what is the location, what is the patient that you're dealing with, what is the indication for airway management, what is the urgency of the situation, or even the complexity of airway management, or even the type of airway. It's going to be something that will, a universal principle that will apply to all these contexts. Now, what is the rationale for having this kind of guideline? Now, I'll just give you an example. And this is myself in the intensive care unit. I come from a background of anesthesia. So I do airway management in the operating room, but 80% of the time I do airway management in the ICU. So I'm in a unique position to compare airway management in the two areas. And I can tell you, unlike when I'm in the operating room with a very stable patient who's come fasted and has been optimized for surgery, that airway management is completely different from this kind of situation when I'm in the intensive care unit. Look at the clutter around the ICU bed. Even getting to the head end is quite a struggle. There's my ultrasound machine, my ventilator, my crash cart. This is a patient of septic shock. This patient not only needs airway support, but also needs hemodynamic support. I have very less help. There's just a male nurse there to help me because my resident is resuscitating another patient. And this is a patient who I have to, work with. If this is a trainee of mine, there are various levels of skills. Not all are anesthesiologists. So a very complex environment while securing the airway in the intensive care unit. Various levels of airway management skills. And most importantly, not only anatomical difficulty airway, but also physiologically difficult airway is what are the concerns in the ICU. Now, if I had to apply the same airway management guidelines that I use in the operating room to this patient, it doesn't take into account the various physiological considerations. We talk mostly about anatomical airway. We talk about waking up the patient. Now, waking up the patient is okay in the operating room. You can postpone the case. You can do it another day when you're better prepared. This is not an option in the intensive care unit. You have to give this patient a definitive airway. So the rationale for having this kind of a unifying document with common principles is so that irrespective of what the context is and where you're working and what the type of patients is, you are using uniform principles for airway management. So just to give you an example, if I had an adult patient who's pregnant and also a trauma victim and critically ill, then which algorithm am I going to use? Because we have different guidelines for each of these settings. So it's important to have a unifying document. And if you see, most of the guidelines that we have are all developed by anesthesiologists. And they're developed for anesthesiologists working in different operating room settings with different types of patients. But you know today that it's not only anesthesiologists, there are intensivists, emergency physicians, paramedics, airway assistants, all of them deal with airway management. And many of these physicians don't have their own airway management guidelines, and few of them do have some guidelines, but majority are from the anesthesiologist. So just imagine a situation where if all these clinicians were say in an emergency department came together to help to secure the airway of a patient who had a difficult airway, then which algorithm would you use, right? So it's important to have a unifying document or principles that would apply and help all these individuals from different specialties. Another very important thing is most of the algorithms that we have are very intubation centric. They start with, attempt an intubation and cannot intubate. But we know today that it's not intubation which is important, but it's being able to ventilate the patient and oxygenate the patient that is even more important. And we know this can be done by different devices like a face mask, a supraglottic airway device, and an endotracheal tube. And we know today that all anesthetics, we don't put a tube. Some start with a supraglottic airway device. So what if you fail with a supraglottic airway device? And you've not put in a tube at all. So then what do? Most of these algorithms start with a failed intubation. And this is why you need a universal algorithm which deals with whatever kind of technique that you're using for anesthesia. When it fails, what are the common principles that you can use across the globe for different settings? And also the transition into moving into doing airway rescue is extremely important. And this is what Puma addresses in detail. Now, you all heard about the Ellen Bromley case, and this is a case that has been discussed a lot. And this was a very unfortunate case of a female in whom they tried to secure the airway. They were not able to intubate this patient. The supraglottic airway device that they put in as a rescue did not work. And there was a lot of cognitive overload. There's a lot of fixation errors. A lot of things went wrong, and they didn't transition into doing a cricothyrotomy in this crisis situation. And, they were obsessed with just trying to secure the airway in some way. And even 15 years after this case, when you look at the airway management guidelines, none of these guidelines today are able to address the very situation that occurred in the Ellen Bromley case. So cognitive efficiency and human factors are extremely important when we develop airway management guidelines, because we know today that it is not only the technical skills, but the non-technical skills that we use during airway management can make a difference to the outcome of the patients. And Puma has given a lot of emphasis to this in their guidelines. Then we have countries without guidelines. So are we going to wait for each and every country to have their own guidelines? No. Another thing that's very important is we have different guidelines, but they're always, they refer to different contexts. For example, we have obstetric guidelines, different guidelines for emergency, intensive care, pediatric, pre-hospital. Now, these are fantastic guidelines. I like them very much, but they are very context specific. And what Puma is trying to do is to have a single unifying document, taking the commonalities between all these guidelines and giving uniform principles by which the airway can be managed, irrespective of the context, irrespective of the patient, irrespective of which part of the globe you are working in and what your setting in is. And that is what Puma is trying to do, make this kind of uniform principle for airway management. So this gets rid of the doing away with the siloing of ideas and also the divergent practices that exist in airway management. So essentially what we're going to do is have universal principles for managing airway. And in addition, this is also a platform for collaboration among different individuals and societies across the globe where we speak one language. Coming to multiple terminologies. Now you can see that in different guidelines, we have used different terminologies. And as you know, critical language is very important. And what is critical language? Critical language is the language that we use in the context of airway management, whenever there's a crisis, it's a different terms that we use to express a sense of emergency, and different action point terms. And there's this very nice editorial that's written by Nicholas Crimes on critical airway, critical language. And quite recently, we wrote another editorial, Critical Language During Airway Management, Time to Rethink Terminology. So critical language is extremely important. And what is very important about critical language is that you need terms that are simple, are unambiguous, are universally understood, and also convey a sense of emergency. Now, what Puma has tried to do is that Puma, has looked at all the guidelines, and our idea was not to replace any of the terminology. We used whatever was, dominant legacy terms that was in the guidelines. However, wherever we felt that there was any terminology that interfered with, patient safety, or we felt there was a disconnect between what was a dominant term in the literature and what was commonly used in practice, there we tried to make new terminology, because we didn't have the methodology in Puma to use make new critical language, because this was not the objective of Puma, and you need a completely different methodology to address the critical language that should be used in airway management. So if you look at the critical language that is dominant in the literature, it's cannot intubate, cannot oxygenate, that is CAICO, and front of neck access, that is FONA. And if you look at what is most commonly used in clinical practice, it is emergency cricotherapy. So there's a clear disconnect between what is dominant in the literature and what is commonly used in clinical practice. In addition to this, Puma has tried to do away with acronyms because we don't want to use terms like CAICO-FONA, which is not universally understood and not universally used, and cannot intubate. We know today intubation is not the only way of ventilating or oxygenating a patient. And in addition, cannot oxygenate is not very, there's a lot of ambiguity in what oxygenation means, especially in the era of apneic oxygenation, because we know that we can continue to oxygenate a patient for longer periods of time. However, airway rescue has to begin at a time when you cannot ventilate the patient. So in view of this, I can tell you that we have done away with terms like CAICO and FONA. And we wanted to use, rather than acronyms, we wanted to use clear, unambiguous terms that convey the sense of emergency. And this is the reason why, and I can tell you that we have used a new terminology in the Puma guidelines, which has replaced FONA, and this will be the neck rescue. What about the methods that were followed by Puma? And again, coming back, this is a guideline committee, as I mentioned earlier, the 14-member working group of anesthesiologists, 3 intensivists, and emergency physicians. The method we followed is, and we have been working on this guideline for the last 4 years, let me tell you, 4 long years. And in addition to this, because of the delay in publication, this will go on to February 2021. And we have experts which are across 4 different continents, and we meet at different time zones, and all through video conference. Every alternate Saturday, we have a meeting, and I can tell you that my timing in India is 2:30 a.m. So we have 2-hour meetings every alternate Saturday for the last 4 years. That's the amount of hard work that's gone in. And this is just to maintain the time, differences between the United States and, Australia and the UK. So it's been extremely challenging, especially for me. But I can tell you this has been a fantastic learning experience, interacting with all these experts, brainstorming, while developing these guidelines. So a lot of hard work has gone into it. This is not just a cut, copy, paste job. We did extensive guideline review. We took all the available airway guidelines. We looked at the commonalities in these guidelines. In addition to this, an extensive literature review was done in all the areas where we made statements, and this was reviewed by several experts in the Puma group. And following this, we made statements of common principles. And to approve this, we had online survey among the group members. And this largely used Likert scale rating. And in addition to this, we also had free text where people could put their comments. Now, whenever there were gray areas or there were disagreements, we resolved this through video conferencing. In addition, for the gray areas, we also have in addition to this Puma group, we also have a 60-member advisory group, and this is stretches across 17 countries. Excuse me. And we put these points up to them, and they addressed various gray areas, and these got resolved through the opinions from these experts across the world. So Puma guidelines is not a rehash of the existing guidelines. There's a lot of novel, statements that we've made. There are a lot of silent areas in airway management which have not been addressed that Puma has made statements on. What about the format, the content, and the publication? So I can tell you that the universal principles, we have 5 documents that we're coming up with. One is the concept and the methodology paper that has already been published in anesthesia. In addition to this, one will be on airway evaluation, one will be airway strategy, airway rescue, and the 5th one will be on communication of the outcome. So this is the concept and method publication. And this was published in anesthesia recently. So this was the Puma, the part 1 of the concept and method paper of the Puma guidelines. And the other 4 should be published in February. This will be published not only in anesthesia, but it will also be published in emergency medicine and intensive care medicine journals. And the full guideline, as I mentioned, this should be sometime early in 2021. Now, our plan is not only to publish guidelines, but also have training program and educational resources. So we will have various, hopefully face-to-face workshops, meetings, web-based programs, and we will also produce various educational resources for people to use, including an airway app. I'd like to end by saying that Puma is not just another difficulty airway guideline. It is basically a unifying document, not context specific, unified approach to general airway management principles. And this is important. It's not just another guideline. And what's really unique about Puma, it has universal airway principles. And these are independent of the context, the geography, the provider, the location, the patient, the indication, even the urgency and the complexity of airway management. So this is something we're really going to be looking forward to, something very unique and an absolute unifying document that I'm sure all of you will really appreciate. Now, what needs to be looked at is whether having this kind of unifying approach to airway management improves outcomes really needs to be evaluated. So I'd like to end, and this is a picture of the last picture when the entire group met during the WAM meeting in Amsterdam. And on behalf of the entire Puma group, I wish to thank each and every one of you for a patient listening, wherever you are in the world. I hope you take care and stay safe. Thank you very much for your attention.
Thank you very much, Dr. K and Professor Sheila, for the excellent talk. We'll just move on to the questions. There's a question from Dr. J. Dasan to Dr. Rakesh. How would you compare the effectiveness of CPAP versus HFNC in COVID patients?
A very good question indeed, because an intensivist, when somebody is managing the COVID patient, the use of CPAP or NIV is a very common phenomena. But for COVID-19, it has been proven that HFNC has its role. So before somebody goes for CPAP, HFNC can be given in addition to the other adjuncts which I've already mentioned, like conscious prodding and other chest physiotherapy measures. But in case if you give a trial of HFNC and patient is having increased work of breathing in spite of an HFNC trial of about 60 to 90 minutes, and patient is using his accessory muscles for breathing, the saturation is not being maintained, patient is getting tired, this is the time where the CPAP needs to be done. So I think we cannot say head-to-head comparison of CPAP versus HFNC, but I will say it will be a series of sequelae of events, starting from conventional oxygen therapy, going to HFNC, then going to CPAP, and finally going to the invasive ventilation. That should be a series, and HFNC is a very well acceptable modality. prior to the initiation of CPAP.
Okay, thank you. Dr. Rakesh, is the role of HFNC in weaning of COVID patients?
I think yet a very important question again, weaning from HFNC.
HFNC in weaning of COVID.
Yeah, so there could be two options here. One is when somebody is on HFNC itself, he has been on high flows, say 60 liters of FiO2 of 100%. So this is one situation. So herein, as we do for the other oxygen therapies, we simultaneously come down with flows as well as the FiO2 gradually. So for example, somebody is on 60 liters and FiO2 100%, we'll try to bring it to 80% and then try to decrease the flows from 60 to 50 liters. And as we do for the patients with the ARDS on mechanical ventilation, the FI and the PEEP and those phenomena, same thing will be analogously applicable here also. So we'll come simultaneously with FI and flows continuously, and then we can shift it to the patients on conventional oxygen therapy. Second situation of weaning would be where patient have gone on CPAP, NIV, or patient was on mechanical ventilation. Now there is no much robust data of weaning from mechanical ventilation, invasive mechanical ventilation to HFNO. There is no much data. But it has been seen that if a patient is quite comfortable, patient is getting extubated, they are usually tracheostomized. And in those situations, we don't have much data, but yes, still in those patients, once the patient is tracheostomized, they can be weaned off and they can be put on HFNO rather than again on mechanical ventilation if patient is deteriorating for some reason. So we should be using HFNO as a rescue measure to mechanical ventilation in any critically ill patients who are not maintaining a saturation of more than 88 to 92%.
Thank you, Dr. Rakesh.
May I add a comment to that about high flow?
Sure.
Okay.
Sure.
Yeah. So just to add, in the general population, not COVID, both high flow and non-invasive ventilation, extubation to this has been shown to be beneficial in high-risk patients. Now, in COVID, of course, we are very concerned about, some people have even done delayed extubations because they're worried more so about a re-intubation in these patients. And we know today, delayed extubation is not required. So especially in high-risk cases and those which you're kind of worried about that, you're not very certain about whether this extubation is going to be successful and you have concern, definitely extubation onto both high flow and non-invasive ventilation electively in COVID patients can be practiced, and we do this in our intensive care unit. And now the confidence, as Dr. Rakesh has beautifully explained in this talk, is much more, because earlier we were worried about the aerosol generation, but now we know that if a modality is going to help a patient avoid a re-intubation, it's better to use that and keep yourself protected and wear adequate PPE than to avoid that therapy and land up with a re-intubation for this patient. Just wanted to add that. Thank you.
Dr. Rakesh, there's a question.
There's a question for Dr. Rakesh. Yeah. Okay, Jay, go on.
There's a question asking, how would you measure the carbon dioxide during HFNO? This is by Dr. Verghese Sherian.
I think it's really a pleasure to listen so many queries of HFNO because it has come up as a very real rescue tool in COVID-19 patient. I must agree that the carbon dioxide measurement is always an issue, especially when you're using high flows. So we cannot measure it. But if you see the pathophysiology of the carbon dioxide exchange in patients of COVID-19, it is not as same as a sepsis-induced ARDS. As I mentioned in one of my slides, the pathophysiology is almost different. So these patients are not retaining carbon dioxide so much because it's a diffusible gas. Carbon dioxide is a better diffusible gas. So the retention of carbon dioxide is not much of a great phenomena. The reason could be the pathophysiology and the beneficial effect of the HFNO itself. When we use an HFNO, it has many additional effects, like it creates a PEEP, it washes away the dead spaces, the exchange of air is much better, and hence carbon dioxide being a better diffusible gas across the alveolar membrane, it is easily washed off. So even for prolonged uses of HFNO and whatever the parameters, if you say I quoted 3 studies, the PaCO2 levels were not much higher. So we do not have a modality of measuring end-tidal carbon dioxide in these levels, but in fact, it is not desirable to maintain them routinely, to monitor them even with ABG pictures, except from a study purpose or for when the patient have some deterioration in the clinical situation. We exactly do not need to measure it in the end-tidal carbon dioxide, but in fact, we do not have a modality to measure it, and it's not desirable, it's not required actually. So we can go ahead and use HFNO in our critically ill patients with COVID-19 with beneficial effect, nothing to worry about the retention of carbon dioxide as such, whatever the existing data is available.
Thank you. Dr. Sheila, there's a question for you. We have resource-rich and resource-poor settings where the equipment, the airway management, the outcomes differ. So how will PUMA address these issues?
Yeah. Thank you very much. That's an excellent question. I've been asked this actually several times because across the globe, even availability of the equipment, there is variation, and there's variation in clinical practice. So what PUMA is giving, it's saying, for instance, that, prefer using a video laryngoscope. It's telling you that the outcomes of first pass success is better. It's not mandating. This is not like a legal document which says that these are the desirable things that you should follow. So what PUMA is trying to do is give you, principles for airway management so that you can improve outcomes. So of course, it will result in, some places they may not have the tools that are described, but I can just give you an example that sometimes these kind of documents really help you. For instance, I'll just give you an example. End-tidal CO2 was not used by a lot of intensivists, especially physician intensivists across India. And when we had the subgroup analysis of the NAP4 project of ICU data, it actually showed the high incidence and increased morbidity and mortality in patients in whom capnography was not used, and much higher compared to the operating room. And this kind of data really helped us with the Critical Care Society to, convince administrators to make capnography available in the ICU. So I think that even in places where equipment is not available, sometimes I think it is because of lack of awareness, and also administrators and hospitals, they need data to show improved outcomes when they invest in some equipment. So I think a document like PUMA, which gives you, tells you that these are the things that you should use, and these are the techniques, and these are the principles that you should follow, which can help you improve outcomes in your patients. I think that can be very useful, especially in the developing world, to improve outcomes from patients. But yes, it is a concern. I agree that all the things that you mentioned may not be available. The one tool that we were concerned about was the video laryngoscopes. But looking at the availability of video laryngoscopes in India, and also the local manufacturers, and the cost having come down so much, I speak to some of my friends abroad and they say, oh, we don't have as many video laryngoscopes as you all have, even in some small district hospitals. So I think it's just a matter of, awareness of what we should use. And of course, cost of things will come down with time. So I don't think this should really be a concern. Thank you.
There's one more question along the same line, madam. What about non-English speaking societies? How would you address them? What is critical language world over? Do you have a translation for all this, or will that be coming up soon?
So a very, very important question. And this was especially, a concern among the Europeans. And, like I mentioned, we had a lot of discussion and debate. You can imagine over 5 years, if you're just debating about critical language, how much discussion on Twitter, there's a lot of, brainstorming that's gone on. And, they felt, acronyms was something we definitely didn't want to use. Because the people who are publishing and writing these papers are not the actual people who are securing or dealing with difficult airway, and we needed language that was extremely simple and unambiguous, and it had to convey a sense of emergency. If it didn't do that, for example, FONA does not. People don't understand what FONA is in a lot of parts of Europe, in China, in different places. So the first step, of course, is to publish this in English. But as a second step, we have made a plan for having this translated in different languages. And this is the second step. So that's a very important question, because in European languages, in Chinese language, South American language, we are planning to get this translated. But of course, the first attempt is to have it done in English, and this will be done subsequently. And it will be it's very important and useful, of course.
And there is one more question. Should individual societies stop producing separate guidelines and everyone just follow PUMA?
So this is an excellent question. Now you can imagine, as president of All India Difficult Airway Association, one would have thought there's a direct conflict for me to be part of PUMA. And many of them are also, with their societies. So as you know, All India Difficult Airway Association came up with the guidelines which we published in IJA and also the critical care one in IJCCM in December 2016. And now in December 2021, we are actually coming out, as we promised, in 5 years with the revised guidelines. So, we are in the process of this, and then here we have PUMA. So again, no airway society needs to be, threatened by PUMA. PUMA is not a replacement of guidelines. As I mentioned, it's not a guidelines at all. It is a document of principles of airway management. So it's telling you how to optimize oxygenation, how to do this. So it's not for a particular kind of pain. It's not in the OT. It's something that everybody can use. We have emergency medicine people. So talking to them, we realize that there are many things that, we as anesthesiologists, we're in these kind of silos. We're not cross-talking with people from intensive care, from emergency medicine. So their requirements are different. So you have to have some common principles. And ultimately, what you're doing is airway management. Like I said, what you're doing is chest compression. What you're doing is, in cardiac arrest, has to follow a similar kind of pattern. So we have made some very, very robust principles, of course, entirely evidence-based, that can improve your outcome. So I would say, rather than replacing, these are actually going to complement the regional guidelines that exist. So this was not the goal of PUMA to get rid of all the guidelines and just have one guideline that everything would follow. Of course, that won't be possible. So it's like principles. And unfortunately, I would have loved to reveal the content, but I'm not able to do that because it's not yet published. But I am sure it will be something that will make you very happy when you see this. And I expect this to enhance the utilization of all the international guidelines of different various societies.
We just hope that the guidelines which come out will be available free for everybody in the world to read immediately.
Yes, it will be. It will be. That's the plan. Yeah. And what's good is that not only anesthesia, but we've also liaised with, intensive care societies, journal, and also emergency medicine journal. So it will be available, across specialities, and that's something we've worked on a priori. So I think it will be globally available, and the plan is to publish this free. Yes.
Thank you.
One last question to Dr. Rakesh. Do we need to use the same high-level PPE for HFNO as for intubation?
We have to use the level 3 PPE, not exactly as intubation, where you use the barrier devices and other modalities while doing the tracheal intubation. But yes, you need to follow the as suggested PPEs for the intensive care, which includes a coverall, which includes gloves, which includes N95 mask, and preferably with a face shield or at least a goggles, and a head cover should be there. So this is the minimum requirement for HFNC to be used. And to be on a safer side, a patient can use a triple layer surgical mask over the HFNC that will prevent the contamination of the environment. And the other precaution, as I mentioned earlier also, it is just not the oxygen therapy, it is a multimodal approach. Same precautions will be applicable for here also. The place where the patient is being managed, it should have at least 20 air exchanges. So you need to take care of those phenomena also. Patient should not be actively coughing. In that case, you can use other pharmacological agents that we are using as a part of modality of these patients' management. So I mean, it's just not PP. We have to include the extended adjuncts to the PP to prevent the contamination of the environment and prevention of a healthcare worker from getting contaminated. But yes, PP should be level 3 for that.
Okay, we are for want of time, we wouldn't be taking up any more questions. Thank you very much, Dr. Rakesh and Dr. Sheila.
Thank you
for joining us.
Thank you.
Thank you very much, Dr. Jacob, Dr. Jaya, Dr. Sheila, and Dr. Rakesh for that excellent talks and discussion. We'll now move on to the third session. This session will be chaired by Dr. Rakesh Kumar, who has already been introduced. Sir is a regular at Kaamcon workshop, and his station is always one of the most lively and well appreciated ones at Kaamcon. Dr. Meera Kurup is the other chairperson. She's a consultant pediatric anesthetist at King's College Hospital, London, UK. And she's also a regular at our Kaamcon workshop. She does a lot of voluntary work in India and Africa, and I'm just waiting for COVID-19 to get over to go with her to Africa. Over to you, Dr. Rakesh and Meera.
Meera, are you there?
Yep. Thank you, Elizabeth. Hello, everyone. Good morning. The first speaker I would like to introduce is Dr. Mary Matthew. Mary Matthew and I have shared the same alma mater while we were studying anesthesia, and then she has remained a friend. Mary is now additional professor at the prestigious Regional Cancer Center, Trivandrum. Mary has accumulated prestigious awards. One of them is the International Union Against Cancer Award, otherwise called ICRAD Award for Training Oncology Intensive Care. She had also experience from other famous institutes across the globe. Her main interest is anesthesia for oncology. Mary is the author and the publisher of many articles across many peer-reviewed journals. Handing over to Mary. Hi, Mary.
Good morning. Happy 2021. Recent advances do not only mean new machines, new instruments, or new techniques. It's also about using old things in a new way. So that is why blind nasal intubation, the forgotten art, has a role in the management of difficult airway and a place in the advanced airway management program. So let's go through everything about blind nasal intubation, the art of blind nasal intubation, how it became a forgotten art, the revival of the art, all literature concerning this art, and how we have converted it into a modern art. Now, what is blind nasal intubation? It is the technique by which an endotracheal tube is inserted through the nose into the trachea without actually viewing it. That is why it is called a blind procedure. How is it done? It is done with the aid of listening to the breath sounds. So it is an awake tracheal intubation procedure. It was first done by Magill and Robotham in 1914 during the World War, when there were mass casualties, and it was done as a field procedure because you didn't need any instrument and you only needed the endotracheal tube to intubate the patient. So now I'm going to show a video of how it was being done. Right.
Very good. Okay. ഒരു മിനിറ്റ് പോലും എടുത്തില്ല. 1.5 മിനിറ്റ് ആയേ ഉള്ളൂ റെക്കോർഡിംഗ് തുടങ്ങിയിട്ട്.
So you see, there's every risk of the patient transmitting a disease to the anesthesiologist because you have to bend down and hear the breath sounds carefully before you can intubate the patient. Then why was this technique forgotten? Because of the invention of the flexible bronchoscope. By the time it was 1980s and 90s, almost all educational institutions, corporate hospitals, and big centers all over the world had acquired this as a part of the difficult airway armamentarium of the anesthesiologists. So all anesthetists were very busy trying to master this technique, and the old technique got regated. So why are we thinking of reviving it today? Because today we are in a pandemic situation, and now the intubation of patients using fiber optic bronchoscope should be avoided due to the risk of contamination due to aerosolization. So what are the indications or the situations in which we can use a blind nasal intubation? In an oncology setup, in a cancer center, we saw that elective surgery was shut down for 2-3 months, and all patients have advanced in their stage of cancer. They have been getting chemotherapy and radiotherapy, but we see a lot more trismus and larger oral cavity tumors than before. These are indications for awake tracheal intubation, and they should be done. Even tracheostomy, which was an emergency procedure for difficult airway, is now being done electively after intubation because of the danger of spread of aerosols, especially in COVID positive patients. Now, in the COVID ICU, where you have patients with difficult airway and the patients are desaturating but are comfortable, you could secure the airway with a blind nasal intubation before putting the patient to sleep if you are not confident of securing the airway. Bleeding and poor visualization has always been an indication for blind nasal intubation. Now, non-apneic patients needing airway support. This is an area we don't think about. A patient coming in the casualty with drug overdose or head injury, they are still breathing, but they need protection of the airway from aspiration and impending respiratory failure or arrest. There, you can use blind nasal intubation because advanced airway equipment may not be available in these peripheral centers, and you may not have personnel to help you. Cardiology ICUs, neuro ICUs, patients with cardiac failure, COPD, CVA, everywhere you could use this technique for securing the airway. So we went through the literature, all what is available about blind nasal, so that we could develop a new technique or a safe technique to use during this pandemic. The most useful article was this in the European Journal of Anesthesiology about how to teach blind nasal intubation. So world over in 2013, they recognized the need to learn this art because they found that in many suburban and rural areas, there was a dearth of advanced airway equipment, and they made it their mission as a global outreach program to teach blind nasal intubation as a life-saving technique in difficult airway situations. So we took a few points from them, and I'm going to show you how exactly they conducted this workshop on mannequins, because it's a difficult thing that to make a mannequin breathe, because you need a patient to breathe to do or practice blind nasal intubation. They use this thing called Beck Airway Airphone Monitor. It's a whistle. So listening to the sound of the whistle of the air going in and out, they taught these students blind nasal intubation. They also use the endotrol tube, which has a wire which you can flex the tip of the endotracheal tube to go into the larynx. But both these are not available in India, so we couldn't acquire this. And further literature search showed that many people had made their own whistles. So we decided to make our own very whistle. There were also articles who used where anesthetists use NG tubes to guide the tube into the trachea, and even an LED source of LED light with a flexible copper wire with a battery operated switch to show where the tube was and to guide it into the trachea. We tried these out, but we didn't find it very effective. So we didn't use this idea. The capnograph guided awake nasal intubation is a good idea because you can see that once it goes into the esophagus, there's a flattening, and into the tube, into the trachea, you get a very good capnogram. But the problem is that even if you have a very good mask fit, you could get a good capnogram even with mask ventilation. But it is a good idea, and we did incorporate it into our the method of doing it. The ultrasound guided blind nasal intubation was not really very helpful because you could see the tube into the trachea or esophagus, but the nasopharynx, the pathway through the nasopharynx, we couldn't follow it well with ultrasound guidance. Now, this was one of the very useful techniques that we saw. That is, if you see that the natural pathway of the endotracheal tube will come and lie between the larynx and the pharynx and the esophagus. And if you wanted to go into the larynx, you could give burp or you could inflate the tracheal cuff. So when the tracheal cuff gets inflated, the tip goes into the larynx. So we took a video scope picture of it. See, this is where it naturally lies behind the arytenoid. If you inflate the cuff, instead of picking up with the maggots, the tube tip automatically rises up to the center of the larynx. So this was a very useful technique that we found. And we went through the IDA guidelines, which told us that you have to reduce the tracheal intubation time, reduce aerosol generation, and prevent aerosol transmission to the intubating personnel. So we kept that in mind. We also found studies which showed us that blind nasal intubation takes less time than fiber optic intubation. And that was very encouraging, in fact, because we had to keep time in mind. And we also had reassuring studies that showed us that the cardiovascular response, heart rate and BP and airway complications were not very different, or in fact same as when you do fiber optic intubation. So having this learned all about this in the literature, so we decided to do the best we can with what we know. And in case we find newer, better methods tomorrow, we will change. So we took the whistle idea, we took the capnograph, and we introduced the viral filter, because having a viral filter between when the patient is breathing will filter the coronavirus and reduce the chance of spread of virus into the atmosphere and to the person. So this is how they conducted the airway workshop in Rwanda. We tried it out with a Laerdal mannequin. You have to manually press the lung and you could intubate so that when the noise comes, you know that the tube has entered the trachea. Now, he's our technician, Mr. Eben, who helped me to make this whistle. You can see that we used the squeaky toy whistle, which is costing about 10 rupees, and a 100 ml saline cap. And we used a viral filter in between two L connectors and blocked the opening of one of the L connectors, and the port of EtCO2, we inserted the whistle. So on assembling, this is how it looked as a T-piece. It's not too heavy to connect the endotracheal tube here so that the air goes out only through the whistle and makes a noise. And you can have the air sampled for EtCO2 and the viral filter in between. So because they're all elective procedures and we are only targeting anticipated difficult airways. If the patient is a cancer patient, you usually have a CT scan. So if you have an Osric software, you can see a 3D picture, or you could go down to the PACS and they would have a virtual airway endoscopy. You could make out whether the larynx is anterior, whether there's a floppy epiglottis, whether there is subglottic stenosis. All these make blind nasal intubation more difficult. Always get a difficult airway consult, a tracheostomy consent, and an RT-PCR done. Now explain the procedure to him, close the mouth, breathe rapidly, and no swallowing. Now, glycopyrrolate is given for drying up the secretion so that the local anesthetic acts better. Midazolam for anxiolysis, and morphine not for sedation, but for cough suppression. Xylometazoline drops are given into the nose so that there's no bleeding when you pass the tube. Calculate the safe dose of lignocaine, give it transnasally and tell him to open his mouth and put it into the back of his mouth. It works just as well as transtracheal, which you can't give because of aerosolization. Now, pre-oxygenation you could do for 3 to 5 minutes. No need of supplementary oxygen during the procedure. They do not desaturate and they maintain the saturation they had pre-operatively. Now, I'm going to show you a video of how this procedure is done. Before that, please note the following points that when you see the video. This tube has been softened in a bucket of hot water. So it is really soft and pliable so that it doesn't produce trauma. 2, close the other nostril. This is not seen in the video, but that should be done is other than the nostril that you're intubating, the other nostril should be closed with a finger and the mouth closed with a mask so that all the air moves only through the filter. Use a tent or better still an aerosol box to increase the distance between the patient and the anesthetist. Since you're not using any instrument, the aerosol box is quite convenient and gives you an armrest. Now listen to the whistle sound. The moment the tube enters the trachea, the whistle sound, the quality of the sound changes. It goes into almost a soprano and you can clearly make out that the tube has passed into the trachea. Now watch the capnograph which is there in the background of the video. My assistant is also pointing it out that the capnograph gets better when the tube goes into the trachea. Now, if you are not successful with this method, you could use burp so that the trachea goes down a bit and the tube passes through the trachea. Rotating the bevel helps a bit because if it is hitching against a vocal cord, you could turn it and pass it through the larynx. Inflating the tracheal tube cuff, I had shown you the literature, that also helps when the trachea larynx is anterior.
ഇപ്പൊ ഉറക്കം വരുവേ. കഴിഞ്ഞു കഴിഞ്ഞു. ഓക്കെ, ഇപ്പൊ ഉറക്കം വരും. കഴിഞ്ഞു കഴിഞ്ഞു.
ഊരിക്കും.
So actually, we have been advised to use the video laryngoscope in times of difficult intubation. But these are the problems that I had because if you have a tent or some barrier between us and the patient, it's quite difficult to access the patient. And now anyway, they've taken off the requirement of putting a barrier for intubation. But since we are not allowed to ventilate, then again, the patient has a strong chance of desaturating if I take a second attempt. And sometimes the patient comes out of scoline and propofol and then jumps, and then the patient coughs and moves. So there is greater risk of aerosolization in a very difficult anticipated intubation than if you do a awake tracheal intubation. So despite the myriad of airway devices that we find, blind nasal intubation still remains an adjunct in the difficult airway management armamentarium. Its utility in clinical settings in urban, suburban areas and in the present pandemic cannot be overlooked. And this is a skill dependent totally on the skill of the practitioner alone. And so I feel that blind nasal intubation is like basic life support. Hope that you'll never need to practice it, but you definitely need to know it and master it as a life-saving skill. My sincere thanks to Dr. Elizabeth. It was her brainchild to make me present this topic in an advanced airway forum. Thank you, Dr. Sam, who's always been very encouraging and supportive in this presentation. And thank you all the organizing committee of Kaamcon for giving me this opportunity to present on a web platform. Thank you so much.
Thank you very much, Madam, for that wonderful presentation of an art which has, which has been forgotten, as you mentioned, but you have very nicely elaborated upon many ways of making this blind nasal intubation less blind, if I were to use the terminology, because by the use of whistle, end-tidal CO2, cuff inflation technique, and so on. And in addition to that, some people have also added a stethoscope which can be put in circuit along with all the connectors that you have described, and thereby keep the person who is doing this procedure away from the patient's face. I'm sure you must have used that as well. Now we go on to the second topic, which to some in some ways related to the first one, because a lot of people use airway blocks while using the blind nasal intubation as well, to kind of supplement the whole procedure. And to do that, the current role of airway blocks, we have Dr. Shiv Kumar, who is a consultant. University Hospital. Good morning, Dr. Shiv. His career spans from Jipmer, Pondicherry to AIMS Delhi to UK, and he has special interest in regional anesthesia, vascular anesthesia, ortho, and trauma anesthesia. He has he is into teaching in a big way, teaching and training. And he's also teaching and training the FRCA students. He has more than 40 publications and chapters in the book, review articles, editorials, and so on. And he loves to use the social media in education. So I'm sure that he'll love this platform. Shiv, all yours. Shiv, do we have you?
Yeah, I'm here. I think they're going to share my video. Hello, good morning, everyone.
Yes, yes. I wanted to at least have a look at you. Thank you for appearing on the screen.
Hello, everyone. I'll be today talking about current role of airway blocks. My name is Dr. Shiv Kumar Singh. I'm a consultant in anesthesia at the Royal Liverpool University Hospitals. So first question is obviously why airway blocks? Why do we need to know about them? All of us in our life will face patients who need anesthesia. And these patients have airway compromise or trauma to the upper way, unstable cervical spine. And in these cases, we need to secure the airway awake. And to secure airway awake, we need to know about airway blocks. Okay, so that's where my talks comes in. So airway blocks may be required for having an awake look. So this is, we're talking about awake video laryngoscopy. Or it may be required for awake fiber optic intubation, which could be oral intubation, or it could be nasal intubation. So when we talk about the airway blocks, we talk about the innervation of the airway. And if we are going to do a nasal intubation, the tube need to pass through the nose, to the nares, oropharyngeal area, and then into the trachea. So for the nasal area, they're supplied by the trigeminal nerve, oropharyngeal area supplied by glossopharyngeal nerve, and the vagus supplies the trachea part. If you are actually planning to do oral intubation, then you could avoid blocking the trigeminal nerve. So the three nerves that, or three main areas that need to be blocked is the trigeminal area, glossopharyngeal area, and the vagus area. If you look at the trigeminal nerve, all three divisions are actually involved. So we have anterior ethmoidal nerves, which are branches of the ophthalmic division of trigeminal nerve, sphylopyramidal nerves coming from the maxillary division, and the lingual nerve, which is part of the mandibular division of the trigeminal nerves. We don't bother much about the lingual nerve. Then we have the glossopharyngeal nerve, as we talked about it. And the vagus nerve, we have the superior laryngeal, and its branch, the internal laryngeal, and the recurrent laryngeal nerve. So when we look at awake video laryngoscopy or oral awake fiber optic intubation, in that case, we are going through the oropharyngeal route to the trachea. So we need to block the glossopharyngeal nerve and the vagus nerve. But if you're looking at the nasal awake fiber optic intubation, in that case, you need to block the trigeminal nerve branches and the vagus. If you want to block the oropharyngeal area, then you can actually, but you can avoid it. It's not really necessary unless you are going to have someone pull the tongue. That is actually required when you are going to do a sedated or patients who are mildly sedated, and you want to do that where the tongue is falling back. So first we look at the trigeminal nerve, how we're going to block. Like I said, lingual is not important. What's important is to block the anterior ethmoidal nerves and the sphenopalatine ganglia and the nerves. So we can actually use a cotton taped applicator that is soaked in lignocaine. And for ethmoidal, you need to go on the, anteriorly through the nose, almost parallel to the nose, the opening. And you apply the anti-ethmoidal and the anterior part just near the cribriform plate. For the sphenopalatine ganglia, you need to go almost parallel to your maxilla. And it goes in the middle turbinate, just posterior part of the middle turbinate. And you, again, have the lignocaine soaked the cotton applicator, and you can actually apply 2 of them in that area, if that is because that is very important for the anesthetizing the airway, nasopharyngeal airway. You could also use atomizers, DeVille Bliss atomizers, and these can also be modified. So instead of actually having the manual pump, you could also use oxygen tubing. You need to actually have a hole. So where you see the right hand, and that's actually got a hole in it. So you can then control the atomization. We also have the commercially available applicators or the atomizers that can be arranged to syringe. I'll talk about them in a minute. We also have the sprays. Now, this one is the one which I use. We have lidocaine with phenylephrine spray. Phenylephrine is a vasoconstrictor. So instead of actually applying vasoconstrictors separately, you can use this combination, and this will anesthetize the nasopharyngeal airway and also cause vasoconstriction, so increase the space for passing the tube in. Lignocaine on its own is also available. This is available as 10 milligram per spray, so you can actually calculate your dose very easily. The other thing I use is lignocaine gel that is applied to a nasopharyngeal airway, and it also helps you to gauge the size of the what kind of size of tube you could be able to pass through the nasopharyngeal to the nerves, and because it's important that you do not cause much trauma, and so you can anesthetize as well as you can then also know what size tube could easily pass through the nose. You need to be careful with the dose of lidocaine used, and we need to not exceed the dose more than 9 milligram per kg lean body weight, not the total body weight, but the lean body weight is important here. So blocking the glossopharyngeal nerve can be blocked using just a spray. And that's the easy way, but you can also block it by doing injections. You need to be careful when you're using injection, intraoral route injection, because the carotid artery is just running behind it. So there are very high risk of causing intravascular injections when using the technique. Okay. As you can see, that it's easy to actually see the tonsillar pillars, and you need to actually just go anteriorly to the anterior tonsillar pillar, inject local anesthetic there, it'll spread to the glossopharyngeal nerve. And like I said, you can easily do it with just spraying with some lignocaine. You can also do an extra oral injection. You need to find the midpoint of the mastoid and the mandibular angle, hit the starlight process and walk off it, and you will be onto the glossopharyngeal nerve. Again, remember the internal carotid artery is running very, very close by. So always aspirate and inject before you try to block anything. When you're talking about anesthetizing the oropharyngeal airway, we always talk about whether we should be using antisalagogues or not. And it is said that it's important to actually have a diamucosa for the local anesthetic to be effective, because the saliva will dilute it. So most people do actually use antisalagogues, though we don't normally use it because we tend to actually do nasal intubation mostly. But if you're going to use glycopyrrolate, then use 200 micrograms, 200 to 400 micrograms. And if you're using IM, then use it 40 to 60 minutes before you get the patient to the theater. If you're going to use it IV, then give 100, 200 micrograms. And with that, be careful, because that is going to cause undesirable clinical consequences. If you're talking about that is tachycardia. It will cause tachycardia, irrespective. Even though it is antisalagos dose, it will cause tachycardia. So the last part is the vagus nerve, and there are lots written about it. How do you block the superior laryngeal nerve or the internal laryngeal branch of it and the recurrent laryngeal branch? How are you going to do? So that is Jackson-Krause forceps. So this is used for application of a cotton pledget soaked with lidocaine, and this is then kept in the piriform fossa on both sides, and that can block the internal laryngeal nerve. Or you could actually talk about doing blocks, and there are two techniques in which some people would actually go and hit the greater corner of the hyoid and just walk off it, or they would go 1 centimeter medially and 4 to 5 centimeter below caudally, and then pierce the thyroid membrane and inject local anesthetic to it. So there is, again, different techniques in which you hold the hyoid bone, if you can actually feel it, and push it towards your thumb. That I'll show you in another image that it is. So you actually, so with your left hand, you hold the hyoid bone and push it from your left side to the right side towards the thumb, hit the greater corner of the hyoid bone, and then walk off it and inject local anesthetic to block the superior laryngeal nerve. Or you could just block, like I said, go 1 centimeter medially and 4 to 5 centimeter caudal, and then you pierce the thyroid membrane and inject local anesthetic, piercing the thyroid membrane. That will block just the internal laryngeal branch of the superior laryngeal nerve. To block the recurrent laryngeal nerve, you can actually use a transtracheal or go injection through the crocothyroid membrane and inject local anesthetic into the trachea directly. So transtracheal injection through the crocothyroid membrane. Deposit local anesthetic, let the patient cough. That will actually spread the local anesthetic in and out, anesthetize the. You can also, if you are actually used to doing the ultrasound, you can do ultrasound guided block as well. You can actually, trace the thyroid cartilage, which is easy to see, and follow it up to the hyoid bone. You can not see it directly, but you can actually see the the vascular, the neurovascular bundle can be seen. You can hit the cone and just walk off it. So you can actually do a block using ultrasound as well. As some people actually say, why actually do all these kind of blocks, poking needle here and there, why not just nebulize? So take lignocaine, doesn't matter, 5%, 10% lignocaine. 10% lignocaine is always in the CD cupboard. It's not freely available. And nebulize it. Give them time, 20 minutes or so, and patient will breathe through the nose. It will anesthetize the nasopharyngeal airway, the oropharyngeal airway, and the trachea. So do that. That's one way of doing it. So lignocaine nebulization is this. The most common method of doing the anesthesia for the airway is by topicalization of spray as you go. There are commercially available devices like ENK device for that, but most of us would actually just use an epidural catheter and attach a syringe. So in this case, we take around 3 or 4 syringes and we load it with 2% lignocaine, and so 2 mLs of lidocaine and 3 mLs of air. So you need to have that air to push the lignocaine on, and then it will spray itself. So this is a look at it. So that's epidural catheter with the lignocaine through that. Like I said, there are commercially available atomizers available. You can have a bottle form atomizers. So this can be attached to lignocaine, or you can pour lignocaine into and atomize it. There are a syringe with the atomizer which can be attached to it. It's conical, it fits into the nares easily, and you can calculate the amount of dose delivered as well. So they're pretty accurate. Or they can have an atomizer stillet, malleable stillet, so you can actually steer it. So you can steer it through the nose or through the oropharyngeal airway. And again, it is attached to a syringe, so you know how much amount you are actually delivering. Sorry. Then there are airways that comes, this is the oropharyngeal airway that comes attached with a atomizer as well as oxygen. So you can attach the oxygen. So one of them you as the atomizer with lignocaine, and the other can be attached to the oxygen tubing. So you can deliver oxygen as well as deliver the local anesthetic. Now, as far as the literature is concerned about evidence of the blocks versus the other techniques, there isn't much, but there are a few commonly quoted articles which talk about the difference between blocks and in topicalization. And they say that blocks of the glossopharyngeal and superior laryngeal nerves are associated with higher plasma concentration of local anesthetic. So there is a greater absorption. There is chances of local anesthetic toxicity. As I've said, your glossopharyngeal nerve lies very close to the carotid artery, injection on there. And obviously there are going to be multiple injections into blocks bilaterally. So you're going to give glossopharyngeal, the other nerve blocks, superior laryngeal blocks. You need to do them both sides. So multiple blocks, multiple needle punctures are required. So what do our guidelines actually say about them? And so the ASA guidelines don't mention. So there are practice guidelines for management of difficult airway. And they actually talk about, you need awake intubation in patients who have difficult airway. But they don't talk about how it need to be done. Okay. So technically you need to use for awake tracheal intubation. That's left to the anesthetist to decide. What about the Difficult Airway Society? Difficult Airway Society came out with guidelines very, very recently, just last year, early last year, they were published. And they do actually talk about it. So if you look at it, they talk about oxygenation, topicalization, sedation, and performance. So it's important to keep oxygenation. You can use sedation, okay, and then but we are not interested. I'm not talking about other aspects which will be covered by other faculty. I'm talking about topicalization. So they do talk about topicalization, and they say that you can use 10% spray, which I was talking about, 10 milligram per spray on the tonsillar pillars on the base of the tongue, and you can use around 20 to 30 sprays during inspiration of 5 minutes. For the nose, you can use cofenilicaine, that is the lidocaine with phenylephrine. That is 5% lidocaine with phenylephrine, so it causes vasoconstriction as well. And you can always repeat them. And you can also actually use it along with co as you spray. You need to actually have, sprays, like I said, you have 5 ml syringes filled with 2% lidocaine, and each is filled with 2 ml of the lidocaine and 3 ml of air, which can be delivered through an epidural catheter. Or you can use, if you have a MAD device, then you can actually use that for that. And it's important like how to calculate the maximum dose. I'm not going to go through this. And like I've said, it need to be maximum need to be 9 milligram per kg. Of the lean body weight, not the total body weight, but the lean body weight is the maximum dose used. To end this talk and the summary of that, we need to actually have knowledge of the innervation of the upper airways. We know that need comes from the trigeminal nerves, from the glossopharyngeal nerve, and the vagus nerve branches of the vagus nerve. You need to have the knowledge of appropriate local anesthetic techniques and vasoconstrictor drugs. So if you're using the nasal airway, use topical vasoconstrictors. Lidocaine with phenylephrine is a good drug to use. And then you need to actually have idea about the various techniques available. You can use nebulization, you can use nerve blocks. You can use combination of it. It does not have to be just, one or the other. You can actually use, so you can use transtracheal injection through the cricothyroid membrane to reduce the coughing, and as well as spray as you go. Or you can use the nebulization technique with, so you can use, so just be careful that you do not exceed the total amount of lidocaine used, because the chances of local anesthetic toxicity are high. And always have intralipid in the theater, operation theater, in case you land up in trouble. Thank you for giving me this opportunity to talk to you all. Have a nice day.
Hi. Hello. Now,
Go on.
yeah, now we are introducing Dr. Jairam Dasan, known to everyone as Jai. Dr. Jairam Dasan is a consultant anesthetist at King's College Hospital, London. He is my current colleague, and he has brought King's to the forefront of airway management and advanced airway management by his own endeavor. He has specialist interest in advanced airway management, bariatric anesthesia, obstetric anesthesia, trauma and maxillofacial anesthesia, and craniofacial anesthesia. In fact, a jack of all trades and the master of them too. He is the airway management lead since 2010 at King's College Hospital, and he's the founder of King's Advanced Airway Management Workshop since 2006. And he's the chairperson of that as well. He is an invited speaker and airway faculty for Association of Anesthesia Great Britain and Ireland, European Society of Anesthetists, World Congress, and there it goes. He's world famous. Over to you, Jai.
Thank you, chairpersons, for your kind introduction. Thank you, Ask Scientific Committee, for your invitation to give me this chance to give this talk. I do not have any affiliations or disclosure to make. To start with, I would like to mention a few words regarding my hospital and what we do at King's. King's College Hospital is located at the Southeast Thames region. That's not too far away from the London Eye and the other attractions in city. King's College Hospital is a large university hospital, and it is a major trauma center in London as well. King's run the largest liver transplant program, and we are a major trauma center in London as well. We run regular airway workshops, and we have airway training programs for the last 15 years at King's. We have more than 40 GLADScope systems and more than 20 fiber optic systems, which enable us to provide teaching and training on advanced airway tools as a frontline rather than as a backup system. Personally, I was fortunate enough to perform and learn more than 7,000 video laryngoscopic intubations as well. Let me take you through a couple of unusual airway cases where you may find it useful to estimate the importance of my topic for this discussion today, which is hybrid intubation technique. This is a 60-year-old female suffering from mucopolysaccharidosis. She presented with a severe flexion neck deformity and severe TM joint, temporomandibular joint ankylosis. And you could see the hard and protruding tongue, and which is always outside her mouth. She couldn't put it back. She was unable to breathe lying flat or eat. So the planned operation was for the tongue reduction, which probably enabled her to breathe better, sleep, and eat. So from anesthetic point of view, the plan was an awake tracheal intubation, and we attempted awake tracheal intubation while we are oxygenating through the throat. But awake tracheal intubation failed as the nasotracheal tube was unable to negate the acute angle created by the hard and large tongue base. So the plan was to try a combination technique or a hybrid technique using glide scope and fiber optic flexible intubation system together. So we used a glide scope for visualizing the oropharynx and possibly to compress to some extent the tongue base, and also to know where the tube is on the fiber optic system when the tube gets into the oropharynx. So started with a glide scope visualizing the oropharynx, and the nasotracheal tube was coming as over the fiber optic system. So we came along gently. We were able to compress the tongue base to give a less of an acute angle for the tube to pass and see the larynx, and then tracheal intubation was made possible. And at the end, we did a planned staged extubation as well. So case number 2, this is a 6-year-old child presented with a dental abscess and with severe trismus as well. The mouth opening was very minimal. The plan was to have an inhalational induction and then perform a fiber optic intubation. So the inhalation induction was done, and child is asleep and breathing spontaneously. But when we did the fiber optic, we found that it was extremely difficult to go along the acute angle created by the oropharyngeal swelling. So the fiber optic intubation attempt failed. We tried this supraglottic airway device in order to ventilate or use as a conduit, but unfortunately the seal was not good enough. So the next plan was to use a pediatric air track, which was inserted, and that provided us a conduit to get the fiber optic scope and the tube over it, and also to angulate it nicely towards the larynx without much problem. So the combination technique helped to visualize the larynx and to negate the fiber optic system and the tube, and intubation was completed, and which was a traumatic. So you might ask, what is hybrid intubation technique? It is the use of a combination of orotracheal or nasotracheal intubating equipment with the synergistic properties resulting in a better intubating conditions. So you could use more than one intubating instruments. Hybrid intubation technique became very useful in the management of mainly complex airway managements. An example is a combination of video laryngoscope like a glide scope or a flexible fiber optic system along with that, which you have seen the last 2 cases how we managed to intubate those 2 patients without much of morbidity. Why is important? Why the hybrid intubation become an important matter to you? As we all know, the human airway structures are not in straight line, and the oral, nasal, and laryngeal and pharyngeal axis, they all can't be aligned. Even in a normal setup, it is difficult. So in a pathological or difficult airway management situation, it is even more complex. And also we know the anatomy changes from person to person, and also anatomy changes according to the pathology of the oropharyngeal airway. So all this add to the complexity of one thing is a visualization over the intubation. So we know there's no single strategy which will work for all the airway management or airway care. So we need to adapt to the changes. What do we know so far? We know video laryngoscopic systems are excellent to visualize the larynx. Especially the MAC blades are normally good, And the curved or hyperangulated blades are extremely useful in very anterior larynx, which you may not be able to see on a direct Macintosh laryngoscope. We also know flexible intubating scopes are useful and it saves lives and make a good your practice, make it easier in a tortuous and difficult airway situation. So there are instruments with particular properties which may be useful at particular instances. So why we still struggle? Yes, we do struggle. We all know that, even irrespective of the best laryngoscopic view from the video laryngoscopes, and irrespective of the ability to negate the oropharyngeal and laryngeal anatomical changes by the fiber optic system or flexible intubating scopes, still we have a problem. So when we struggle in this situation, why can't we use a combination of these two together and make the intubation condition much better way? So it is good to look at how the video laryngoscope make your visualization part of intubation easier, and what price you have paid for that. In a normal Macintosh laryngoscopy, you may be able to see all the grades 1 and 2, probably 3 and 4 you won't see the larynx, obviously. And then came the video laryngoscope, which enable you to visualize all the grade 3 and grade 4 Cormack and Lehane laryngoscopic view to grade 1 and 2. That means visualization made very easier. This is especially happening when you use the hyperangulated or very curved blades or deep blades or difficult airway blades, which is very much angulated, which helps you to visualize all the difficult larynx in an easy way. What price you paid for that one? You can see on the screen, there are two, the oropharyngeal angle in one and oropharyngeal angle, the other, the line in the other. By putting a hyperangulated blade through the oropharyngeal airway or oropharyngeal space in a difficult or anterior larynx, you created the oropharyngeal axis extremely difficult now. It could have been much more easier and streamlined, but now by the introduction of this hyperangulated blade, visualization easier, but the path to get there physically make it difficult. That is a change happened when the visualization became easier with the hyperangulated blade. The access to that part became more curvaceous. So hyperangulated blades has got some benefits, as we all know. It improves the laryngeal view. But we all know, because of the curve, because of the curvature here or the curvature here, you may not be able to compress the tongue mass. Without compressing the tongue mass, you cannot get a straight axis. You're going around that uncompressed tongue base. That's what we saw in my first case I presented to you earlier. So the hyperangulated blades induces a large oropharyngeal curve, or we call it, sometimes called as a primary curve. So the potential difficulty in tracheal intubation become more prominent. So we also need to know there is a disconnection we created through this hyperangulated blade in very anterior or difficult or complex airway cases. In the past, Macintosh laryngoscope provided you an easy laryngeal view, means an easy laryngeal access or orotracheal intubation. But here you have made the intubation and laryngoscopy slightly disconnected by the introduction of hyperangulated or difficult video laryngoscopic blades. So that disconnection needs to be looked separately. That means one issue is the laryngoscopy and the other issue is intubation. So you disconnect the concept of intubation into two parts, which was almost together in the previous or the conventional Macintosh laryngoscopy. Now you can have an easy laryngoscopy or laryngeal view, but you could have a difficult access to the airway because of this hyperangular or the curve we created by the introduction of the hyperangulated blades. So where the hybrid intubation come into this equation? Whenever you have airway visualization made easy by hyperangulated laryngoscopes, one part you are successful now is visualization. Now, by introducing another instrument which has got the flexibility to access to tortuous route, like fiber optic or whatever you call it, video intubating scopes, so any of those flexible intubating systems, we can combine the property of both to achieve successful intubation in difficult cases. So what's the solution? The solution is to continue to visualize within video laryngoscopes. That means almost all pathological and non-pathological airways by video laryngoscope. But we may not be able to get access to guide that tube to the right place. We can use flexible intubating scopes in combination with the video laryngoscopes. So to establish a definitive airway during the management of complex airway, the hybrid intubation strategy became handy and useful to you. Clinical advantages. What are the clinical situations where particularly you will come to value this hybrid intubation techniques? Mainly the complex airway cases where you can see but you can't get the tube. That's number one. And also the skill is important. In an experienced airway operator, any intubation situation, they can manage it. That's why they're experienced. But majority of us are not that experienced because we don't do airway list every single day. So those who are moderately skilled in airway management, sometimes the best of many would be better than the best of one single technique that make it easy for you to manage it. So what are the other situations where you can go use hybrid intubation? So technique, one is ET tube exchange in the operating theater or in the ICU, where you can visualize one tube is coming while we can see the other tube is going in over the fiber optic system. Even if you get stuck at the arytenoid, still you can manipulate and you know exactly where the problem is and we can act upon it. Say for tracheostomies, when you do the percutaneous tracheostomy and the surgical tracheostomy, you can visualize where the cuff of the tube by video laryngoscope orally, and while you can look it up the fiber optic system to see the subglottic structures as well. Panfacial fractures, where we need to tube exchange from nasal to oral, you can again use combination technique. Cervical fractures, normally we take the collar off, but there is no guarantee that we can immobilize fractured cervical vertebra. So in that situation, what you could do is keep the collar and use combination technique to manage the airway very well. If there's a blood in the airway, the the properties of video laryngoscope allow you to lift the structure up and suck and clear the airway, and then you can use fiber optic. As you come in, you can just visualize it through the video laryngoscope and advance the fiber optic. So in bleeding airway, this can be a useful combination technique like hybrid intubation technique. And the trauma, again, as I said, tortured anatomy, we don't know exactly where we are going. A combination of video laryngoscope and fiber optic become handy. So can you do hybrid intubation technique in any situation? Yes, you can. You can do under general anesthetic as I did in the child, and you can do awake tracheal intubation as I did in the other case I shown at the beginning. And also it is useful in intubation and extubation. During extubation, in one of the slides previously I showed you, we did the staged extubation technique by visualizing with the video laryngoscope and fiber optic to exactly to position that wire correctly. So what are the equipment we likely to use? We can use any form of video laryngoscope, that's one, or you can combine those with any form of flexible intubating systems. So for example, CMAC, very common, GlideScope available in most part of the world. AirTrack has been in practice for a long time. McGrath, Kingvision. So you can use any video laryngoscope as you wish. And again, Well, nowadays we have got disposable flexible intubating systems are also available from Ambu and Verathon as well, and many other companies. So you can combine these two categories together for the hybrid intubation technique. It is nothing new. Hybrid intubation technique has been in practice long time ago. So it's not a new entity, but now because we are using more and more video laryngoscopes and more hyperangulated blades, we can get into occasional trouble. So that stops you sometimes. Why I can't get it? Because that change in your practice can have room for this kind of a stuck situation. So this makes you to think, okay, a combination, a hybrid technique become more valuable. So it doesn't matter oral intubation, nasal intubation, or transtracheal, any approach you do, you can use combination hybrid technique. So it can be useful for nasal and oral. Is there any limitation for hybrid intubation techniques? I would say the available resources are not the same all over the world, and depends on which part of the country you are in as well. So resources limitations, one issue possibly. There may need more manpower, because you normally can perform a case yourself, but when you do hybrid intubation technique, you might need another skilled person to be with you. Sometimes your assistant may be able to help you, or you may have to get another anesthetist to help you out as well. So there is an involvement of an increased manpower. Teaching and training, obviously, there is nothing can be done without teaching and training. There's no shortcut, I'm afraid. That need to be good. You should be good in fiber optics and video laryngoscopes. And again, if somebody gets extremely trismus, limited mouth opening due to trismus, it may be difficult. So a reasonable mouth opening is also important. So in conclusion, hybrid intubation technique, when you take it forward in your practice, you need to know that few things. And every intubation system is successful and depends on the operator and the patient's condition. If you're an expert, yes, you can do well, but we are not in that position. Majority of them are usual standard practitioners. Combining the qualities of two or more intubating systems make the hybrid intubation as a useful tool in your practice. So you may need to be skillful and trained in more than one instrument. Resources are only limitation which we can see in this technique, why we can't do it. But again, that is a temporary or a time-limited factor. As we push forward for whatever you need for safety of patients, that can be made available. And also we know there's no one single system or one single tool which fit for all patients or airway situations. So in short, for a moderately trained operator, a combination of more than one intubation technique and adding one property of one instrument and with the addition of the other would be useful when you deal with difficult situations and make your intubation successful and a successful practitioner. Thank you very much.
Thank you. 3 golden topics in advanced airway management. Thank you, speakers. There are quite a few questions. I'll start with Dr. Mary Jo Thomas. And sorry, Mary, I pronounced your surname wrong. Sorry, apologizing.
No,
You're getting quite a few questions. So to give other speakers some chance, I will limit the questions to you and you might have to answer them on the chat. Is that okay? Yes. So the first question is, before that, wow. 60 seconds for a blind nasal intubation. That's like a sauna or a calm blue sky, you know? And the first question is, should fiber optic be chosen over blind nasal intubation in patients with altered airway anatomy, especially head and neck tumor, especially as SARS-CoV-2 is sensitive to sterilization, meaning fiber optic bronchoscope can be sterilized. So whether we should choose fiber optic intubation to blind nasal.
It's just the question of whether a fiber optic instrument is available in the COVID ICU. I think most of the COVID ICUs, I do not know, but how many of them do have a fiber optic is how the availability of the instrument is the question. So if you do not have an instrument, so you see the patient is desaturating, but he's awake. That's the usual scenario in a COVID patient. You could have him cooperate with you and use this technique. It is safe for the anesthetist and the patient. Have the tube in so that you can give some pressure support or any respiratory support that is needed. That is the whole idea. You need to think that there's an alternative way. If he's a difficult airway, you're not sure of securing his airway. So this is an alternative method that we need to think about in the COVID ICU. I do not, if you have a fiber optic awake, well, very good. Well, you can go ahead with it. But if you do not have, when there is a lack of resource, it's definitely a good way. You're not going to lose an airway by putting him to sleep and then, finding it difficult to intubate. Because that patient is awake and he will definitely, they do cooperate when they know that there is a need. And that's the only way that you can secure the airway. They do cooperate very well with you as long as you talk and, that's a safe way, definitely a safe way of securing.
Thank you.
Can I come in there?
Yeah.
But in our setup, we have actually moved complete to the disposable fiber optic scopes. So we just use the Ambu scopes. They're single use. Use them and they are easily available. So you don't actually have to actually get it from anywhere. They are on the difficult airway trolleys. And so you just use it and throw it away.
Thank you.
But the situation is not the same everywhere. So this is a method where such
the
instruments are not available.
Yeah. Cost is always a issue. That's always there. But I'll say that there are options available.
Yeah. Thank you. Dr. Rakesh?
So you said you will be asking.
Okay, so Mary, back to you. There's another question: how safe to use blind nasal intubation in COVID patient? You sort of explained that. And another question: can armor tube be used for blind nasal intubation? This is by Dr. Jaya Jacob.
Yeah. I personally do not use armored tubes because one of the contraindication for armored tubes is a nasal intubation because it has metal rings in it. And usually we use it when you're scared that the tube will kink. But in a nasal intubation, usually as of now, I have not had a problem with the tube kinking. And since it's less traumatic, I generally use the normal endotracheal tube, which is softened. And in case you need to use a tube which is of lesser size, then usually we retain the tube for 24 hours whenever it's a difficult intubation. So then suctioning becomes a problem. This tubes can get clogged with mucus. So it's better to use the ideal size tube for nasal intubation. And moreover, an armored tube, the tip is little floppy. Even for oral intubation, we use a stillet. So I think, though I have not used it, maybe it could be okay. But I think for these reasons, we usually don't use an armored tube. We just use the normal endotracheal tube, which is dipped in a bucket of hot water with the cover so that it really softens, and just take it out immediately before you're going to use it, because even the AC temperature in the OT can make it harder again.
Thanks.
So that's
Thanks,
how
Mary.
Meera,
yeah.
Can I come in?
Yes, please.
We have been practicing nasal intubation and a lot of work on blind nasal as well. And we love the ILMA tube because the soft, blunt tip, which is siliconized or silicon tip, is the least traumatic. It is in literature as well. The only problem which occurs, as Mary has pointed out, is that they are too floppy. But for that, she herself has suggested the technique that we use very often, that is cuff inflation. So the cuff inflation technique, makes it very much more easy to direct it into the trachea. That is my take on it.
shall we move on to Dr. Shiv and Jai, please?
Yes, you ask from Jay, then I'll
Okay.
ask Shiv and then we'll wrap it up.
Okay, Jai, the question to you is which position better for hybrid intubation, supine or sitting?
If you are performing an awake technique, it's always better to sit the patient up, and then you can perform both combination procedures in that way. If it is as patient in under general anesthesia, much easier for you two people to work together in a supine position with a slightly head up tilt. So it is just for practical reason. For the patient that's awake, better to be sitting in position. That's what we done in the first case. But it is for you to be practical, it's better to be supine with a head up tilt, because two people can stand around and work together.
Thanks, Jai. There's only 3 minutes left, so I'll hand over to Dr. Rakesh. You have more questions, Jai, but can you answer that in the chat, please?
Of course.
Thank you. Thank you.
Shiv very nicely summarized the whole thing about block, and you recommended combination of techniques for airway blocks and minding the total dose. The questions for you are, do the blocks increase the chance of aspiration by Navanita?
Absolutely. I mean, you have to, that depends on the duration of the surgery. So if you're doing an awake intubation using blocks, even for nebulization, if your surgery is going to be just say 30 minutes or 60 minutes, the effect of the local anesthetic is going to last for nearly 3 hours. So you need to be careful. For 3 hours, you do not feed the patient.
Okay. The second question is, are the invasive blocks obsolete? And secondly, are they, do they increase the risks?
Absolutely. I mean, if you look at it, there are simpler techniques. So if you look at the spray as you go or nebulization, they are far, superior in a way that they are less invasive. Now, if you look at described, you need 3 areas to be blocked, right? Glossopharyngeal airway, block is, well, like I said, that's the most dangerous one, especially if you're using a needle, you're next to the carotid artery. So intravascular injection. Also, you need to actually do multiple injections. You need to block both sides, right?
Well, I think
so you're doing multiple injections, so your risk actually increases.
So I think you summarized it very well when you said use combinations.
Yeah.
Where the injection is going to be more dangerous, we should definitely avoid it, especially in the light of AFI guidelines, which you just pointed out. Wow. Yeah. And which has given us a lot of spray doses which are available. Like almost 50 puffs. If only puffs were to be used in an adult, by 40 ml, you said, in a lady who was 60 kgs only.
It depends. The other thing is that not everybody has got 10% lignocaine. In our theaters, 10% lignocaine is available. It is actually kept locked. And you have to be very careful with that dose when you use for nebulization. The other thing is that one thing which combination one is the transtracheal injection. So that is still used. So you don't need too much. You just need 2 or 3 mLs of lignocaine, and it anesthetizes your trachea, as well as when they cough, they anesthetizes the vocal cords and the epiglottis. So when the tube goes in, the patient doesn't cough.
Can I ask?
Yes.
Do you use transtracheal during this COVID season? We have stopped because the patient.
No, I don't use anything. My technique is very simple. I use the lignocaine with phenylephrine for nose, and followed by the nasopharyngeal airway, which is actually loaded with lignocaine gel. And then it's just 3 syringes. I don't even use 4. 3 syringes, 2% lignocaine with 3 mLs of air in 5 ml syringe, and spray as you go. It's a very simple technique. But if you have got time,
transtracheal works very well. It really works well. But during this COVID pandemic, we are unable to use it. Otherwise, it works very well.
Yes, absolutely. I mean, nebulization was never actually considered as a, aerosol generating, because lignocaine will itself actually stop patients from actually coughing.
especially
So
when the
if you're actually nebulizing it, it actually stops patients from coughing.
So I think we are in the last minute of this session. Thank you very much, all the three speakers, Dr. Mary, Dr. Shiv, and Dr. Jay. It was a wonderful session and talked about something which now I think will give a complete picture of how to manage a difficult airway situation, whether you used to want to use hybrid technique or the blind nasal technique. We have Shiv who has blocked the whole airway for us. So we can go ahead with blind or multiple visualization as Jay has put it. And thanks Meera for joining all of us together. And it's a wonderful time that we have had. So have a great Sunday and wonderful sessions going on. Thanks to the organizers, Elizabeth, Sam, and Sajan. And it's a pity that we are not there at lovely location at Kochi, but hopefully next time. Kochi has this habit of getting under the deluge sometimes. It is sometimes drowned in floods and sometimes because of the pandemic. But I'm sure we'll be lucky next time. Thank you very much. Thanks a lot. Over to the organizers. Over to the organizers.
Okay. It's my next duty to introduce the next speaker. It's Dr. Dasan. I'm going to introduce Dr. Muhammad Islam Nasir. Dr. Nasir did his early training in anesthesia in Pakistan, and he developed the IGEL supraglottic airway device when he was working in the United Kingdom. And then he moved on to develop the VGEL, which is a veterinary supraglottic airway device. And in respect of his contribution, vast amount of contribution in the field of airway anesthesia, Dr. Nasir was awarded the prestigious McEwen Medal by the Difficult Airway Society in 2016. Dr. Nasir is well known to every single anesthetist, and he transformed our anesthetic and airway care. Dr. Nasir, an anesthetist, inventor, innovator, and an entrepreneur, continues to devote his life in the field of airway management. His wisdom and sense of innovation is going to shed some light on the future of airway management. Dr. Nasir, the floor is yours.
Good afternoon, everyone in Kochi. Thank you, Sajay. Thank you, Jay. Thank you, Elizabeth, for inviting me into this exciting but in a difficult times. I'm sorry, I wish I was there and I could have been there, but the time are very unprecedented and challenging. Let's kickstart. Sajay gave me this topic of the futures of airway management. And I thought that was something very close to my heart. And I found myself very excited with it. And let's kickstart just from disclaiming that I'm the inventor of IGEL, VGEL, but in this topic, there is no conflict. I'm sure you understand. I work with Intersurgical and Doxynovant on research and development. I also chair a charity called Life to Life, which is registered in UK as well as in Pakistan. I just want you to just step back and think that the patient do not die because of the failure of intubation. Okay, they could die, but most of the time we rescue them. But they really die because of failure to oxygenate. The airway has been very well understood to some extent, to large extent, to really perfect extent, from mention of its in the Old Testament to, sorry, my screen has suddenly got something. Old Testament to Aristotle describing epiglottis, vocal cords, and trachea, to Alexander the Great saving one of his near-dead soldier by slitting his neck, Hippocrates, intubation, devices, adjuncts been created. A lot of work has gone in to make that one part of which we understand, to get the air into the patient, to oxygenate the patient, to have a safe airway, to supraglottic devices from early 90s till today, including iGel, intubation adjuncts, laryngoscopes, video laryngoscopes, you name it, to fiber optics have been our armamentarium in the operating theater, which really help rescue the patient. But imagine God has created human body, a very complex structure. I remember we just actually try to understand and rescue this area. But having said that, remember, the whole body is not very largely understood. And even in my view, this area is still not very much understood. We think we know it, but we don't. And I usually say, more I know that I don't know. So it needs exploring further, and a lot of things are being done to understand it largely, to understand how to get into this hole safely and properly. So I go back to again the same slide saying that the oxygenation is more important than a failed intubation. Intubation could be achieved quite easily, but the other things are more important too. NAP4 has put another, in my view, a big plunger, a big spanner into the back of anesthetist and us clinicians who care for our patient's airway. We know very clearly, and we have seen, I'm sure, in our lifetime, that when we are intubating, a big well behind it would start welling up. And if it goes into the lungs, you know, and I know what happens to it. But also, particularly, if you Google silent aspiration, I think that's the even bigger killer, bigger comorbidity, which actually is caused during our anesthesia events. And it happens quite clearly. I'm sure you have heard this lecture of Professor Tim Cook.
It's not in the presentation, but deaths, this is a paper that Aidan gave me, my mentor. Deaths associated with anesthesia. 1956 anesthesia, a report on 1,000 cases by Edwards, Morton, Pask and Wiley. Commonest cause of death during anesthesia, aspiration of gastric contents, mainly associated with hernias. Having my left hand, a report from 2011. Airway complications. Commonest cause of death during anesthesia, aspiration.
So aspiration has been labeled as a single most common cause of death during anesthesia events. And this is not me calling it. It was a study by Morton, Pask and Kiley back in 1956, which started in 1949, published ultimately in 1956, where it was very commonly seen that aspiration was the common cause of death during anesthesia events. And in almost 55 years, in the report of NAP4, again, aspiration being the single most common cause of death during anesthesia events. So have we really done much, or have we really improved on the airway management, if you really call it? We have been talking about difficult intubation. We have been accomplishing difficult intubation, but have we really put our emphasis on the aspiration? Yes, there have been a lot of aspects which have been ironed out from pre-operative preparation of a patient, knowing that he is full stomach or is symptomatic with regurgitation prone symptoms. But when aspiration happens, it does happen mostly in non-symptomatic patients, especially in intensive care. In operating theater, procedures more than 5-6 minutes, 10 minutes, aspiration is bound to happen. Okay, I understand there are difficulties we face in certain manners of having a difficult airway, but really other factors also come into play. So what are the sort of future developments happening? we have to think out of the box to really address this complex issue or a complex problem. There have been a lot of work done on virtual laryngoscopy and bronchoscopies, where you can look at the hardware, look at the software quite clearly and help. I wish I had more time to actually go on each aspect in more detail, but you can actually Google it, find it, and these references, and I'm sure you will be able to go into further detail of that. I have to finish this within 15 minutes. Also, 3D imaging of the computed tomography, that does help in assessing the difficulty in the difficult intubation scenarios, patients like Treacher-Collins syndrome, like Golden Horse syndrome, and see exactly how the airway lies and what difficulties you face really. Cone beam is another one. Cone beam computed tomography also is an innovative tool in the assessment of the airway, which also gives you all the hardware from the software, and you can play in between and see exactly how your airway looks like. And you can separate soft palate, tongue, airway shapes, and the airway caliber could be assessed quite easily. So those areas are also developing in a big way. So look in this picture, for example, the comparison of a normal oval airway shape in a 32-year-old healthy male on the top with an abnormally round shape in a 52-year-old male with obstructive airway symptoms. Similarly, 16-year-old male here, female here with a history of obstructive airway symptoms. If you look at the top 2D image of an apparently normal airway, but if you look at the bottom one, just at a 1 centimeter cut, lower showing an incomplete airway occlusion. So these kind of technologies are very helpful and very useful in assessing. I'm sure you must have heard Kepler intubation system. This is another adjunct coming probably in our theaters, helping in difficult intubation or normal intubations, where you can use the Kepler arm to be able to intubate the patient instead of you intubating the patient. Facial image analysis for a fully automated prediction of difficult endotracheal intubation. I mean, facial recognition is a big thing all over the world from security perspective, even in UK, Europe, USA, Dubai, everywhere. I say just to recognize criminals and things, but it's actually also being advanced to use to predict a difficult airway. Also, it's pretty easy to have a dimensional areas and be able to predict the difficult airway. I'm sure most of you use ultrasound and are using ultrasound and could easily assess the airway, largely the upper airway, in many dimensions and directions. It's been used, I think, since almost 2010 and 9 onward, and it's also developing further. Further techniques are being developed. I'm sure you know this big data thing from Google, visual analytics in anesthesia and healthcare. So essentially, those data are being also put on the side through this big data of all the 7 billion people on this face of Earth, are those people who go through difficult airways. And nowadays, people traveling across the world, what if they meet an emergency or need of anesthetic, and their data could be quite easily accessed with all the confidentialities intact and to all the clinicians all over the world. So those things also very helpful. I'm sure you must have heard and seen videos and on the YouTube where acupuncture anesthesia, but in a very selected group of patients are being done. Even major surgeries like sort of tumors, thyroid, I've seen also cesarean section being done, even open heart surgery being done with acupuncture anesthesia, but it's in a very selected number of cases. But I know Chinese are working very hard in improving those acupuncture techniques to be able to use the acupuncture on each and every patient, but that has not been achieved. But they're working very hard on that as well. I personally feel it will be unfair if I don't mention the new drugs development, which essentially the mainstay of their changing. I mean, I wish again I had a time to go through each drug one by one, but essentially each of the drugs, pharmacokinetic and pharmacodynamics are being changed. And those are actually just to make them CNS safe, with the intense analgesia, with least respiratory depression, or the preferred is the no respiratory depression whatsoever. And the patients are intensely analgesed and relaxed. They're breathing fine, like acupuncture anesthesia, if you like to call it, but no pain. So in that respect, all the hypnotics, even propofol analogs, midazolam, mesalam, etomidate analogs, carboetomidate, xenon, ketamine, remifentanil, dexmedetomidine, clonidine, you name it. There are a lot of work going on, especially on synthetic ultra short-acting opioids, as I said again, to take it is like dissecting the hair, essentially taking the bad effects of, sort of from D-isomers to S-isomers, and just dissecting their better half than the bad half, taking that away and causing the mainstay is to cause an intense analgesia, least sedation, hypnosis possible, and without respiratory depression. That's the take-home message. So those things are developing, and they're developing big way. And this is also a very interesting one, that using the current or the new drugs with the closed loop systems for hypnosis or even anesthesia. So models, different computerized machines are being created, which will deliver as and when required basis, so that a certain type of infusion continues till it's needed, whether in operating theater or whether in intensive care. But in my view, close to my heart is this nanoparticle technology of engineered micro particles carrying oxygen. I think this is the ultimate in my view. If they can manage it, there's a lot of work going on this. I wish I can learn my A-level mathematics and further the way they are creating this. It's like oxygen in a bottle. So it's injectable oxygen essentially. And if you can't intubate the patient, you sit tight, just inject into the patient and wait till Sajay or Jay comes around and helps you rescue the airway of the patient. So that's in my view is ultimate. But meanwhile, you continue using iGel and happy days. I'm not sure whether the iGel or the airway adjuncts, intubations, and other supraglottic devices will go out of fashion, but it will continue. But keep saving lives, guys, and iGel still is being used pretty widely everywhere. But my last word, please be careful with regurgitation, especially silent aspiration is really a bad thing. And I usually recommend and say, if you are in a worry, especially an intubated patient, please put a throat pipe around. And have a wonderful day and happy belated Happy New Year to all of you. Thank you.
this was a keynote session. It wasn't supposed to have a discussion after. Thank you, Dr. Nasser and Jay. That is a very informative session. It is my pleasure to introduce the chairs for the next session. That is Dr. Gunjit Dua and Professor Sheila Maitra. Gunjit is a consultant in Guy's Hospital in London. She is the co-director of the well-known Guy's Airway Management Conference, which is incidentally going to happen next weekend. She's the clinical content lead for the RCOA web events, and she's also the training program director for South London, and she is involved in developing multiple courses focusing on airway management and human factors. And you already have seen Professor Maitra. She is the president of All India Difficult Airway Association and the vice chancellor of Indian College of Critical Care Medicine, and also the secretary of the Indian division of the International Nosocomial Infection Control Consortium. Over to you, Gunjit and Sheila. Thank you.
Thank you very much, Dr. Sajay, for that very kind introduction. I now request Gunjit to go ahead with the session.
Thank you. Thank you, Sheila, and thank you, Sajay, Ellen, and Elizabeth for the kind invite to this meeting. And I think I echo everyone's sentiments since morning that we miss meeting everyone, but we'll have to carry on this way for the time being. So I won't take long, and again, take the pleasure to introduce our colleagues from UK for this, looks to be a great session in the contentious times, where we will be covering current evidence on aerosol generating procedures, obstetric airway management, and above all, human factors. So first, I would like to introduce Krish, and Krish has been a colleague since long here, and we have always seen him very enthusiastically teaching at lots of airway management courses. Krish has been a consultant anesthetist in UK in 2000. He was honorary secretary of DAS and organized a very successful Difficult Airway Society meeting back in 2014. He was a working party member for Infection in Anesthesia Working Group, which was recently published in 2020. And Krish will be enlightening us today on the current evidence based in aerosol generating procedures. Thank you, Krish. Over to you.
I would like to thank the organizers of Kaamcon for inviting me to do this talk. And also thank you for the very kind introduction. We shall look at the aerosol generating procedures and the current evidence base for it. So the learning objectives are, we look at the definition and we shall look at the respiratory system, a quick recap of what we studied many years ago in medicine, learn something about the COVID-19 virus, look at the guidelines, and also discuss the physics and how we can protect ourselves from this virus. The definition of aerosol generating procedure comes from the World Health Organization section on high-risk aerosol generating procedures. And we shall look at all the procedures that can cause aerosol generation and the level of evidence that we have for each one of those procedures. This is a detailed document by the World Health Organization published in July 2020 and is the backbone for many other subsequent publications that came out. This is a section that focuses on aerosol generation procedures in detail and also on transmission of the virus. And as you can see, this particular document that came out on 16th of October 2020 has looked at detail, and what it has done is reviewed nearly 5,000 results, focusing on 367 relevant articles, and they have tried to identify the important procedures that can be classified as aerosol generating procedure, and look at the evidence base. What is the evidence for calling them high risk for transmission of the infection? This is an interesting article as well, in great detail from PHE, and for greater detail of the topic, I would recommend you consult this document. Let's look at the respiratory system and how it protects us. It has several functions. Most importantly, the upper airway protects against aspiration, humidification of air, heats up the air from colder atmospheric temperature down to the body temperature of 37 nearly, filters off the dust particles. This is an important part, and we shall look at it in a bit more detail soon. It also has an immunological function because there are macrophages guarding the alveoli that remove any dust or unwanted foreign body that comes to the alveoli. We breathe a number of polluted particles that are out there, and some countries like Japan and China and Indonesia and many parts, we have seen people wearing masks well before the pandemic hit the world. So there was almost a routine practice for these countries to use masks. And there is a good reason behind it. As you can see, there are numerous sources and sizes of airborne particles. For example, we have pollen, which is about 10 micrometer in diameter. You have clay particles, tobacco smoke, smog. All these are tiny particles that are hanging in the atmosphere, and we can easily breathe them in and bring them into our respiratory system. So they are there in the upper airway. In fact, is very protective, the nose, the mouth, and all that. They have a system where it actually picks up they pick up most of the foreign particles that travel towards the lung, and they are removed. Whereas particles that are larger than 100 micrometer, they are not typically drawn into the body by inhalation because of their size. They often get removed. Whereas particles less than 100 micrometers, say from 10 to 100 micrometer, they have to encounter the twists and turns of the airway system, and they get deposited and they do not travel very far. However, particles that are less than 10 micrometer can actually make their way into the bronchioles and where they are down almost to the alveoli. But however, they have come up with the macrophages which pick them up and remove them from our system, protecting us further. Smaller particles that are less than 100 nanometers would actually get as far as the alveoli, and they may even escape the macrophages and can potentially get into the circulation. This is relevant because the SARS virus is in the diameter of 60 to 100 nanometers. So if it gets past and gets into this wide area of lung, which is nearly 100 square meters, I'm told, if the virus gets into that vast area, it has the potential to get in and establish itself. So this is the virus, 60 to 100 nanometer. As you can see, the bacteria is 1 to 2 microns, and there are other viruses that you see that are slightly bigger, but the coronavirus is a much smaller virus, 60 to 100 nanometer. They are bigger than Zika virus and parvovirus, but 60 to 100 nanometer is a significantly smaller virus to travel in towards the lungs. So this virus travels because once through droplet infections, which has the diameters of 5 to 10 micrometer, and when we sneeze, the droplets come out, about 40,000 droplets come out in a sneeze at a speed of 100 meters per second. In a cough, 3,000 droplets come out at a speed of about 50 meters. And as these droplets hit the atmosphere, they break down into smaller particles, which we call the aerosols, and they can travel farther. Some people call them droplet nuclei, which is a very good term to describe the aerosol, because having discarded the peripheral epithelial cells and structures and saliva going through dehydration process, the aerosols, they carry the core of the infective material. They can carry a number of viruses in them. In winter months, the air is thicker. So when we cough into during cough or sneeze in winter, the sneeze and cough that comes out confronts air that is thicker. Therefore, they have a greater chance of aerosol production. Therefore, infection is more common during winter months. In summer months, the air is rarefied, and therefore infection is less, because the droplets, they tend to dehydrate and move up towards the hotter part of the air, and they also do not produce as much aerosol as would be possible in winter months. The transmission of the virus occurs through droplets, through aerosol, and also because the virus has been coughed out on various fomites like the board, the work table, and then if we can actually carry them on gloves. So it's very important to stop the transmission of virus from fomites. We must wear gloves, wash hands repeatedly, and make sure we are not leaning on things or shaking hands or touching face. There's also proof that the virus can make its way into feces and urine and may also into the blood. But this currently looks like a very doubtful route of transmission of the virus. So aerosol is produced by talking, singing, at gym when people are straining, coughing and sneezing, of course, as we had discussed earlier. In closed spaces, when this is generated, it travels in air currents and can go a distance. So, for instance, it has been shown that a person in a closed room sitting nearly 4 to 6 meters from two other individuals, when he was there for about an hour, he could actually transmit the virus to the other two, though they were sitting quite a distance. This is because over a period of an hour, small aerosols build up and generated in a room and tend to travel and cause infection. So though there is much to show that the aerosol is generated by speech, singing, and coughing, and that the important point to bear in mind is that duration is an important factor. A person who's been talking for nearly 5 minutes may produce as much aerosol as would be produced during a cough. The list of aerosol generating procedures from the PHE, or Public Health England, that is based on the World Health Organization, lists all these as aerosol generating procedures. Those that are in red, like the tracheal intubation, manual ventilation, and tracheostomy, and also the non-invasive ventilation, they have colored them in red because there is evidence to show that these are definitely aerosol generating. Those in yellow, like bronchoscopy, have weak evidence, and there is no evidence to show currently that the blue, those in light blue, are aerosol generating procedure. However, the PHE and the World Health Organization have recommended that we take full precautions when we are dealing with these, and therefore they are listed as aerosol generating procedures. The lack of evidence does not mean that transmission does not occur. The reason is many, since the pandemic, have been wearing PPE. Therefore, when people are wearing PPE and protecting themselves, it is hard to quantify and prove that these are not aerosol generating procedures. Therefore, PHE and the World Health Organization have recommended that we treat all these procedures as aerosol generating and take adequate precautions. Aerosols have been generated by uh, perfumes and by various other things like the nebulizers and Tanox. So aerosol is sometimes generated for benefits. Particularly, a nebulizer can carry the drug into the alveolar space, but because the aerosol is generated from outside the human body, it does not cause infection. And also it breaks down to tiny particles that travel with less force into the airway. Therefore, they do not agitate and bring down infective particles. So these do not cause infection. Entonox, nebulizers, and humidified oxygen are not aerosol generating procedures, though they themselves are aerosols. Here you can see that the compressed air in a nebulizer, this is a cross section of the nebulizer. You can see that as it comes up, it travels up, hits the baffle, and the aerosol goes into the patient, and it gets into the patient very quickly at about 200 to 400 micrograms of the 2.5 milligrams of solubutamol that we give gets to the patient. Only a small fraction gets in. A large part of the drug gets deposited in the nasal airways and the upper airways, but a small portion of the aerosol gets all the way to give the patient the benefits of the drug. And therefore, this is unlikely to bring out the virus and cause a problem. And this slide shows the difference between the medical aerosol, which I have just discussed, and the aerosol generating procedure that we have discussed as well earlier. So physics of aerosol. They have to obey two theories, the kinetic theory and the Brownian movement theory. So in the kinetic theory, all the particles are constantly in motion, particularly the smaller one. We know about the molecules in motion in a gas chamber, and that's what causes the pressure on the walls of gas. We know that as anesthetists, so that is easily understood. But also the biological particles like the bacteria, the virus, and also the pollen grains are constantly moving. And this is called the Brownian motion described by Robert Brown in 1827, and he showed how the pollen grains are moving in a solution. So you would expect that if the particles are moving, you cannot expect the viruses to sit quietly along the mucous membrane as shown in this picture, but they would rather be moving around in this particular fashion, moving in and out with the breath, and also they are all around the patient when the patient is talking, and potentially they can travel by airwaves in different directions. Some of these aerosols, diameters 4 micrometer, can hang around according to this research paper where they use light scattering, high sensitive laser light scattering. They found that these may actually, though not visible, may hang around the atmosphere for 8 to 14 minutes. The aerosols might be there. So this is an interesting paper to read, and therefore also confirm that substantial probability that normal speaking causes airborne virus transmission in confined environment. This particular study was a very good study which looks at droplets, aerosols, and how they may be transmitted. Here is a droplet, and it has got a central part of it, which is made up of saliva, mucus, epithelial, various types of cells, and also harbors fungi, virus, and bacteria. So this particular droplet, about 5 to 10 micrometer, when this is coughed out, like we see here, it comes up against the air and breaks down. And at the periphery, you can see here that it actually becomes aerosol or droplet nuclei, which will carry the virus. The droplets themselves tend to gravitate down and move. And as they move, they become smaller and smaller, as shown here my wall in 1955, that we see that as the cough comes out, this is the time from 0 time, about particles that are less than 100 micrometer, they do not reach the ground. And up to 140, you can see they have rarely reached the ground. A lot of them tend to become aerosols, and then they stay in the atmosphere. Only larger particles that are about 200 micrometer, they tend to become smaller, and they may end up hitting the ground. Therefore, up to 2 meters, the larger particles can travel, but the rest of them can become aerosols and be hanging in the air for some time, and may even travel through air currents. Here is an infected person who has a sneeze, and you can see that a sneeze, a lot of the droplets may tend to gravitate down, but a generation of aerosol also occurs at about the same time, and it tends to travel like a cloud, and there could be a considerable amount of these, nearly 40,000 droplets come out in a sneeze. In a cough, about 3,000 particles come out, and you can see that they also produce some aerosol, and then some of them gravitate down. Same is the case with simple breathing and exhaling, which also produces enough aerosol that can infect. If that person stays in the environment for sufficient period of time, he may be breathing out a lot of this aerosol that can cause infection. Wearing the mask is the key to avoiding the problem. And this has to be done along with all the good PHE guidelines of standard infection control precautions, and also the transmission-based protocol that came out, which talks about hand, space, face, and of course, the PPE that we're going to talk about. There are different types of PPE that are available. People have been using homemade cloth masks. It gives some protection, if nothing. At least it stops the individual from spreading virus outside. It gives about 40% protection, but that's not good enough. The surgical face mask can give up to 80% filtration, but unfortunately, there are leaks around the surgical face mask, so it is not as effective when you're dealing with a patient who is actually COVID positive and you are within 2 meters of the patient. So we have to depend on more efficient face masks, and this would be the FFP2 mask, which filter about 95% effective, 25 times more effective than the surgical mask, and they're about 50 times more protective than homemade masks. The ultimate one, the FFP3, 99%, particularly when they're fit tested, are the best masks to use in this crisis. And I personally always go by the FFP3 mask. I always use a visor or goggle, and also fluid resistant gown and gloves for every aerosol generating procedure that I undertake without fail. There is no substitute to safety, and we have to be cautious while dealing with airway generating procedure. A paper came out from Bristol, which claims that anesthesia procedures may generate fewer aerosols than presumed study suggests. I do not question the validity of this, but in this crisis, I would like to say that I would not like to follow this particular guideline or this particular research outcome. I would not like to use it at all. The reason behind, there are so many unknowns in this complex situation that people who approach a patient who could be COVID or suspected of COVID, if they do not take sufficient precautions, can potentially get infected. So there has been a lot of pressure on hospitals and on management to get the cases done. And in this complex tug of war between efficiency and safety, sometimes safety is under threat. So this is a controversy. My belief is please always use PPE while dealing with aerosol generating procedure. So for this controversy, I have put together a verse which says what I am trying to say in just 4 sentences. It's a game of chess between commerce and science, where we side and wish good science to win. But commerce finds ways facts to undermine and owns the chessboard and pieces therein. In conclusion, hand, space, face, absolutely vitally important. PPE correctly, put it on and remove it correctly. Practice, learn how to do it correctly. Because even if you use PPE, if you take it off badly, you can end up infecting yourself. Risk assess patients green, amber, and red. This is important to do in every hospital. Use fluid resistant gowns, FFP3, eye protection, gloves in all AGP procedures, whether green, amber, or red. Just use the AGP completely. And that is the recommendation that we have fallen back on with this new variant hitting UK. And the reason behind that is there are just too many false negatives, an increasing number of silent carriers. Almost 1 in 3 may be silent carriers, it is predicted. And of course, if you're dealing with airways, video laryngoscopes are preferred, and this slide shows why, which I recommend. And of course, and there is one more slide which I added for you to look at. This is about how to deal with cardiac arrest. Thank you.
Thank you very much, Dr. Krish, for a very interesting and informative lecture on aerosol generating procedures, the current evidence, You've given us very practical tips, and I really like the verse that you ended with. Thank you so much. I'm sure there'll be a lot of questions that we'll take in, at the end. Without any delay, we'll move to the next presentation. And I'm very happy to introduce Professor Mary Mushambi. Professor Mary Mushambi is the honorary consultant anesthetist in the UK. She's also the Difficult Airway Society DAS Professor of Anesthesia and Airway Management. And she's also the Associate Director of the University Hospitals of Leicester, UK. And there's a whole lot of things I can say about Dr. Mary Mushambi. But one thing I'd like to say is today we're on the 17th of January. And I can say that Dr. Mary Mushambi, I've already, this is the third presentation I'm seeing her deliver in India. So I can tell you that she's really a very popular figure in India and very loved by the people here. And who better to speak on this topic? She's an expert in obstetrics, and she's going to be speaking to you about obstetric airway in 2021. Over to you, Professor Mushambi.
Good morning. Thank you, Sajay, and the organizing committee for inviting me to speak today. I'm delighted to be part of your faculty. I'm going to be talking about obstetric airway management, and I thought I'd cover three topics. I thought I'd look at rapid sequence induction in the obstetric patient to see how can we modernize the obstetric airway management. And then I'm going to look at how to manage a pregnant woman with an anticipated difficult airway. And lastly, I'm going to talk about a controversial topic, which is this suggestion of using a supraglottic airway device as the primary airway device for elective cesarean sections. Okay, so you might ask me, why have I selected to talk about rapid sequence in the obstetric patient? Well, the reason is when we look at the obstetric airway morbidity and mortality statistics, there's no doubt about it that obstetric airway management doesn't fare very well. For example, if we look at the incidence of desaturation during rapid sequence induction, obstetric women desaturate to less than 90%, 10% of these women do that. Less than 95%, 20% of the women desaturate. This is not good, particularly when you compare it to the non-obstetric patients. Similarly, if we look at other statistics, we know that incidence of failed intubation is higher. We also know that the incidence of front of neck is higher than in the non-obstetric patients. And if you fail to intubate, the chances of needing a front of neck is 1 in 60. The chances of dying after an obstetric general anesthetic is also higher. And if you fail to intubate, the chance of that woman dying is 1%. This is quite alarming, and we need to do something about it. So what can we do about it? Well, you know that in 2015, we published the obstetric failed intubation guidelines in the UK. And one of the algorithms that we included was the safe obstetric general anesthetic algorithm. And the reasoning behind this algorithm was really to modernize obstetric airway and general anesthetic, and also to use it as a standardized teaching tool. We can use this in simulation and make sure that our anesthetists are following all the items put in this safe obstetric general anesthetic algorithm. I haven't got time to look at everything, but we'll look at some of the salient points that are in this safe obstetric general anesthetic algorithm. So if we start at the top there's several things that we can look at. For example, intrauterine fetal resuscitation is a very simple way of improving placental flow when you have that fetal distress and you're rushing down to theatre. Simple measures such as changing positioning, giving oxygen, etc., can improve the condition to such a state that it takes away this pressure, the panic, and you might even prevent doing a general anesthetic. The next stage is the checklist. We know that the WHO safety checklist improves safety. Well, we've gone a step further and introduced a general anesthetic checklist specific for obstetrics, such as this, which we use in our hospital. And what we do is that you do this when you're pre-oxygenating the patient and your assistant asks you the questions as anaesthetist and you answer. And it looks at things like preparing the patient, simple things. Is your cannula working? Have you given antacid, etc.? Have you got your equipment and drugs? Are they all checked? And how have you prepared for difficulty? What is your plan B if things go wrong? What is your plan D? If you fail to intubate, are you going to wake this woman up or are you going to proceed with surgery? And to answer that, we use the table 1 from the difficult airway guidelines, where we know that 7 of the 9 factors that are required for this decision are there before you put the patient to sleep. So make that decision at that time, rather than leaving it till you've got things going wrong and you've got failed intubation going on and you're trying to make a decision. So let's look at the rapid sequence induction technique and some of the things we've recommended to try and improve safety during this period. Starting off with the simple things like positioning. There should be no pregnant woman going rapid sequence induction lying completely supine. Put them head up. Very simple. It improves airway management. And then we should be taking all the measures to improve oxygenation and avoid these patients becoming hypoxic during rapid sequence induction. And they're all listed here, and we'll look at some of them. Let's look at the first one, mask ventilation. Previously has been discouraged because we're worried about gastric insufflation. But in fact, studies show that if we reduce the peak inspiratory pressure to 20 centimeters of water and we've got correctly applied cricoid pressure, we don't have gastric insufflation. Therefore, please use mask ventilation because it prevents hypoxia. Another simple procedure, apneic oxygenation, something that was regarded as an old technique and it's having resurgence and makes a difference. Using simple cannulas such as this and providing low flow oxygen, 5 liters per minute before the patient is asleep. And as soon as they're asleep, increase it to 15 liters per minute and make sure you've got a patent airway. It gives oxygen during that period when you're doing laryngoscopy, when you've got a difficult airway. And of course, if you have extra money, you can go to the high flow humidified nasal oxygen, which we know that in the non-obstetric patient has an important role in increasing the safe apnea period. Now, there's a bit of question mark in obstetrics where there are 2 studies which are here, which showed that in high flow humidified nasal oxygen does not perform as well as mask pre-oxygenation during the pre-oxygenation technique. But this is by judging at the end tidal oxygen levels that are achieved. Unfortunately, the whole pre-oxygenation technique is not just looking at the oxygenation technique, the pre-oxygenation. There's also the safe apnea period. And this is where high flow humidified nasal oxygen is very beneficial and we should be using it. Moving on to the drugs we use for induction, the debate between propofol and thiopentone. As far as I'm concerned, if we look at all these positive things of why we should be using propofol, there is no debate, and we should now be using propofol instead of thiopentone. Unfortunately, in the UK, for some reason, between 60 and 70% of anaesthetists are still using thiopentone in obstetrics. My question is, why? What about the debate between succinylcholine and rocuronium? Well, this is a debate that's probably going to continue for a bit longer. And the reason is these 4 reasons. The first one is anaphylaxis risk. We know that succinylcholine has the highest incidence of anaphylaxis. But if you look at outcome after a rocuronium anaphylaxis is much worse off than with succinylcholine. The dose of succinylcholine, easy to calculate. But with rocuronium, do we use ideal body weight? Do we use lean body mass? More difficult to calculate. Can you imagine trying to calculate a dose for rocuronium when you're rushing down the corridor with a category 1 cesarean section with a patient with a BMI of 40 or 50? Not easy. If you use rocuronium for rapid sequence induction, then sugammadex has to be available for reversal. And this has cost implications. If you use succinylcholine and you have a failed intubation, the times you're going to be doing your air manipulation is when your succinylcholine is wearing off. And of course, you may end up with laryngeal spasm and get into worse trouble. So as you can see, there's pros and cons for each of the two, which is why in the UK, 92% of anaesthetists are still using succinylcholine. Therefore, this debate will continue for a little bit longer. What about video laryngoscopes? Should we be using video laryngoscopes or Macintosh in obstetrics? And again, I don't think there's a debate here. Video laryngoscopes, we know they give you better views, higher success rates, fantastic teaching rules, and as far as I'm concerned, they should be now the first line in obstetrics. But we have to make sure that firstly, they are available on the lay boards and that we're teaching our trainees how to use them so that they feel comfortable to use them as first line laryngoscope. Let's move on to my next topic, which is how to deal with the pregnant woman with a difficult airway. Now, the reason I brought this up is because we've just published this narrative review where we looked at over 150 published cases of pregnant women with anticipated difficult airway. And what we found was that the technical skills required to manage difficult airway are no different to when you're pregnant or not pregnant. But what is different are the decision-making tools. That decision of, if you have this patient with a difficult airway, are you happy to allow them to labor and know that you may have to cope with the difficult airway in the middle of the night? Or do you bail out and go for an elective cesarean section? If you go for an elective cesarean section, are you happy to do a regional anesthetic, knowing that there's a chance you may need to give a general anesthetic intraoperatively? Or do you bail out and go for a general anesthetic at the beginning? If you go for a general anesthetic, do you do an awake airway or an asleep airway? And of course, we have the unpredictability of the pregnant woman presenting at any gestation or at any time of day and night. And of course, the obstetric related pathology, pathophysiological changes in obstetrics may affect airway management or even affect the airway itself. So when we came to giving some recommendations in our review, we focused primarily on this decision making and brought out this decision aid overview, which gives you guidance on how to manage a pregnant woman with a difficult airway. And in it, we also gave you decision aid 1 of how to deal with a patient who we have to make a decision. Do we go for an elective cesarean section because we're worried about the airway, or are we happy to allow her to labor? And lastly, we had a decision aid 2 to help with that decision of, do we go for an awake airway or an asleep airway if we need to give a general anesthetic in this patient? Now, to give you some idea of the kind of patients that I'm talking about with a difficult airway, this is an example. This is a lady who presented at 36 weeks, having had an eclamptic fit and bitten her tongue, and this is what her airway looked like. And on top of that, she also had low platelets. So what anesthetic would you give to this lady who needs an emergency cesarean section? And they gave a spinal anesthetic, which is quite understandable. But the next question is, what would you do if she required a general anesthetic intraoperatively because she was bleeding? Good question. Another kind of case we had, this is kind of common finding of patients with congenital syndromes. Not only did they have a difficult airway such as this, but they also had a difficult spine and therefore would be a difficult regional block. Patients who are pregnant often want to protect the babies and refuse treatment. And this is a patient we had who had Hodgkin's lymphoma, who presented to us and then refused treatment and disappeared to follow up, and then presented back to us again at 33 weeks with stridor and completely narrowed airway and needing emergency delivery. Another epidemic that we're having on our labels, which is the morbidly obese patients. And we have to decide at what point do you feel comfortable for them to go through labor and be able to cope with them in the middle of the night? Or when do we bail out and go for an elective cesarean section? So these are the kind of cases that I'm talking about. So let's go through some of the decision aids that we have put forward. So this is the overview of how to deal with a pregnant woman. So we want our colleagues, our obstetricians and our midwifery colleagues, to identify these patients and refer them to our clinic, our anesthetic clinic, where we then do a thorough airway assessment, and we have to make a decision of, do we feel these deserve a multidisciplinary meeting where we then have to decide the mode of delivery and timing of delivery. And this then helps us to decide, are we going to allow labor, or are we going to go to an elective cesarean section? If we go for elective cesarean section, are we happy with the regional anesthetic, or are we going to go straight for general anesthetic? If we go for a general anesthetic, are we going to secure the airway asleep or awake? And there's two steps which are really quite challenging. And the first one is that decision of allowing labor or elective cesarean section. And we put this in a little bit more detail in the decision aid 1, which I'll cover just now. And the next stage is this, where you have to make a decision between a secure the airway awake or asleep. Now let's look at decision aid 1, which is that question. You have this pregnant woman, a bit like the ones I've mentioned, and you want to decide, are you going to allow labor or cesarean section? And the question you have to ask yourself is, can safe airway management be achieved out of hours in this patient? And to do that, and to answer that, you have to look at 3 things: the clinical characteristics of that patient, the airway pathology, the obstetric history, their state. Can you do a regional block in this patient? If you need to put to sleep, do you need to do an awake airway in this patient? Do you have the equipment available for this patient on your labor ward 24 hours a day? Do you have the personnel available in your hospital 24 hours a day? And if you think you can safely manage that airway out of hours, then by all means, go and allow the woman to have labor. But you might consider to induce the patient, so she's being managed on a specific day with everything set up for that woman. But that labor needs to be actively managed. We want a good regional block, everybody communicating and monitoring the progress and preparing as if you may need to go to theatre in that patient. On the other hand, you might decide that safe airway management cannot be achieved in this patient out of hours, and you bail out and you go for an elective cesarean section. Now, some of these decisions cannot be easy, and I'm going to give you a tool to help with some of these decisions. The first one is this, where you're trying to decide whether you're going to go for regional anesthesia or a general anesthetic in this patient with a difficult airway by using awake laryngoscopy as part of airway assessment. And this was done in this patient with Klippel-Feil syndrome, a bit like the one I mentioned earlier on, who has a difficult airway and a difficult back with the kyphoscoliosis. And this was done by Martin Dresner in 1995. And what they did is they did a direct laryngoscopy using a Macintosh blade. You can now use video laryngoscopes and a topical anesthesia. And they had a good view of the glottis. And therefore, they were happy to do the cesarean section under regional anesthetic. In fact, they used a spinal catheter because they knew that if they needed to give a general anesthetic, they'd be able to intubate this patient. Another decision is when you want to decide, do you go for an asleep or an awake airway? And again, you can do an airway assessment using an awake laryngoscopy. And this was done in this patient who was a dwarf, high BMI, had Harrington rods, and they did an awake laryngoscopy, had a good view of the glottis, and therefore did a rapid sequence induction and an asleep airway. Now we're going to move on to this controversial topic of using supraglottic airway device as a primary airway device for cesarean section. And we wrote this review editorial in the BJA, which covered this subject. And what we found was that there are quite a lot of studies now. There are at least 11 studies that have been published, and over 8,000 patients have been studied. And only 4 randomized studies, which is just under 600 patients in randomized studies. And what we found actually is worrying is that this is already becoming practice in some hospitals. And I'll pick one study here which described their practice in their hospitals. So they said the majority of their cesarean sections are being done using Supreme LMA. And quite often it was a patient preference who wanted the use of the Supreme LMA. And it's already become part of a routine practice for at least 5 years in their hospitals. And in this study, they used the Supreme LMA in category 2 and 3 cesarean sections. And the patients had been fasted for just from 4 hours onwards, which is not very long. So it's already becoming routine practice in some places, which is a bit worrying. So let's look at the safety side of it. What are the findings? Well, it's reassuring a bit in that there's been no cases of aspiration, which is one thing that we would worry about. There's been one case of regurgitation, which occurred during the application of fundal pressure. When we looked at the randomized studies comparing the supraglottic airway device and endotracheal tube, in fact, supraglottic airway device performed better. There was one failed intubation in the endotracheal tube, and there was a case of laryngeal spasm in the endotracheal tube. So in fact, the supraglottic devices were performing better from the evidence so far. But I'm not going to stand here and say, by all means, go and use supraglottic airway devices. No, because we still need more studies. We've only had nearly 600 patients in randomized studies. We need bigger studies than this, because we need to confirm in selected patients, is the use of supraglottic airway device safer than intubation? And how do we select those patients? Could it be based on BMI, fasting status? What type of anesthetic are we going to give? Are we going to allow the patient to breathe spontaneously, or are we going to paralyze and ventilate the patient? Of the types of supraglottic airway devices that are there, which is the best for the obstetric patients in this situation? And of course, what is the role of gastric ultrasound? Could we use it to assess gastric contents and then make a decision on which is the best airway technique? Still questions to be answered, but we need more studies. At the end of my talk, and hopefully I've covered the 3 areas I mentioned. I was going to manage to about modernizing the rapid sequence induction technique, talking about anticipated difficult airway in the pregnant woman, and controversial question about supraglottic airway device as the primary airway device. Thank you very much.
Thank you so much, Dr. Mary. That was really a very interesting presentation. I'm sure there'll be lots of discussion about this at the end of the session. I request Gunjit to please introduce the next speaker.
Thank you, Sheila, and thank you, Mary, as usual, very comprehensive in very short time. And now my pleasure to introduce Mark. Dr. Mark Stacey is a consultant anesthetist and associate dean at Cardiff. With extensive experience on the management of difficult airway, he is very, very well known for investigating performance and skills under pressure and has developed lots of training methods for emergency scenarios. Additionally, for the last 8 years, he has been developing strategies to improve our well-being. What could have been more relevant during this pandemic? Thank you, Mark, and now runs a very successful workshop on well-being. And I mean, in addition to all this, I would just personally add that every time I hear Mark talk, I just say that if I could just inculcate even a bit into my personal practice, it would just make me a better anesthetist and improve my well-being. So I look forward to hearing you again, Mark. Thank you.
Thanks very much, Gunjit and Sheila, and thank you for inviting me. I'm going to play a video, I hope, which will come in now.
Good afternoon, everybody. I hope that you're all okay in these extremely challenging times. My name is Mark Stacey. I'm a consultant anaesthetist in Cardiff in Wales, and I've been asked to talk about human factors in airway management. So I'm going to give you a short introduction over the next 20 minutes. I'm happy to provide more learning material if anybody's interested. I think it's important to realize when you're talking about managing an airway in anesthesia or in resuscitation, in order to do it well and to do it as well as you can, it's not just about the airway. And in fact, I'm probably going to spend very little of the next 20 minutes talking about guidelines. You're all quite capable of looking those up. So our job is pretty time competitive. My particular clinical interest is managing difficult airways in pediatrics and adults, but also I am an obstetric anaesthetist, which can be a very time sensitive job. And like most of my sessions, this session will follow what I call my baobab rules. The baobab is this tree that you can see in the background. And the story that the Africans tell about the baobab is that God was so unimpressed by its bloated arrogance that he planted it upside down. And I use it to remind me on a daily basis that arrogance in our specialty is an extremely dangerous trait to have. But it's also to remind me that 90% of what I'm telling you, I think, is correct. Only I can't tell you which 90%. And in fact, the more I learn about this subject, the more I realize 90% is probably a gross overestimate. So I want you to imagine that you are looking after a patient. You are the anaesthetist responsible. It's 4 o'clock in the morning. This lady is a 30-year-old grand multip with symptomatic COVID, and she is on the red ward, some distance from your normal labor ward patients. The midwife looking after the patient, it's her 4th night on a series of nights. The clinical team, including you, it's your 3rd night on a series of nights. And the midwife, very sensibly, because of the potential risk of a significant postpartum hemorrhage, has ensured that there is a bag with 40 units of syntocinon and 500 mils of Hartmann's drawn up, ready to go as soon as the baby is delivered. The woman is on an IV infusion, and at 4 o'clock in the morning, the bag is changed. And at that point, the fetal heart rate drops significantly. And she realizes with complete horror that she's actually transfused inadvertently the bag containing the syntocinon. The consequences of this are significant fetal distress and a category 1 or emergency cesarean section. The anaesthetist hastily, with the surgeons and the theatre team, try to put their PPE on and do a briefing. The anaesthetist starts to pre-oxygenate the patient, induces and paralyzes the patient, looks up to see what the SATs are, and realizes that he has forgotten to put the monitoring on. And now he's got to intubate the patient. So what we've got here is a perfect example of the lining up of holes in Reason's Swiss cheese model. Ostensibly, if you looked at this from a root cause analysis point of view, you would say that the incident was caused by the infusion of syntocinon. But it's much more complicated than that. And this is often poorly understood by those retrospectively analyzing an event such as this. So what does human factors mean to you? Well, usually when I ask this question, people will talk about the mistakes that human beings make, particularly when they're stressed, and strategies to minimize the risk of those mistakes causing more significant harm. What we call a system 1 approach. More recently, we've started to look at a system 2 strategy, which also looks at things that go well or things that go right, and see how we can make that side of the scale even bigger while making the things that go wrong side of the scale even smaller. But actually, human factors is more than that. It encompasses all those factors that can influence people and their behavior. And in our work, it's the environmental, organizational, job factors, and individual characteristics which influence behavior and performance at work. And what I'm talking about here is a variety of skills that we're all quite capable of learning. And the reason that we understand that they are skills does mean that you are more likely, if you understand that it's a skill, with significant practice, to turn that skill into a habit. And over years of practice, that habit may then become part of your behavior in such a way that you're continuously looking to ways to improve your performance, to ensure that when faced with a challenging, time-limited airway potential catastrophe, you have the appropriate skills to manage that situation. And if you go on a human factors course, you'll often be taught a variety of skills, such as the ones I've listed here. And the idea is you learn those skills and you ensure that you practice and perform those skills in such a way that patient safety is optimized. But as I said, it's more than that. This is the error troika taken from some of the original work done by NASA looking at human performance. And in order to ensure that the system is appropriately managed as best as it can be, ideally your system should be enabled in such a way that and designed that the error is avoided in the first place. That's the bottom section of the pyramid, which is also the biggest section of the pyramid. If the error is unavoidable, then you need strategies to trap the error. And interestingly, often when we design traps for errors, you then run the risk of making that system more complicated, which actually leads to a different set of errors. And at the top of the pyramid, the smallest part of the pyramid, is the human being who has to find a strategy or plan or skill to mitigate the consequences of that error. But frequently when analyzing errors using hindsight bias, it is the smallest part of the pyramid, i.e. the person at the top of that pyramid, who is blamed for that series of circumstances. Because there are three key issues. For any of us, error is normal. Problem is, with the best will in the world, our performance is also variable. But you can mitigate both of these problems by ensuring that the team optimize their communication and optimize information sharing. This is some data taken from eye tracking data. So what you can see here is somebody's vision as they're driving down a dead straight road. They're looking in the rear view mirror, which is the mirror at the top, and then the two side mirrors. And you can see that they're scanning the whole area, even though this is a dead straight road. And this is what happens to your eye tracking when your phone rings in the car. What you can see here is that the area of focus is narrowed right down, and hence there is a significant risk of fixation error. You effectively become cognitively blind to anything that is outside that small area of focus. And this can cause significant issues. So this is the simplest model of the mind that I use for a variety of different purposes, but I'm going to use it here to look at human performance. And it's based around an understanding of our working memory, which acts as a bottleneck between two things. It acts as a bottleneck between the skill, and for this example, we'll use the airway, and your long-term memory. Now, your working memory is limited. And Ronald Miller looked at this function of the working memory in the 1950s, wrote a paper called The Magical Number 7, and suggested that at any one moment in time, we can cope with 7 plus or minus 2 items of information. Personally, I've always thought this was a bit of an overestimate, and this work was repeated by another psychologist called Kaamcon in the 2000s, and he said it's not 7, it's 4 plus or minus 1. And then, of course, there's the issue of stress. What happens to that number, 4 plus or minus 1, when you get stressed? Well, what we think happens is you become almost a binary unit. So your 0 response is your classic rabbit in the headlights response, the freeze response. And your +1 response is your classic fixation error. I must intubate, must intubate, must intubate. And then, of course, there's a -1 response, which is where you run around with your hair on fire. And of course, there are a couple of real blocks to this process of putting the skill into your long How many of you noticed that in the bottom left-hand corner, I changed the quote each time? If you don't believe me, you can go back and watch this talk again. Because we have a huge arrogance about how good we think we are in a stressful situation. We think we will perform better than we've performed before. But the best we're ever going to perform is the best we've performed in practice. And unless you practice that skill in those circumstances, you really have genuinely no idea what you're actually going to do. And there's a saying in the Navy that under pressure, you don't rise to the occasion. You sink to the level of your training. So how can we improve things? Well, we can look at teamwork. And one of the questions I encourage you to think about in your teams is, what is it about the teams you've worked and the people you come into contact with that worked effectively? And what didn't work effectively? Again, NASA looked at this and they looked at 8 different components, which I've listed here: briefing, communication, feedback, inquiry, leadership, interpersonal relationships, preparation, and workload. And if I were to ask you to vote for your favorite or the most important of those team skills, normally in a group of people, I will get a spread of votes. But the most important one, the one from which all the others feed off, is of course interpersonal relationships. And I think it's useful to reflect on this as we move forward. Because again, when you go back to your environment, ask yourself, ask your team, what do you do to make a positive contribution to those interpersonal relationships? If you've got good interpersonal relationships, the likely performance of that team is enhanced. If you've got poor interpersonal relationships, well, then the reverse is possible. And they've looked at the effect of rude surgeons on anaesthetist performance in a simulator, and surprise, surprise, it impairs the anaesthetist performance. But I have no doubt it works the other way around. Rude anaesthetists impair surgeons' performance, and rude anybody impairs somebody else's performance. So our behavior affects the way that our teams function. And you can do that in a positive, neutral, or negative fashion. So, reminding you of the error troika, how can you design systems that maximize that bit at the bottom and minimize the pressure at the pointy bit at the top? Well, first of all, you can look at systems such as the pharmacology of some of the drugs we use. The drug on the left is an anesthetic agent and puts people to sleep. The drug on the right is an antibiotic and kills bugs. As you can see, they look very similar. And if they're stored in the same place, such as this, there is a significant risk that the wrong drug may be drawn up and injected. It doesn't just happen in anesthetics. MasterChef is a program that looks at improving the performance of chefs in cooking for the entertainment of the general population. This particular episode actually had professional chefs, not amateur chefs, on the program. And one of the chefs made a raspberry souffle, which you can see here looks absolutely beautiful. Unfortunately, when the testers came to taste it, they nearly vomited. What was the reason for that? Because the chef had put salt in the souffle instead of sugar. And if you rewind the tape, what you discover is that the salt and the sugar containers were right next to each other. And under the stress of performing in front of a live TV audience, even a professional chef can make a mistake. So look at a process in your work group. Ask yourself the question, does it work optimally? Could it work better? And how would you implement changes? And we certainly, in the current environment with the pressure that our health service is under, have had to do this on a sometimes daily basis, but certainly on a weekly basis. And we've got better at some things and other things not so much. Because what we're trying to do is improve situational awareness. I recently, sadly, couldn't find my cat anywhere. So we put up some posters complex environment. And it's very important that in order to manage that environment, use a variety of practical strategies. There are practical strategies that we can use to improve our performance. So an awareness of the hungry, angry, late, tired acronym. Those are not recommendations, by the way. Those are recommendations to avoid those particular components. I think it's also important to be aware that your colleagues may be suffering from hungry, angry, late, tired. So if you have sufficient spare bandwidth, can you support them? Additionally, make better decisions. And the more you practice making these better decisions, the more likely you are to ensure that that decision is appropriate in the stress of the moment. And this model here is one of the ones that I teach routinely to encourage people to think about making decisions. But you need to do it in the cold light of day. You can't do it under the pressure of a hypoxic patient in a stressful environment. Sleep is probably the most important performance enhancing agent we know. So maximize your sleep. If you've got difficult cases the next day, do your best to ensure that your sleep is optimized. Ban your phones from the bedroom. Look at strategies that will enable and ensure that your sleep is optimized so that when you wake up in the morning, you are in top physical condition. Also be aware of the nadires of human performance. So the 4 o'clock in the afternoon, 4 o'clock in the morning are times when we're definitely not at our best. Teach people stuff, and I'm grateful to my colleague Fiona Kelly for the Arachnid education tool, which looks at a variety of different components when you're talking about human factors and ergonomics. And you need to practice these because you can't practice them under pressure. Because what we're trying to do is to ensure that that working memory doesn't act as a bottleneck. We need to be aware of errors. We need to ensure that our stress is managed. We need to ensure ideally that our team are all in the same movie and our environment is optimized. So if we look at some of the factors that might have affected that case that I got you to imagine in the first few series of slides. Ideally, what you want is to ensure that your working memory is not overwhelmed. So what are the key inflexible things that have to be got right to ensure that that airway is managed in as safe a way as possible and the patient's care is optimized? But then you need a lot of other information that you've dealt with in the cold light of day in your long-term memory: ergonomics, training, teamwork and interpersonal relationships, and awareness of the HALT acronym, optimizing your sleep, understanding that things like PPE dramatically decreases everybody's performance, communication, knowledge, stress management, optimal decision-making. There's a lot of stuff in there. So thank you very much indeed for listening to me. I wish you all the best in your respective hospitals. It's been a very, very tough time and things at the moment aren't looking like getting a whole lot better. But what I'd like you to do when you go back to work or before you go back to work, I'd like you to write down 3 things you're going to do as a result of attending this session today. Not just my lecture, but this session. Many thanks and good luck.
Thank you very much,
Thank
Mark.
you, Mark.
Very interesting session. Yes, go ahead, Gunjit.
Yeah, we'll just go on with the questions we've received with our audience. And we have Mark, Krish, and Mary. Can we have you with your videos on and your audio muted?
Thank you.
Should be on.
Sorry, Thank you for the excellent talks and early morning. Good morning in UK. Okay. First questions for Krish. We'll go with the same order. Krish, we've got a question. In the green pathways, how long will you wait between cases? And this varies considerably between various hospitals. What's your opinion on that?
Yeah, I think evidence. Are you able to hear me, Gunjit? Is the voice coming through?
Yes, all good. All good.
Good. Right. Okay. It all depends on whether the theater you're using has laminar flow or it doesn't have, what kind of a room you're working in. And Initially, we were waiting as long as 20 minutes. That was what was based on research. Then as the pressure mounted, we are now stopping for about 5 minutes. That is the break we are giving between the cases, which is what you're doing. But if you look at the aerosol that hangs around, according to research that I found, was anything between 8 to 14 minutes is what they found was aerosol in that particular room. So I would recommend that the local practices should vary depending on what you actually facilities you have. And you should ideally give at least 15 minutes between the cases. If people do come in, they have to make sure that when you're extubating, keep people out. So when I'm extubating a patient at the end of the case, I send everybody out except me and the ODP who stay there. And we make sure that there is somebody guarding the door so the surgeons don't walk in, which is often the case. They just walk in and walk out of the theater, keep them out. And then when I give my voice is loud and clear often and reaches distance. So I give a shout at the end of it and tell people to come in when it's ready. So keep a 15-minute gap, which is probably the safest for you to protect your own staff, because you don't want them to catch the COVID and go off sick. You have to retain the staff. So that's my recommendation, 15 minutes, and then the staff come in. Ideally, they should have protection as well and do the cleaning that is required of the area before the next patient is brought in. We are suffering a gap of about 20 to 30 minutes between the cases at the moment.
Thanks. I'll quickly move on to the next one. So HFNO is an AGP, but administering nebulized humidified oxygen is not. How come?
Nebulized humidified oxygen is not an aerosol? Yeah, because it is it's coming from outside source. So when you administer something from outside source, it is largely sterile, and it goes up, comes up, the nebulization occurs, goes through the nasal passages, larger droplets get deposited, a few of the aerosol goes in. It doesn't have sufficient force to generate enough to bring the virus out. So, however, it is always important for people around to keep the distance and also to wear the PPE, because at this moment we know what we know. We do not know everything.
I have a
Krish. That's
question
very good.
for you, Dr. Krish. Firstly, excellent presentation, very interesting and very nice presentation as usual. My question to you is that, we're still not sure. You mentioned that you would use FFP3 for aerosol generating procedures, but we're still not very certain which is definitely an aerosol generating procedure and which is not. Recently in anesthesia, in the same week, they published 2 articles, and one that showed that actually intubation and extubation, which we consider as high aerosol generating, may not be so much of a concern, whereas coughing and speaking loudly was. And in the same week, there was an article that showed there are concerns about aerosol generating during intubation. So how would you make this distinction that this is definitely aerosol generating, this is not, I would wear FFP3 for this and I wouldn't for this?
I would go by what the recommendations have been made by the World Health Organizations and PHE, who actually poured over a lot of research and have come out with a very logical, sensible recommendation that at this point in time, we regard all the things I listed in my slide as aerosol generating, because the lack of evidence does not, however, mean that there is no aerosol, does not infect. So the droplet nuclei carry the virus. And there was another study from Bristol that came out that you need something like 1,000 of these particles, droplets to cause an infection. So to really ignore that advice and then just get on and use without PPE would be putting yourself at risk. You can see how the research has been changing for the past 1.5 years. We have had research changing every day, like a Hollywood actress is dressed in a single song. So we have to be very careful about how research is interpreted at this particular point in time. When I'm in the theater, I take it my responsibility to protect not only myself, but my ODP and the surgeon and the rest of the staff. So it is very important, just stick to the rules and wear the PPE properly. Do not change it based on some new research that has come in. Tomorrow, anesthesia or some other journal may come out with another article. Interpret it carefully.
Yeah, so I think thank you very much. That's a very practical suggestion. So it's better to err on the side of, probably
Caution.
and considering most of them as aerosol generating till we have more robust evidence. Just another very quick question. You mentioned about the time period between cases. Now, isn't that dependent on the number of air changes? We have Tim Cook has very nicely described based on the air constant theory that every air change, 60% clearance of the virus. So doesn't it depend on that rather than just 15 minutes across the board?
Yeah, no, I didn't mention the laminar flow theaters that we have. In laminar flow theaters, people have come out with durations of 5 minutes between the cases, which is shorter than you would think. But really, we are not visualizing it. You see, this is based on studies, small studies done in different parts of the world that are coming out. We really do not know. So being pragmatic and practical, it is much better to have a standard in a hospital and saying, we'll do 5 minutes here, we'll do 15 minutes there. That is going to cause a lot of confusion because staff move between the cases. And we just had a good lecture from Mark about the human factors. These factors have to be taken into consideration. It is better to have one standard rule in a hospital saying, between cases, we are going to give 15 minutes. Okay. Let's do less cases and let's do them well and let's do them safely than trying to do one extra case and put 4 people at risk.
Thank you, Chris. That's a real nice practical.
And just to add, I mean, taking from Mark's talk about human factors and the importance of WHO team brief and communication at the beginning of the list so that the whole team is on the same page with the timing between cases and what pathway are you on and which patient is amber and which is green, because I think that leads to more delays because somebody's thinking 5 minutes and somebody's thinking 20 minutes and it's not a happy team. So I think that's the most important thing in the beginning to decide and everybody's together.
I'll ask a question to Dr. Mary that's come on the chat. So they've asked, what is the incidence of aspiration in obstetric cases who do not receive prophylaxis? Is there any comparison?
Oh, I think that we don't have that figure, I'm afraid. As you know, research in obstetrics is always a little bit behind any non-obstetric cases. But what I can tell you is that the incidence of aspiration in obstetrics in general has gone down. Recent studies show that it's between 1 in 1,000 and 1 in 4,500. And 1 in 4,500, that was a UCOS study in the UK where they looked after a 2-year study and look at all the cases of aspiration. So we're saying it's not high, but when it does happen, the morbidity can be quite serious. I think they had, if I remember correctly, they had 6 cases of aspiration, of which 1 patient died, but they thought the other comorbidities might have contributed. 1 patient ended up on ECMO, and then several patients ended up on ITU. So, that's actually significant. So although it's low, if it does happen, it's significant. And we need to keep that in mind.
Right. Thank you, Mary. Another question that I'd like to ask you, and this is specific to India. We have rocuronium. A lot of people use rocuronium, but we don't have Sugamadex. Okay. And if we get it, there will be cost implications.
Yes.
So, and I liked your, discussion about between rocuronium and suxamethonium. And you said, it's still, it's still not conclusive as to what, and you give the pros and cons for each. So in this kind of setting, would you say that we should still continue to use choline for RSI in India?
To be honest with you, I like rocuronium for the reasons that, particularly the airway side of things. I know that I talked about anaphylaxis, but from the airway point of view, rocuronium gives you the best conditions, but you have to use Sugamadex. If you think about it, if you give rocuronium 1 milligram per kilogram, cesarean sections take 30 minutes average. Well, you're not going to reverse that with neostigmine. You need Sugamadex. So you have to have Sugamadex. And I will not use rocuronium as an RSI without having Sugamadex in that situation. So you have to have it.
Right. I don't see any other questions for Dr.
I have a question for Mark.
Yeah, go ahead.
Mark. Hi, Mark.
Hi, guys.
A lovely talk as always, every time. We've done so well in improving our performance under pressure with our known teams and in known conditions and circumstances. What is your tips for like unknown places, new teams, working with locums in private hospitals? How do we then get, we are still very behind with improving working with new teams under emergency situations.
Yeah, I think that's right. And I think one of the points I made right at the beginning of this, February, March, was that disasters are going to occur in my unit. And like Mary, I also work in a tertiary referral obstetric anaesthetic unit. Problems are going to occur not because of our skills, but because people were starting to panic. People were starting to get tired. People were frightened. And we have a handover every morning at sort of 8 o'clock, 8:30. And at that handover, one of the things that we talk about is the new members. So we introduce them so we know who people are. And also we talk about the support that we have for each other. And I think the key there isn't, there's a massive skill set. There's always people who can help you. You just have to ask, or you just have to tell them that you're not doing well. One of the things I encourage both myself and my colleagues to do is I carry small quantities of food in my backpack, usually little packets of chocolate chip cookies. And if I can see my colleagues are beginning to wilt, which is quite common actually at the moment, because of the conflict between home, the fact that they're often homeschooling. Most of the people I work with are women, and they provide the primary care at home. Make them a cup of tea and give them a couple of chocolate chip cookies, and it does actually reframe that interpersonal relationship. It does mean that they will do their best, the best that they can. And we've got a sort of, I suppose, an approach that what we're trying to do is to ensure that the patient is put first and foremost, but also that our colleagues are put first and foremost. And I think it's been a really rough year. I'm sure you'd all agree. And I think the only way we can look after each other is by looking after ourselves. And when I'm having a good day, I'll help other people. When I'm having a bad day, they look after me.
Yeah, thank you. I have a question.
Thank you.
For Mary, if I may ask. So Mary, you touched on a very kind of controversial area about supraglottic airway device for obstetrics. And you said we still need more robust evidence about patient selection. Nevertheless, in your experience, which are the kind of cases you would say, we could go up front with using a supraglottic airway device?
I think if we did go down that way, it would have to be an elective cesarean section.
Okay.
Somebody low BMI with no known difficult airway and probably no other sort of comorbidities. So you're really looking for the really ASA one with no comorbidities. And I think most of our pregnant women having an elective cesarean sections don't fall into that category, I'm afraid.
Right.
There's a shortage of those.
Yeah.
For people in India who want to start using supraglottic airway devices for cesareans, can maybe use this as a starting point.
Yes.
Dr. Mark, excellent presentation. I have a question for you. We're focusing a lot on moving away from just technical skills to enhancing the non-technical skills in our trainees. And there's a lot outlined in theory, about reducing the cognitive overload and fixation errors. And it's all very beautifully outlined. But can you give us some practical tips as to how we could improve, human factor training in our departments with our trainees? I mean, what are the methods that you use and how can we enhance this?
I think it's a really good question. I think, the issue isn't for me around technical skills and non-technical skills. It's the issue around performance, which means you've got to do both. So whenever I teach skills, I teach them both. I break down the skill initially with a novice to make sure that they have the understanding of what they actually have to do, how to put a spinal in, how to set up a spinal tray, for example. But then on top of that, and you can do this easily at a desk, you don't even have to have a simulator, is to start increasing the stress. So you can play with things like, you can get these sort of monitors on an iPad, and you can give a patient, give a trainee a deteriorating clinical picture and then see, and you can start to discuss what they do. I think Mary gave a brilliant example of two of the key things that I think that we underestimate. One is the planning for when things don't work. And I think the other, which is very, very much underestimated, is how we make decisions. And I think for me, when I look at airway disasters, when I look at anesthetic obstetric disasters, I would say probably 70–80% of them are caused because somebody makes the wrong decision, not because they don't have the right skills. And you can teach people that. So, and we do. And I think I've got lots of stuff on this I can send if people are interested, but I think for me, it's don't just look at it as non-technical. Don't just look at it as technical. Look at it as how do I do what I do to the best of my ability.
Right. So you would combine the training with both, because a lot of people think that you need simulation-based training. And so you're saying you could just do it around the patient and just increase the level of stress and, use other, devices like an iPad or create scenarios at the patient end. Yeah.
As I say, and there are lots of things that you can practice away from a patient, and probably should practice away from a patient, because practicing in front of a patient would scare the hell out of them.
Thank you.
And me, probably.
Thanks, Mark, and thanks, Mary, and thanks, Krish. Excellent discussion, and
thank you.
We will hand over back to the organizers. Sorry for overrunning.
Yeah.
Thank you. What a wonderful session, and we sincerely wish we could have extended the discussion time for another half an hour, but unfortunately we can't. For the next session, I would like to invite the chairpersons, Professor Cyprian Mendonca. He is one of my mentors since my training days, and he's a consultant at University Hospital Coventry in Warwickshire, and honorary professor of University of Warwick. He's also the co-author for DAS 2015 guidelines, and he has authored several books, chapters, and articles, and he runs several courses focusing on airway management and human factors. And we got Dr. Sajid Kumar, who is a colleague of mine at the University Hospital Birmingham, and he is the lead thoracic anesthetist here, and he's involved in several organizations, several courses, including his regular update sessions on thoracic anesthesia at the Association of Anesthetists. Over to you both.
Okay, thank you, Sajay, Elizabeth, and Sam, for your kind invitation. And it's a great conference and excellent organizing this conference. I welcome our guests to our session 6. In this session, we have 3 excellent talks from 3 expert speakers from Switzerland, Ireland, and Netherlands. It's a great pleasure to introduce our first speaker. It's Professor Patrick Schotke from University Hospital Lausanne, Switzerland. He has great research interest in pre-hospital airway management, video laryngoscopy, and monitoring. He has invented several airway devices and intubation aids, and I see his great interest in using advanced technology in wireless monitoring and so on, and he's published numerous highly cited papers on airway management. And let us now try to understand how 1 + 1 is equal to 3 in video laryngoscopy. Over to you, Patrick.
Well, thank you. I think now there is a recording of my talk, which I'm ready to share. I'm happy to take some questions afterwards. Thank you.
Hello, everyone. It's a great pleasure for me to talk to you about the video laryngoscopy and why I think, as a Swiss doctor, that 1 + 1 = 3. My name is Patrick Schotke. I'm a professor of anesthesia here at the University Hospital of Lausanne in Switzerland, and a long-time user of this device called the video laryngoscopy. And if I could summarize my talk, it's just talk about the new mathematics of intubation and how these devices have massively changed our approach to this common tool that we do have, which is the intubation. We have been using this fantastic device that has been invented by a fantastic man in 1943. And this device has been extensively published, not only because at the beginning, Macintosh had seen somebody using it, not only because he had actually gathered some experience that there might be some reasons why this device is so great. He made some interesting findings and discoveries about specifics, especially demonstrating that the specifics are not that important. And most of all, what I like the most about that paper is he even gave you some advice where you could buy it. Jokes apart, this device has been fantastic, has been used for a long time, and has generated a huge array of worldwide specialists of airway management, the experts of intubation, who have become experts in understanding what they've been seeing through this little keyhole, but they've also become experts in teaching the airway management by looking over the shoulders of their juniors, trying to understand what their juniors were seeing, trying to understand what their juniors were telling them, and trying to find solutions to manage the difficult airway with this device. We come from a world of direct laryngoscopy, where we use this device to pull the tongue away from our side of view to generate a classification. And the interesting thing is there's some close correlations theoretically between what you see, between the Cormack-Lehane classification and the ease of intubation. Now, many papers, and I especially want to highlight this NAP4 study that demonstrates that although we have been using these devices for a long time, the area management is still an issue of concern. And depending on where we are and who we are, there are some key factors that play a big role. Of course, the patient, the complexer the patients, the more difficult the intubation can be related to. But of course, the judgment, the own physician's judgments, and the team. The team, and when I talk about team, evidently you talk about the communication, bring the information across the existing people who are next to you and are there to help you intubate patients, and of course, education and training. This is true for the anesthesia world, but this is even more true for intensive care and emergency departments. And you can see here the contributory factors: communication, education, and training, and judgments are one or a few of the main issues that have been highlighted by this great study. If you want to summarize it, direct laryngoscopy is a tool, has been demonstrated useful, but there is the expert, and then there is the rest. And depending on the balance of competencies, it can be one bigger than one or one smaller than one, but never or very seldom do they addition to bring this magic number 1 + 1 = 3. As ever in the world, there have been some fantastic love stories, and I want to relate to you about a love story that happened around 2001, 2, or 3, a love story between a direct laryngoscope and the techniques of fibroscopy. These fantastic meetings have given birth to many children that can be related to video laryngoscopy, and each child is as beautiful or even better as the one before. The first child that had been coming out in the market was evidently the gyroscope in 2001. For us anesthetists, it's also interesting to remember that this device had actually been put into life by a surgeon, a vascular surgeon. This could be also something we should remember when we use this device, so that we can take part in the development of newer solutions. The indirect laryngoscopes have given us some way of thinking that we need to change the attitude towards tracheal intubation, that we need to go from the direct way we do it to the indirect way, which allows us to position a camera with a specifically designed blade in an anatomy, and that allows us to look around the corner with the hyperangulated video laryngoscope on a screen which is sitting next to the device. And nowadays, in 2021, we still have the two techniques: the direct laryngoscopy, where if you see the larynx, the intubation is okay. If you don't see it, it will be difficult. And the indirect laryngoscopy, where you leave the anatomy as it is. You look around the tongue and you share the view with the whole department or with your whole people who are around you. And by sharing the view, you bring the competencies of your surroundings to your help that might increase or improve the way you will manage the airway. There are some specifics. You need to understand the angle, the three-dimensional anatomy that you see on a two-dimensional screen. You need to understand the trajectory that the tube will have to do to reach the tracheal inlet. And of course, you need for that hand-eye coordination. To make the things even a bit more complex, at least it looks like, but it's very simple. There are two specific techniques to the video laryngoscopy: the channeled and the non-channeled. And to go even deeper in the dichotomy, if you use a non-channel, you can use a Macintosh type blade, or you can use a hyperangulated blade, each of them designing some specifics related to the way you manage the intubation. Aim and tube, if you have a video laryngoscope with a channel, the tube will go where the channel leads him to, show and play. And evidently, the success rate will be dependent on your understanding, on using the proper device for the proper anatomy, and this will allow you to use the aim and tube technique or the show and play, depending on your understanding of the anatomy of the patient you need to take care of. Here, a little example of a properly used device in anatomy, which is perfectly fine for the channel type intubation with a beautiful alignment. And if you push the tube into the trachea, you will see that the channel will bring the tube where it needs to go. Now, if you have, this is the picture of a normal anatomy. If you have now an anterior lying tracheal inlet, you can easily understand that the channel technique will not allow you to bring the tube in an anterior way. And this is where you need to bring the movement of the tube. And this allows us all, for you, or also for all of you who watch over the shoulder on the screen of the intubating doctor, that the intubation is a three-step process. First of all, you need to have a look. You need to see laryngeal sighting. Then you need to bring the tube in front of the glottic opening. And then you need to bring the tube inside the tracheal inlet through the thing. And here you can see, and you can share the view on this patient who has an anterior lying tracheal inlet. You will see that the tube, the view, the first laryngeal sighting is easy to see. Second, bring the tube in front of the laryngeal inlet, fairly easy. And then look at the anatomy, look at the trajectory of the tube when it goes through the anatomy of the specifically anterior lying tracheal inlet. You see how the tube moves up over the tracheal inlet inside the trachea. By sharing this, you will bring the team next to you by sharing the view. You can demonstrate, and this is where I come up to the 1 + 1 = 3. This is an interesting situation. Again, anterior lying tracheal inlet, somebody using the tube and the stylet. You see the stylet within the tube being slowly retracted. And it looks like it's going to be a difficult intubation because the tube cannot be thrown into the tracheal inlet. And here comes the 1 + 1 = 3. The teacher sees what the student is doing. The teacher is teaching, and now the teacher is taking over, just to demonstrate that by properly handling tube and stylet, you will bring the tube in the anatomy and allow the proper intubation through the specific anatomy. By sharing the knowledge, you improve evidently the performance of your students, and you might have some quieter nights at night when you're home and the student or the resident is intubating the patients because he has seen, he has heard, he has taken part into this intubation, that you are able to share your own knowledge with the screen of the tracheal intubation. Here is an interesting movie where I am supposed to be the expert. I'm teaching the young residents how to handle the video laryngoscope with a screen. You see, he's not looking over my shoulder. He's just looking on the screen. I'm explaining him what I will do. And look at how difficult for me it is to bring the tube inside. And you will see the hand of the student say, hey, doc, you should be doing this. Here, put this. And thanks to his help, I'm able to manage the goal of properly positioning the tube in front of the tracheal inlet to intubate. I think what video laryngoscopy has taught us, and this is where I'm going to come towards the 1 + 1 = 3, that what we want to reach is success. To be able to succeed, you need some specific skills. Evidently, you need hard skills. You need to understand the device you have in front of you. You need to have the understanding of the patient you have in front of you. But you also must pay attention to the team you have with you. And this is where the soft skills come into play. The usage of indirect or video laryngoscopy has dramatically changed the way we manage airways. Here at the study we did in-house a couple of years ago, we tried to assess the effect of our airway management, the difficult airway management in our institution, just by the only thing that we introduced 2 video laryngoscopes. You can see in red the techniques we used after the introduction of these devices, and you see that in red, the number of patients we intubated with the help of a laryngoscope dramatically decreased, same with the fibroscope or some other devices. So there is a change of practice, there's a change of skills. We need to learn some new skills, some hard skills, but the hard skills are only part of the success. You need to be able to understand what are the specifics to each device, what are the good and bad sides, and what you can bring to your patients with these specific devices. Changes of practice introduced by the usage of video laryngoscope. You see patients with a C-spine connection, C-spine collar on that immobilates generates a difficult airway because you can't move the neck. You have a small mouth opening. We were able to intubate all of these patients with a video laryngoscope by somebody who knows how to do it. We changed the practice in the airway management of patients with an unstable cervical spine fracture, using the gold standard fibroscope, comparing it to the newly introduced AirTrack.
देखो मैं तो हमेशा अच्छा सोचती हूँ.
Without bringing any harm. What we also learned is that it's not only hard skills, but there might be human factors that play a role. There's experience, the location, specific relation related to the patients, equipment, and time pressure. And this is where we're coming towards that we were able to discover, or at least was reinforced by the usage of using devices that allow you to share the view, is that the soft skills are big component of part of success. And I specifically like this editorial published recently about non-technical skills and human factors are probably the most radical changes to our clinical practice to the airway management. And this should not be underestimated. I think, and this is my proper belief, 1 + 1 = 3, by allowing everybody to share the view, to have a look at what you see, to demonstrate, you improve the proper airway management, and you improve the management for the patients, you improve the teaching, you improve the quality, and this is the way to go forward. What I like as an airway provider, the VL has made airway management fun, and I specifically insist on management. Management is a team approach, and this is what we are able to deliver now daily with the use of the video laryngoscopes. Thank you very much, and I'm happy to take any more questions. Thanks.
Thank you, Patrick. You very clearly demonstrated us how 1 + 1 is equal to 3 in video laryngoscopy. We'll take some questions after the third talk. Now it's a great pleasure to introduce our next speaker, is Professor Ellen O'Sullivan. She is a consultant anesthetist at St. James Hospital, Dublin. She's been involved with Difficult Airway Society since its foundation, and she is a DAS professor. She has held numerous posts and roles in various specialist societies and councils in UK, Ireland, including she's been the past president of DAS. She's past president of the College of Anaesthetists Ireland, and been in the past vice president of Association of Anaesthetists. She is currently the council member of Royal College of Anaesthetists. She has co-authored several airway guidelines and published numerous papers and chapters in the book. And currently she's working on ASA difficult airway guidelines, and also on the project for management of universal airway guidelines. Over to you, Ellen. Thank you.
Thank you very much for the introduction, and to the Airway Society, Kochi, and to Elizabeth, Sam, and Sajay for the invitation to speak at your meeting. I'm going to talk today about supraglottic airway devices and their role in COVID times. Now, firstly, I'd like to bring to your attention this fantastic resource. It's COVID Hub. And it was started in early March by the Royal College of Anaesthetists. the Association of Anaesthetists, the Intensive Care Society, and the Faculty of Intensive Care Medicine as a resource with information guidance to support the understanding and management of COVID. You can download it on, this is the website, and in it you'll get lots of useful information. One of the first publications in that resource are the airway guidelines produced by the Difficult Airway Society in conjunction with the Association of Anaesthetists, the Royal College, and the Intensive Care Group. And again, very useful. And I won't go through all those guidelines, but I will just see and particularly concentrate on supraglottic airway devices. And did the hub have any information on that? They obviously commented that the use of supraglottics during the COVID pandemic didn't have much evidence base, but they recommended that if an SGA is used, it should be a second generation, and that scrupulous attention should be paid to ensuring a leak-free seal. This is very important. Now, some other groups and societies have guidelines. This is a consensus statement from the Safe Airway Society in Australia. Again, confirming also that if you use a supraglottic, it should be a second generation device, as its higher seal pressure during positive pressure ventilation decreases the risk of aerosolization and virus containing fluid particles. We all know the advantages of a supraglottic airway over tracheal tube, the fact that they're faster and easier to insert, there's lower anesthetic needs to tolerate the airway, less hemodynamic changes at insertion and removal, less coughing and better sats on extubation, and less sore throat. So potentially there are advantages using supraglottic airway devices in COVID, and because of the smoother induction, obviously less coughing as a result, the reduced need for relaxants, smoother and safer extubation, and fewer pharyngolaryngeal complications. So let's just look at, first of all, our classic LMA as designed by Archie Brain and came into clinical use in the late 1980s. I think we owe a debt of gratitude to Archie and his friend Shandia Verghese for their brilliance in bringing this into the market. And also, I mean, Archie's stressing of the importance of proper positioning. And this is a soft tissue view of a correctly placed LMA lying between the hyoid bone here and the and T1. And he was always insistent on its on the proper positioning. And this is CT scans taken whilst in cadavers during the work he was doing. And again, you'll see the cuff of the laryngeal mass between the hyoid and over the tracheal inlet, with the tip conforming to the anatomy of the hypopharynx and plugging the upper esophageal sphincter. A lot of work was done in the meantime then following the classic LMA to produce the Pro Seal and launch it in 2000. This was the first double lumen LMA with airway and gastric access, a second seal, and increasing sealing pressure. So in our armamentarium at the moment, we have a plethora of first generation supraglottics, all quite similar to the classic, some disposable and some with slightly different features. But the second generation, we have a number on the market as well, like the iGel, the Supreme, the Protector, and the Pro Seal, etc. So what do we mean by second generation supraglottic device? We mean one that is designed with features to reduce the risk of aspiration. So you will have a drain tube to separate the respiratory in green here, the respiratory tract, and the gastrointestinal tract in yellow here. And they have, by definition, a higher oropharyngeal leak pressure compared with first generation supraglottic airway devices. Now, this is important because it is the pressure that breaks the seal between the supraglottic airway cuff and the pericuff mucosa. It's often used as a surrogate measure of correct device positioning, with greater than 25 centimeters of water recommended. And the cuff manometers have been designed to allow adjustment of the intracuff pressure to 40 to 60 centimeters of water and eliminate under or over inflation if this is a problem. Now, I talk about the seal. So the first seal is the nice seal over the tracheal inlet, with the second seal then with the longer tip of the second generation supraglottic device sealed quite nicely into the upper esophageal sphincter. So all second generations, by definition, have gastric, as I said, access and a second seal. So there are quite a few of them there. So which should we use? As I said, again, there's a lack of evidence, but and again stressing that the correct positioning is really what matters. And most important advantage of the second generation supraglottics is that their ability to your ability to check the correct positioning of them in the patients. If the cough is intratracheal, you will find that you've got a negative positive bubble test. In other words, when you put gel on the gastric outlet, you will get bubbling because of the position of the tip intratracheally. Equally, if you've not placed it in far enough, if you're in the hypopharynx, the bubble test will also be positive. So this is a nice early indicator that you must replace and improve your position. So I look for 5 steps. One is the depth of insertion should be more than 50% of the bite block, and most second generation supraglottic airway devices have bite blocks. The gel test, as I said, the bubble test should be negative. You can use the suprasternal notch tap test as well, and you might put a nasogastric tube in, and you should get free passage of the tube. I wouldn't not use that routinely, and a seal pressure greater than 25 centimeters of water. And how do I know it's positioned properly? Because of the 5, you can do some of the 5-step position testing, but you should get effective gas exchange as well with good Kaplan-Meier trace and SO2 and adequate airway pressure. So perfect alignment, you should have the tip of the epiglottis aligning with the proximal cuff of your supraglottic airway, as you can see with that eye gel, with the Supreme and with the ProSeal. The biggest challenge with SGAs is positioning them properly. And we know that about 50 to 80% you get a failed positioning, although they can function adequately, but maybe not in critical patients. So here we have it placed correctly. Below that we have it positioned intratracheally, and then we get down folding as well of the cuff of the supraglottic airway device. And to improve positioning, jaw lift or thrust is very useful, and in fact I use it relatively frequently to lift the epiglottic structures so that you can place your cuff, as I say, in that correct position. So looking at which supraglottic of the many that are out there should be used, I'll just bring you back to this editorial, in fact, which was written by Tim Cook and Fiona Kelly, and they looked at functioning of all LMAs, including the classic LMAs of first generation and the second generation. They looked at ILMA, ProSeal, iGel, Supreme, and laryngeal tube to see how they functioned. In other words, successful insertion, speed of insertion, quality of ventilation, whether they give a good airway seal or not, if there's any protection from aspiration, avoiding airway trauma, and so forth. And they summated these various features in an arbitrary sort of way, but just showing that the ProSeal and the iGel and the Supreme function more effectively for all these functions than the classic LMA, and in fact the laryngeal tube as well. So they made the point that we should abandon the vintage LMA and adopt second generation supraglottic airway devices as first choice. And I think that is happening. Now, are supraglottics classified as airway generating procedures? The COVID-19 has resulted, as you know, in the promulgation of a list of medical procedures referred to as AGPs, or aerosol generating procedures. And there's a list of PPE which drives the appropriate level of PPE donned by healthcare workers, especially for AGPs. And what is characterizing as an AGP? Well, we're all familiar with this. I think intubation, extubation, front of neck airway, awake tracheal intubation, tracheostomy, bronchoscopy, high flow nasal oxygen, non-invasive ventilation, face mask ventilation, suction. There's no guidance. There was no guidance on whether SGA use is an AGP or not. And if it is an AGP, you would wear airborne level PPE. Now, maybe SGA insertion, which involves operator inserting perhaps fingers into the oral cavity, a period of PPE usually with an ensuing leak, has the potential for contamination via droplet, fomite, and aerosol routes. Maybe the process of insertion of an SGA is an AGP. And in that situation, obviously, we should use the appropriate airborne precautions, which includes your FFP3 or N95 mask. So now, looking at COVID guidance and airway rescue, we look at the guidelines published by DAS, and following your 3 attempts at Plan A at intubation, if that fails, you move on to Plan BC, and that's your rescue oxygenation, where you try face mask and insertion of 2nd generation supraglottic airway device. Again, like the DAS guidelines of 2015, 2nd generation supraglottic airways are mentioned. And if you succeed with your 2nd generation supraglottic and your oxygenation is okay, your options are to wake the patient if planned, perhaps not, maybe not also, and particularly not if it's a COVID patient. You have an attempted intubating via the supraglottic airway, or you may go to front of neck airway. And it is recommended that the Aintree intubation catheter is used. Now, I did some work on this originally in 1996 with Peter Chart, as you can see here, and myself at Aintree Hospital. And we devised this ventilation exchange bougie for fibre optic intubations with laryngeal mask airway, and eventually we called it the Aintree catheter. It's a 19 French radiopaque catheter with an internal diameter of 4.7 millimeters. It's 56 centimeters long and markings at 5 to 35 centimeters. It comes with 2 connectors. One is the 15 millimeter connector and the other is the lower lock connector, and it has a swivel adapter which allows you to seal it while you're doing the procedure, so you can oxygenate the whole time, and side holes here for jetting if needed. You can load it on a fibroscope less than 4.2 millimeters, so any standard intubating scope of 3.8 millimeters, or the Ambu Slim grey scope, which disposable, which can be useful, particularly in an emergency. So here you see this patient who has in fact been done under local anaesthetic because of an anticipated difficult airway. He's a burns patient who had this done on a number of occasions and we did a series of burns patients in placing an LMA in the patient and then intubating with the fibre optic scope with the Aintree mounted via the supraglottic airway device. And again, it's an easy procedure because when you come out of the supraglottic, you should be straight in front of the larynx, particularly if you've optimally placed your supraglottic airway device. You can do this, in fact, with any supraglottic, but preferably a 2nd generation. And here you see the patient then we spray as you go, and you railroad your endotracheal tube here, reinforced Mallinckrodt reinforced tube over your Aintree catheter. Now, which 2nd generations should you use for airway rescue? I said you can use 2nd generation, but really the ones that have been shown in the literature to be, and clinically to be more effective, are the post-seal, the iGel and the protector, but not the LMA Supreme or the laryngeal tube. So in fact, these are the 2 or 3 supraglottic, 2nd generation supraglottic airways which we use. And this is the Plan B in our hospital, where we have the Ambu scope with the iGel and the Aintree always ready to go as our Plan B in our difficult airway trolley. And this is something as well you can practice with the trainees electively. So when it comes to an emergency, it's something they can perform. Again, just to stress, blind intubation via supraglottics is not recommended in this situation, as the first go success has been shown to be very poor, and when intubating with fibre optic through the 2nd generation supraglottic airway device, the first go success improved dramatically. This is work done by Robert Greif in Switzerland. So again, which of them, just looking at this schematic, which was designed by Tim Cook and Fiona Kelly, which schematic came out best, which supraglottic came out best? And again, the ProSeal and the iGel much higher success with regard to even blind or guided intubation through them with the Supreme and the L-laryngeal tube, not as useful, or the classic LMA. So in summary, intubation via supraglottic airway device, it's recommended that you always use fiber optic guidance, and blind techniques are actively discouraged. The ProSeal and the iGel are described as the most successful to use, with the Aintree intubation catheter. Supreme is not recommended, and the classic LMA, little evidence. So what happens if you decide following your rescue oxygenation that things are a bit, you still want to go ahead with a front of neck airway because the patient perhaps is deteriorating? So what do you use then? Again, as I say, you have your supraglottic in place, and this was a recent paper which was done by Conan McCall in a gynae population, prospective observational study looking at the accuracy of the cricothyroid member identification in adult females in this group, and showing that there was very much increased accuracy of locating your cricothyroid membrane when you were supraglottic in place, oxygenating while you're doing your identification. So this might translate to better success at your front of neck, your surgical cricothyroidotomy, if you already have the iGel in situ splinting your cricothyroid and also helping to identify the membrane. So important questions when choosing a supraglottic airway device are: which ones are easiest to insert, which ones have the highest oropharyngeal leak pressure, which ones can you intubate through, and obviously there's always this cost benefit discussion as well. So we must also remember that in the COVID era, we must make the procedure safe for the staff, for the operators, and for those around them, safe for the staff and the patients. So lots of people started to discuss these intubation boxes, and many of them came to market, and there was a lot of research done on those. But also then came papers showing that in fact, rather than being protective, the aerosol block resulted in marked increase in airborne particle exposure compared with other devices or with no device, and conclusions that the novel devices intended to protect the laryngoscopist require objective testing to ensure they are fit for purpose and do not result, in fact, in increased airborne particle exposure. And overall, I think with the many studies that have come out in the last year, most show that they confer minimal to no benefit in containing aerosols during ADP and may in fact increase particle exposure. Also, this New England Journal correspondence implied that they decrease rather than increase safety. So I think many of us have abandoned using any of these sort of devices. There's also some MacGyver, I call them MacGyver devices, like homemade attempts to kind of, in fact, improve safety, but perhaps a bit misconstrued. And this was a technique looking at a closed tank probe cover for intubating with an Aintree catheter through a supraglottic airway device. We do, in fact, in COVID patients, use a plastic sheet around the supraglottic airway device and then change over to a face mask in the recovery just under the sheet, and then dispose of it with the sheet. So I think in summary, supraglottics and COVID, it's about SAS, which is the mantra of the DAS COVID era management. It's keeping it safe for staff and patients, using techniques that are reliable, familiar, and that you have practiced. So getting the supraglottic placed accurately on first attempt and making sure you have a good seal. And it's about techniques that are timely without rush or delay. So thank you very much for your attention. I will take any questions you might have.
Thank you, Alan, for your excellent talk. You have enlightened us the importance of second generation supraglottic airway devices, and also for emphasizing the correct placement of supraglottic airway devices. We'll take the questions a bit later. Now it is great pleasure to introduce our final speaker of this session, that is Dr. Hans Hutnik from Amsterdam. He has worked at various centers in Melbourne and Amsterdam, including Netherlands Cancer Institute. His interests include advanced airway management, neuroanesthesia, and high fidelity simulation. He is highly involved in teaching airway skills. He is the founder and director of Airway Management Academy and member of International Advisory Board for Anesthesia Journal. He has published numerous papers and co-authored books in relevant to airway management. Now let us hear about situational difficult airway. Over to you, Hans.
Net wat ik leuk vind. Hi all, this is Hans Huytink. I'm an anesthesiologist. I'm based and working in the Netherlands. It's an honor for me to speak to you, and thank you for inviting me. I would like to talk to you about the situationally difficult airway. First, let me tell you that there are no conflicts of interest. I'm speaking to you on behalf of the Airway Management Academy, and there is a bit of a conflict of interest with these two fellows. They're sharing the same living room with me at the moment. I hope they will keep their peace during the presentation of my lecture. We'll see how it goes. What are the learning goals? I would like to present some airway cases to you, and I hope you can learn how to manage airways under situationally difficult circumstances. If we talk about situationally difficult airways, it may be caused by poor patient positioning, there may be lack of proper equipment, there may be limited backup. If you work pre-hospitally like we do in the ambulance during the COVID area, transporting patients from the one ICU to the other, and managing airways may be a real challenge. Let me take you to Bonaire. I was privileged to work there 10 years ago for a couple of months. It's an island based close to South America. There are 15,000 people living on the island. And sometimes big ships are coming to port. And every time these large cruising vessels come to port, there were some little surprises for us, because many tourists are old and they travel on boats. And we had 3 or 4 patients who were brought to our hospital to be managed, and they were really, really sick because these ships are rather good equipped. At that time, 10 years ago, we worked with 2 anesthetists, 1 nurse anesthetist, 1 surgeon, 1 gynecologist. A cardiologist was visiting every 14 days. There were some general practitioners, but no emergency physicians. As you can see, this is a tropical setting, only 36 beds, 1 operating room, no intensive care unit. At that time, no CT scan, 1 ventilator, no flexible scope, and no ENT surgeon. It's beautiful diving, by the way, as you can see. We had to manage very small patients. They were then medevaced with a small plane to the other islands, Curacao and Aruba. Sometimes we had to intubate patients, and because there was no ICU, we had to transport them this way to Aruba or to South America. And this is the entrance to the emergency bay. This is the equipment we had to work with. And as you can see, accidents can happen. It's a small island, so it's rare. It's the incidence of accidents is not very high, but sometimes people crash their cars or their bikes. They don't wear helmets. They drink while driving, so you may end up with severe injuries. And diving is very big, and Bonaire is beautiful, and you can enter the water really easily, and you can exit the water really easily. And that was what this patient tried to do. We were called to a guy who was snorkeling on Little Bonaire, which is a small island close to Bonaire, and it's only accessible by boat. and we had to go there for resuscitation, and we had to intubate this guy on the beach. And this is the problem we had. We did not have a video laryngoscope. We used a normal direct laryngoscope, but the sunlight was so bright, and it was so the sun rays were reflecting on the white beach and on the sand, that you have really big problems seeing your equipment. So this may be a very challenging airway, in the situation, a difficult airway, because of the sun. Is it difficult? Yes, it may be really difficult. Is it a difficult airway? Not sure, but the situation where you work is really difficult and challenging. I would like to present a new way of defining airways to you. I rather like to speak about basic airways or advanced airways. And you can define a basic airway this way. It can be managed with basic techniques by a trained person, and airway rescue is most probably possible. In contrast, an advanced airway may require techniques that are not often used, and these patients should be managed by a team that has special skills and access to special airway devices. I think most of our patients have basic airways, maybe 10% or so have advanced airways, depending where you work. And in these cases, it's really, really important to find complexity factors. Complexity factors and the context determine what kind of help may be needed during airway management, and what kind of equipment can be brought, or what kind of technique can be used. And complexity factors can be found doing a special checklist. This is the way you can do airway assessment. Do airway triage, you use the phase checklist, patient factors, but also human factors, for example. You can triage your airways into basic or advanced, and if you have an advanced airway, find complexity factors. Complexity factors may be, for example, time pressure. If the blood pressure is low, or if saturation is dropping really fast, you may end up with an easy to manage airway, but because of the time pressure, it may be really advanced. So complexity factors are key. We've described it in an article in Anesthesia. It's called The Myth of the Difficult Airway, so you can read it. But you can also download the Airway Triage app, which can be downloaded on your phone, and you can find out for yourself if this is a helpful technique to triage airways. In these advanced cases with complexity, it is necessary to personalize airway management. It may no longer be possible to use guidelines or protocols because the complexity is too high. And I would like to present you some examples of these airway cases. This is a guy who was intubated on Bonaire. It's a guy who had a cardiac arrest, and then he needed intensive care unit in intensive care, special treatment, but there was not available on Bonaire, so we had to fly him to Colombia. The thing is, this guy had never traveled before, so we had to improvise, and you can see his airway on this passport. I've never seen this before. We had to call in a photographer. They made a passport, and then we were able to call in an air ambulance team from Colombia to travel to Bonaire and get this guy to a decent hospital. What are situations with airways? It can be caused by location, by the environment, or it can be caused by the patient self. Let's look at location. You may work pre-hospitally, end up in an environment where you have to care for diving victims, or you may work on an air ambulance, or you may work out of theater. And if you work out of theater, you will notice that the normal equipment may not be readily available, help may not be available. So even an out of theater location in your own hospital may cause a situation of difficult airway, or things are different. Let's look at an unusual situation that happened in Amsterdam. It was a case of flooding, and there are no big lakes or very big rivers and close to this hospital, the VU University Medical Center, where I worked at that time. What happened, there was a breakage of a water pipe. So within an hour, the basement of the hospital was flooded, and all patients of the hospital had to be evacuated. You can see the level of water because this guy is sitting on top of his truck. we had to work clinically and evacuate all these patients within a day. And the military were called, and many ambulances were called, and all patients were transported to different hospitals. We had to manage airways under really difficult situations. Is it unusual to end up with a situation of difficult airway? I think it is not. Because if you think about your own career and how many patients you care for, the situation may be sometimes really challenging. This is another example. This is a girl, 8-year-old. She had Down syndrome, and she was presented with an unstable neck. And what the neurosurgeons tried to do was to exchange the hollow frame for a cast. And what we had to do is sit the patient right up on the operating table. We had to intubate her, and then they were working for 19 minutes to make a cast. And as you can see, this is a rather strange situation because she's not lying on the table. She has to sit her up. We had to intubate her or put in an LMA while she was wearing a hollow frame. And I think in these situations, preparation is key. Preparation is of key importance when the situation is difficult, because you have to be prepared. The size LMA is also of importance in these patients because she has is 8 years old, and you cannot use adult equipment. Pediatric equipment may be available, but maybe not be the right size. You have to determine the size of the flexible scope, see if your tracheal tube fits the LMA, and if you can intubate through the LMA. So we had to figure it out before we started. And what happened, we started with LMA, she was spontaneous in breathing, and because the procedure was taking 90 minutes and we had to sit her up, we decided during the procedure to intubate her with a tracheal tube through the LMA, which was uneventful, but we were prepared. And this is how it looks like. You can see the tracheal tube was introduced through the LMA. In this way, we were able to manage her airway very safely. If you work pre-hospitally, for example, in a helicopter emergency medical service, you may end up with a situational difficult airway. We were called to a baby, 26 weeks old, very premature. It was a home birth, and the paramedics called for help because they could not intubate and only backmask ventilate. As you can see, the baby is placed in a plastic bag for temperature control, and a rendezvous was done with the ambulance and the helicopter. And this baby was intubated in the back of the ambulance, and it was really difficult because it was blue, premature. There was no saturation measurements. There were no breath sounds because of very stiff lungs. It was difficult to detect the heart rate, and we used defibrillator pads to get that, and there was no IV access. So you may end up in the situation with the patient with a difficult airway, and it can be very challenging. It's a good example of a situation in difficult airway. So I think you can conclude that the situation of difficult airway may be common, and so better be prepared. How can you prepare for these airways? I think the best way to do this is train as a team and use simulation. So if you simulate a situation in difficult airway, you know you can manage these airways if a real patient comes to your hospital. And the question is, can you manage a basic airway under situation of difficult circumstances? Even a basic or easy airway may be difficult to manage if the situation is difficult. And then the question, is it the basic airway or an advanced airway? And I think because of the complexity, you may end up with many patients with advanced airways because of the situation. I think use airway triage app to be prepared. Another example of a situation in difficult airway is this woman who fell down in her bathroom, and her blood thinner caused severe bleeding. She had a facial fracture, and try to find out for yourself, how would you manage this airway? Could you do an awake intubation? And if yes, how would you topicalize the airway? how would you administer oxygen, because the nose is totally occluded. Would you use a video laryngoscope, or would you use a gyroscope because of the blood in the airway? So this is an interesting case. I've called it the no-nose airway, because these patients can cause really a lot of trouble. It's a good example of a situation with difficult airway. We managed her with a direct laryngoscopy, and we had a backup tracheostomy because she was desaturating really quickly. And we thought we cannot topicalize the airway, we cannot administer any oxygen, and our plan B was put in an LMA and intubate through an LMA. But the intubation was luckily for us really uneventful. We used succinylcholine and propofol, and we were able to secure the airway really fast. Go back to Bonaire. We had an interesting case. I was on call, and one of the family physicians gave me a call. Said, I have an 8-year-old boy who had late dinner at Kentucky Fried Chicken, and he swallowed the bone. I asked him, are there any symptoms? Can I see the boy? So send him please to the hospital. And when we saw the boy, he had a hoarse voice. He was coughing. It was 11 p.m. at night, and the situation was as follows. There was no ENT surgeon. I didn't have at that time a flexible scope nor a video laryngoscope in the operating room, and I was a little bit anxious to put him under anesthesia, because if this bone is wedged in the larynx, I may worsen his clinical situation. So I tried to visualize the bone on an X-ray. So we took an X-ray. This is the X-ray. Try for yourself to find the bone. I had really difficulties finding the bone, the piece of bone, and see if this was wedged in the airway or in the esophagus. And then I decided, together with one of the family physicians, to call the radiologist back in Amsterdam, send them a mail, send the photographs to Amsterdam, and see if they could locate the bone. And this is the mail we wrote to them, and it's in Dutch, so I'll translate it for you. So my question to the radiologist was, okay, please let me know if this chicken bone is wedged in the airway or is in the esophagus. If it's in the esophagus, I will be, the boy will be fine, it can wait, but if it's in the airway, we may need to do some emergency procedure. And then the radiologist mailed back to me and said, okay, this is an interesting case, but sorry, I can't help you. I cannot see if the bone is stuck into the airway. I cannot locate the bone, so I'm sorry, I can't help you. So then I had to decide what to do. There was no air ambulance at night. I contacted the ENT surgeon, asked him if they could help the boy the next day. So we then made a plan to medevac the boy to Curaçao. It's an island next door. In early morning, medevac was arranged. So I went home, back home. I couldn't sleep because I said, "Well, is this the right decision?" But yeah, if you're on a tropical island and there's no help, what do you do? Next day, I came back into the hospital in the morning, and what happened? The boy was already gone. I said to the nurse, "What happened to the boy?" He said, "Oh, we sent him with the air ambulance and the pilot to Curaçao." But I said, "I'm the doctor. I'm supposed to fly to Curaçao. What happened?" Oh, so the nurse said, "This is what we normally do." So the only thing I could do was make a phone call, and I called the ENT surgeon in Curaçao and said, "What happened?" And he said, "Oh, the boy is fine." And I asked him, were we able to locate the bone and get it out of the airway? He said, "No, it's not a problem at all. We didn't bring him to the operating room." I said, "What happened?" He said, it was really easy, because when patients arrive from other islands, a culture swab is done. So one of the nurses took a swab, stuck this to the nose of the patient, he coughed, and the bone came out. So this was a case that solved very easily. I was really anxious, and I tried to make the right decision. And in the end, the solution was really easy. So just put in a swab, and the boy is coughing, and the bone will come out. Thus, I think the situation of difficult airway can occur everywhere. It can make airway management challenge, even in your own hospital. You better better be prepared for the unexpected. I think you can do that with simulation or talk some case scenarios with your colleagues, and try airway triage app to triage airways into basic or advanced. Thank you for your attention, and I hope you like the lecture. If there's any questions, I'm really happy to answer them, and hope to see you next year live in India. Thank you very much. Bye-bye.
Thank you, Hans. Sharing your great experiences of managing highly difficult airways in the challenging environment and circumstances with the limited resources. May I now invite all three speakers to join us for the QA session. Okay, thank you. As we're looking for the questions from the delegate, I will start with one first questions to Patrick. Patrick, there are lots of video laryngoscopes available in the market now, and particularly you mentioned the channeled and non-channeled. And how you make decision about which is the best one, and is there a real difference between the channeled versus non-channeled? Is it non-channeled better than channeled, or in a given resource limitation, can we buy only one type?
Thank you very much for the question. Can you hear me fine?
Yes, yes.
Okay, I think the best BL is the one you understand the best. So I'm not going to make any advertisement for any one of them, but I think there are some major differences between the ones that have a channel and the ones that don't have a channel, because the handling is different. As I said, it's the one is you have to align the anatomy with the channel, and the tube will go where the channel leads him to. Now, in specific cases where the anatomy does not align well with the channel might restrict the tube movements. So I would say, in the ideal world, you choose one with a channel, one without. Now, if you have limited resources, you must always understand to try to use the tool that will cover most of your patients, because evidently the types of patients that come into your institution will depend on the type of institutions. So I wouldn't say there is one better than the other one. That's the best one is the one you use the most. But this allows me to say one topic. If you have difficult airway, use the device you know the best. And in some institutions, it might still be the DL. In some others, if you use regularly the VL, maybe the video laryngoscope might be of advantage.
Thank you, Patrick. Thank you. So I will want to ask a couple of questions about the supraglottic airway device. Thank you for your excellent talk. Firstly, a bit of regard to the intubation to the supraglottic airway devices. I know entry intubation catheter, the most of the work is done during the time of LMA Classic. Now there are a lot of second generation supraglottic airway devices with the favorable features for intubation through them, and particularly fiber optic guided intubation, what we call as one stage or a direct intubation, where you can load a size 6.5 or 7 cup tube over the fibroscope and intubate directly through that. So do you think the role for entry catheter in the future?
Yeah, that's a good question. I still prefer to use the entry catheter. It fits snugly over your over the scope. You don't have a cuff that can get caught. I know we don't have epiglottic bars now in the newer LMAs, but in the past that was a problem. But the cuff, particularly our kind of high volume, low pressure cuffs, are quite bulky, and they can be a problem getting through, particularly if you have pathology there. And also I feel that the advantage of getting the entry, and you can railroad whatever tube you want over it then, if you're using a ray tube or whatever tube you want over it. So I still prefer the entry with the fiber optic scope. And as I say, I know it fits snugly over my scope. And when it comes to railroading, it is easier.
Thank you for that. One more slightly different question. So I know we got a wide application of supraglottic airway device, clinical indication and clinical use is day by day it is increasing. So what's your views on using supraglottic airway devices for laparoscopic surgeries, and you some literature described for some robotic surgeries?
Yeah. I think particularly the second generation supraglottic airway devices can be safely used in certain situations, including laparoscopic surgery. I tend to be careful about my choice of patient and my choice of surgeon as well, particularly for gynae-laparoscopic surgery. We do a lot of diagnostic laparoscopies. I'm very happy in the lower BMI patients to use supraglottic airway devices, knowing my surgeon and knowing how long he takes and so forth. In the obese patients, I still think it is quite difficult with the pressure in the abdomen and so forth to use supraglottic airway devices. So I'm quite particular in my choice. And any patients with a history of reflux and so forth, obviously, I wouldn't specifically use it. But they are a fantastic armamentarium for me, for my laparoscopic work. When it comes to things like, I don't use it in prone patients ever. I think you must have a plan B, and at least with laparoscopic work, you can exchange and you can put a tube in. When patients are prone, I think it is quite, your plan B is difficult if you have a misplaced second generation any supraglottic airway device. So I think just because you can do it doesn't mean you should. I have done it, but I would not teach it. I would not recommend it. And I'd find it hard to defend it personally. I know that's something that's debated and there's a lot published on people using it in prone patients, but I still think it's quite a risky procedure.
Thank you. I will hand over to Sajid to see any more questions from the delegates.
Thanks, Cyprian, and thanks for all the speakers. Wonderful session. I have a question to Hans. I was listening to your talk, fantastic talk. The initial slides, I thought I'll ask you whether I can, get that job. But when you showed the clinical scenarios, I thought, let it be. I'll stay back in Birmingham. It's quite wet and murky here. But my question is that if you have to design an airway kit for all these kind of unusually difficult scenarios, what is one toy that you will have in your kit? Your pure personal preference, and why?
That's a tough question. I think I would take a video laryngoscope, and I would take an eye gel, I think. And I will take a Frova catheter, a scalpel, a bougie. I think that would be most of the equipment I would take with me. I think most of the cases can be managed with that. And of course, the flexible scope.
You got both the parents and the, the love child, isn't it?
I think there's no universal kit for these patients.
Fantastic. And then you spoke about simulation. So how would you design a simulation for a situationally difficult airway? Because the situation is going to be different in each scenario, isn't it?
That's right. I think you can be trained to react to certain stressful situations. And if you end up in a difficult situation, then you can train it in the simulator, but of course not every scenario can be trained. But most cases, like different patient positioning or out of hospital situations, can be trained in the simulator. And if you train that very well, you will know that you can improvise. And I think that you can stop before you act. You don't have to act immediately. So I think you can learn how to react to certain different situations. I think simulation has a very powerful. It's very powerful to do that. But of course, you cannot train for every strange situation.
Absolutely. Thank you. Here is a question for Ellen. We are bound to answer this because this is from Sajay. He asked, with the obvious evidence of better safety profile of the second generation SADs, why are we still using classic LMAs in our normal practice? Are we ethically correct?
Another very good debate. Yeah, well, I prefer second generation for all the reasons I outlined and the safety profile, but yet there will be a small percentage where, because they're bulkier, most of the second generation, you may have difficulty. And if you don't place it optimally quite quickly, I sometimes do change over to a first generation. The reason being you have the cuff. So you have a deflated cuff. You can place it under the structures and then inflate and move the structures out of the way. The second reason, the type of surgery I do a lot of maxillofacial with LMAs, and the surgeon I work with can work around the slimmer classic versus, you know, the bulkier iGel ProSeal or even the protector and so forth. So I still think there's a place for the first generation supraglottic airway devices, and occasionally when you have a failed second generation, I think it's quite a good rescue because of the ability, the narrowness. When you've a fully deflated cuff, you place it with jaw thrust and then lift all the structures. So occasionally it works when your second generation isn't sitting so well. So to answer the question, preferably second generation, but have a backup first generation still. So I wouldn't throw them out yet.
Thank you. We have a question from one of the delegates who's asking whether we can use video laryngoscopes to confirm the position of SADs.
That's a very good question, because to get optimal placement, a lot of people, in particular Andre van Zondert has written a lot about this, placing all your LMAs with a scope, and more to place them rather than even check them. And because of the bulk, this is quite difficult. I have tried it and I do it sometimes. It is quite difficult to do that. It's easier with the first generation, because it takes up less space in the oral pharynx, and you can put your video laryngoscope in and you can place it. It isn't in that it lifts the structures for you. So placing, if you're really worried, placing it with a video laryngoscope, particularly if you've used a muscle relaxant, is quite a good idea.
Thank you. There's another question for Hans, because we are in the COVID time. How will you prepare yourself in terms of PPE when you're going for one of these cases?
Yeah, you have to. I think you can do that in a simulator as well, and there have been very good examples of hospitals who do that. They train their teams in a simulator, and how to don and doff PPE, and then how to react to these situations. Yeah. I think that's the best way to be prepared.
Thank you.
May I ask one more question to Patrick quickly, please?
Thank you.
One of the problems which I come across commonly, particularly with the non-channeled hyperangulated blade, the design and the curvature, the bougie, standard bougie with a two tip or sometimes tube as well, get stuck at the anterior commissure and finding difficulty to advance what I call as anterior impingement. Have we come across this problem, and do we need to redesign our tubes? I find the tubes currently designed up during from long time for the direct laryngoscopy. Do you need a different design of tubes without bevel and so on?
Yeah, everything comes back to understanding what the problem is. And I think I like to outline that the intubation process is a three-step approach. The visualization is always, or most of the times, good with the VL. And then we have this problem bringing the tube through the tracheal inlet. And if the anatomy is specifically anterior, and the angles are very steep, then evidently the tube must do this up and down movement. And by using properly stylets and tube movements, you may be able to make this tube dance. That's what I call the tube dance. So it comes down to understanding the anatomy and the devices you have in your hand, and how you can mobilize these two devices, stylets or bougie and tube.
Okay. Thank you. I think we're nearly to the time for the questions. Any more questions, Sajid?
We don't have any more questions. I think we are short of time. And I would like to thank all the three speakers, eminent talks. Thank you so much for your time. And we will move on to the next session. Thank you very much.
Oh, thank you.
Thank you for that excellent session. And now we are on to the last session of the day, and possibly the most awaited session. And it's going to be a live case-based discussion led by none other than Dr. Imran Ahmad, who will be well known in India anyway, because he has been doing talks in Indian conferences for the every other week for the last couple of years, I think. Anyway, he is the current Honorary Secretary of Difficult Airway Society UK, as a consultant anesthetist at Guy's and St Thomas Hospital, London, and lead for DAS awake tracheal intubation guideline, and also a co-author for DAS intubation guideline 2015. And the panel members, you have seen the panel members in the previous sessions, but I'll just introduce the names. Professor Ellen O'Sullivan, Professor Ramkumar Venkateshwaran, Professor Patrick Schottker, and Dr. Hans Hutig and Krish Radhakrishnan.
Lovely. Thank you, Sajay. I'm just going to try and share my screen so that we can hopefully then. Can you all see my screen okay?
Yes. Yes.
Yeah, and you can all hear me?
Yes.
Lovely. Good. Okay, well, good morning from the UK, and good afternoon to everybody over there in India. You can probably guess from what I'm wearing, I'm actually at work today, and hopefully I won't be disturbed for the next 45 minutes or so. You've already introduced our experts for this session. I'm just going to put them up again. We have Professor Ellen O'Sullivan, Professor Ram Baketswaran, Hans, and Krish. So what I'm going to do is the aim of this session is essentially an interactive session where what we're trying to do is just present some interesting airway cases, and I had them as interesting airway cases because I thought they were interesting, but after seeing Hans's talk, I might rename this as boring airway cases. See how our experts would manage the case. There's no right or wrong answer, and then just see what I did, and just share with you how I managed the case. These are all real life cases that I've actually had to deal with, and it'd be just interesting to see how we manage these cases in different places under different circumstances. The aim is not to talk about the obvious, barn door cases where you're going to have to do an awake intubation. I want to just challenge the thought process a bit more. So something like this is fairly obvious. Most of us will probably do the same thing here. But I'm going to talk about cases where they're a bit more like this. Well, this is another one where again it's quite obvious what we're going to do here and what the challenge is. But I want to just to scratch the surface a bit and go a little bit more deeper and challenge our thought processes. So this is the first case. And what we have here is a 55-year-old male who's presented with an unstable T4 fracture, and that needs urgent stabilization with a posterior approach. But the problem is the patient has also had a failed intubation previously, on which occasion the patient required an emergency surgical tracheostomy by an ENT surgeon because they just can't intubate, couldn't ventilate the patient, and therefore they had to do an emergency surgical airway. Patient has ankylosing spondylitis because of a fixed neck and has limited mouth opening. This is his airway assessment. What you can see here is that this is his neck extension. That's all he's got. You can see his previous tracheostomy scar. And I ask him to open his mouth. It looks okay from in front, but when I ask him to see how many fingers it is actually only just about 2 finger breaths mouth opening. Okay, so that's his airway assessment. So I'm going to go over to our panel. I might start off with Ram first, if I may, and ask him, how would you manage this patient's airway for his fixation of his fractured T4 vertebra?
Sure, Imran. Thank you. Just an audio check. Can you hear me?
Yes, we can hear you.
Yeah. Thanks, Imran. Before I start answering, give you my answer to this airway, I had just a couple of questions. The history does say that on a previous occasion, the patient had a difficult intubation. And how long ago was that? Because we know that ankylosing spondylitis is a progressive disease. And obviously, we don't expect the airway to get any more easier as we move along. So it also mentioned that there was an emergency surgical tracheostomy. So if you would like to share what happened on the previous occasion, that might help in our planning for the next for this occasion.
Yeah, so the last anesthetic was about 2 years ago, done by a consultant, an experienced consultant anesthetist who thought that the ankylosing spondylitis was okay, and he would be, or I think it was he, would be able to intubate the patient, but was unable to, and was unhappy to do his own emergency frontal neck airway, and so a surgeon was called, and that's why it was an emergency tracheostomy. That's what the surgeon opted to do at that time.
Okay, Imran. So the easiest answer, I think, would be a surgical trach again. But to add another angle to the discussion, I would think that because this patient has an unstable spine at the T4 level, again, positioning in the prone position is going to be another issue. And I would actually like to have this patient awake at the time of positioning, so that we don't, we are able to kind of log roll the patient and we don't further create any more neurological deficits. So I would go, the simplest solution would be for a surgical trach again this time, under local anesthesia, of course, and then assist the patient to position himself in a prone position, and if required, do a second neurological examination just to make sure that the act of positioning has not created any further issues. And of course, again, if I know the senior consultant who has handled this case earlier, I would certainly, consider that, because I have not ruled out a possibility of an awake fiber optic aided intubation, but I would think the safest way would be a tracheostomy. That's my answer.
So you've opted for an awake surgical tracheostomy under local anesthesia, position
and also awake positioning, please. Here.
Awake, and then induce anesthesia once you're happy that the patient.
Yes.
Okay, I'm going to go down my list. So Ellen, what would you do?
Excuse me. I think looking at the patient there, I would be happy to do an awake, first of all, a nase endoscopy to see what I'm dealing with, but with the view to continue, if I had a good view of the larynx, and to do an awake fiber optic intubation. Obviously, coughing will be an issue, particularly if it's a T4 fracture and so forth. So I think I would prepare him quite well with local anaesthetic to limit that. But I'm sure there's going to be some issue with that. But I would definitely go for an awake fiber optic intubation in this patient. And I don't know if you can tell me if he had any difficulties with his nase endoscopy or anything.
And you do a nasal approach?
I would do a nasal approach. I think because the angle is better and it's easier in difficult areas. Yeah.
Lovely. Okay, I've got Hans next. Morning, Hans. You're on mute, I think.
Yeah, sorry, I have to. Thank you, Imran. Good morning. I would go for an awake intubation. I think positioning in the bed can be a bit of a problem, as you will be put in a prone position. I would use, I think, high flow nasal oxygen, topicalize, and I think you can either go for a nasal or oral approach. I think if you put it in a prone position, maybe oral approach is okay. The mouth opening seems okay to do a flexible intubation. And I think as a plan B, I would go for tracheostomy. I think that seems okay. Yeah.
So you go for an awake
flexible intubation. Yeah.
And you would prefer an oral or a nasal, or you don't mind?
I think you can choose both ways, and if you put in a prone position, sometimes if they put prone the tube in a nasal position, maybe not be ideal. So maybe I would go oral intubation.
Okay, and Chris, finally, morning.
Well, I agree with all the procedures are possible, but I think 3-point immobilization of the patient is important, particularly if you are dealing with somebody with a unstable fracture of T4. Your attempts to do anything, fiber optic or tracheostomy, can make the patient move suddenly, causing more problems. So make sure either there is inline immobilization or there is 3-point immobilization. I would prefer an awake nasal intubation. However, you can also do, if you are going for oral, you can do an awake video laryngoscopy and intubation as well. That is possible.
Okay, lovely. Okay, so I think we've got more options for an awake intubation, either nasally or orally, and I think orally is probably slightly one. Personally, I think nasal might be tricky in a prone patient because there is risk that it can kink, or you might struggle with ventilation once they're prone, and you might realize that too late. So I actually went for this option, which was, I haven't got the whole video, but I did an oral awake intubation using a flexible scope, flexible bronchoscope, as well as a flexible endotracheal tube, reinforced tube, secured the airway, and then we prone the patient and put the patient to sleep. So a bit of everything that you suggested. And when we didn't opt for a nasal for the reason that we thought it may kink once we had the patient in position, and we didn't want to have to compromise that once the patient is prone, especially knowing how difficult his airway was. That's good. Okay, so that was a fairly straightforward one to start off with. This is our next case. An 18-year-old young girl who has known Treacher-Collins syndrome. She has a subglottic stenosis, and now that's resulted in her being quite stridulous, enough to her to be quite symptomatic. She has limited mouth opening and neck extension. She's quite small, only 42 kilos, and she needs the surgical procedure she needs is a pan endoscopy to assess the level of the and the extent of the stenosis, and also treatment of her tracheal stenosis if possible, because she's now is symptomatic from this. This is her airway assessment. So her mouth opening, don't forget she's only 42 kilos, is again only 2 finger breadths, and she has quite limited neck extension, which you'll see in a second. So this is her trying to extend her neck. Okay, so there's hardly any movement at all. Okay, and the surgeon wants to do a pan endoscopy and possibly treat the subglottic stenosis. Okay, so let's start off with Ellen.
Thank you very much. Now, looking at that patient, she's 18, and I would have developed a rapport with her. So because she's quite young and might be quite anxious, and I would like to do personally an awake fiber optic intubation on her. She didn't look that stridorous there. She wasn't drooling and so forth, but I would be cognizant of that. So I would definitely put high flow nasal oxygen on her. And I would do it with remifentanil, which I find is an anxiolytic as well as, and I would be generous enough with that because I feel I could probably get an LMA in there as well if I had to. But I would talk her through it, and I would do an awake nasal intubation with high flow nasal, because that does relax the patient, particularly if they have stridor. The stridor tends to be more relieved with the high flow nasal. I know she has limited neck movement, but I would probably do it sitting like you, Imran. I do it from the front in this situation, I think, and chat to her as I was doing it. I think the difficulties are her age, anxiety with the stridor, but I don't see any problems with doing awake fiber optic on her.
Okay, I'll just add a couple of points. One is she was very petite, so and the nasal, I think you'd be restricted by the tube size because of how small she is. You might not come across on the video. And secondly, the surgeon wants to do a pan endoscopy, and the surgeon wants to try and dilate the stenosis. So the tube may cause a problem with the actual procedure.
Yeah.
Down.
Sorry, I absolutely neglected to. He was going to operate on the stenosis. Yeah, that's exactly. So that's completely different scenario, because he probably would like a tubeless field here in that situation. So I would, looking at her front of neck, it looked okay. So I would probably put a cannula in there and consider jetting her. It depends what you tend to do for your surgeons for subglottic stenosis. He may want to use a balloon dilatation, in which case you could do it with just high flow nasal oxygen and put a cannula, a little needle in here as a safety backup.
Okay, I'll move on to Hans.
Yeah, I'll agree with the apnea oxygenation, and I think that's the most viable option, and you make the surgeon happy. Do we know how long the procedure will take?
Probably, well, it'll probably take a good half an hour, because you'd have to position the patient and then deal with the actual stenosis.
Yeah, and I think because of the nasal passage will be difficult, I think this is a very viable option, and I would use general anesthesia, propofol, remifentanil, and do apnea oxygenation.
And what happens if she desaturates during the procedure?
Yeah, I think we can ask the surgeons to, for a rescue, you could do back mask ventilation in between. It's not ideal, but that would be an option. Or increase the FiO2. And if you really have to have a backup plan, I think you could put in an ILMA. Yeah.
Put in
a laryngeal mask airway to re-oxygenate maybe.
Okay.
And see if you can restart apnea oxygenation. Yeah.
Okay, fine. And Ram?
Yes, Imran. I kind of agree with all that Ellen said. In fact, my plan was almost like what Ellen said. But I just want to add on one more thing. If we, since the patient looked reasonably comfortable, would it have been a good idea to get an MRI done and a virtual reconstruct, of the tracheobronchial tree? That will definitely give both the surgeon and the anesthesiologist a little more information as to what kind of problem we are getting into. And I was planning actually a good topical anesthesia and have the surgeon go on with a nasal endoscopy and maybe do a balloon dilatation. But having seen the mouth opening, I'm now tempted to also consider a supraglottic airway device as a backup. And the surgeon could definitely then have a fully anesthetized patient and could operate through the LMA, could pass the scope through the LMA and maybe definitely do a balloon dilatation. Again, the MRI report would be important. And if required, even incision of a cyanotic segment. Another point that crossed my mind was if an adult, 18-year-old girl is having stridor, I expected that the size of the tracheal stenosis would probably be around 4 millimeters, not more than that, for her to have such extreme stridor. So that was a word of caution in my mind. But when you showed us a picture, it didn't look that bad, like Ellen said.
Okay.
That's what I want to add on, Imran.
Lovely. Okay, yeah, I get the point of imaging. We did have imaging, but that was from a while ago, and it showed a marked subglottic stenosis, which is why we wanted to assess it dynamically and then treat it if they could. Krish?
Right, it would tell us not only the diameter, but also the extent, the vertical extent of how narrow is it and how wide is it, the whole, it will probably give us a better idea to go in.
Yeah, okay, Krish?
Right, this is one of my Monday cases routinely. So nothing surprising for me at all in this case. The important point here to understand is that the surgeon is going to do the procedure. He needs to do a pandidoscopy. He must have access to the airway. So what I tend to do with these patients is position them for the procedure the surgeon is going to do, get a venous access in, total intravenous anesthesia. I may choose to use OptiFlow, keep the patient oxygenated. I have a twin stream, or you can use your monsoon or whatever you like. Once the surgeon gets the scope in, I give them a good anesthetic, remain fentanyl, patient is off to sleep. Surgeon inserts his laryngoscope in the, and then I connect my high frequency jet ventilation. Patient's got total intravenous anesthesia, happily asleep. Surgeon's got the full view, and then he can dilate or whatever he wants to do, balloon dilatation sometimes with a 2-minute balloon inflation. It all goes happily. I've done BMIs of 55, narrowed down to 3 millimeters, 4 millimeters. So I'm not concerned with these cases anymore.
Okay, that's great. The only premise for what you've just said is that the surgeon needs to have access to the subglottic area. So
Correct.
what happens if the surgeon cannot get access in that situation?
Why? Well, he should, if they don't have, you always have a backup. You can have front of neck access, which a surgeon can do. You can do a variety of things to rescue that airway that others have already discussed. But as a matter of routine, if the surgeon with a straight blade often can get into the space, if he can't get in, well, wake the patient up, rescue the airway, wake the patient up, because the surgeon can't do the procedure anyway.
Yeah, exactly. So I wanted to highlight the fact that
you're frozen.
So I'll just show you what I did. So this is we did a nasendoscopy first because I want. Sorry, I'll get the volume there. I went to nasendoscopy first because I actually wanted to assess the airway myself to see how bad is this stenosis. I opted for the oral route because her nose was so small that I knew that I wouldn't be able to get any decent sized tube if I needed to. But I didn't want to intubate her anyway because I knew that would affect the surgery. And if she had a subglottic stenosis, we may have struggled to intubate her. So just going through the cord, you can see just how marked her subglottic stenosis is. And we know that we will not be able to intubate this girl. Impossible. No chance of intubating. So it has to be some form of supraglottic or subglottic ventilation. So we opted to thrive the patient, so apneic oxygenation, put the patient to sleep. Surgeon was unable to get any access whatsoever. Could not, actually no, I beg your pardon. Yeah, surgeon was unable to get any access. I then woke the patient up and we opted to do a surgical tracheostomy because we knew that the patient needed airway protection. So we actually did it under local anesthetic, so she was awake. And we've topicalized her, lots of local anesthetic, slight mild bit of sedation, and we secured the airway subglottic below the level of the stenosis. And then but we knew that we couldn't treat the actual problem because he could not get access because of the fixed neck and the limited mouth opening. So we ended up just doing a tracheostomy and protecting her airway, and we didn't actually treat the stenosis in the end. So that's a nice one, just to show that you need the options and you need to have a plan B available to you as well. And also the fact that an awake tracheostomy is an option as long as your conditions are right, and it does take a bit of time. So you need to make sure that you give yourself time, and it's not not done as an emergency, but in more controlled conditions. I won't go through the whole thing, but you can just see that we did a local tracheostomy while she was slightly sedated. Okay, good. Another case now. So this is a 35-year-old lady, and she has quite marked interstitial lung disease, okay, quite severe, and at all costs we want to avoid a general anesthetic. She has pretty poor lung function as a result. She also has a tracheal lesion, which they want to biopsy. This can be done by a flexible bronchoscope, but this is done by the bronchoscopists, and therefore their bronchoscopes are quite large. Because they've got the extra bits on them, and because they want to maybe do more than just take the biopsy, and therefore the smallest size tube it'll fit through is a size 9 endotracheal tube. Okay, and we want to avoid a general anesthetic at all costs. So how do we do this procedure? Let me go to Krish first.
Imran, these cases we used to do in Liverpool.
Muted,
Am I muted? Am I muted? I shouldn't be.
No.
Can you hear me?
Yeah.
Yes. Yes. Okay.
Can you hear me?
Yes.
Yes, Krish.
Okay. Yeah, funnily, I learned my first thing when I was working in Liverpool. We used to do a list where bronchoscopy was done purely with sedation. We used to give a bit of fentanyl and midazolam and get bronchoscopy done in a number of these patients. So we here want to avoid general anesthetic. So we can either rely totally on sedation with maybe awake sedation with a bit of remifentanil if needed, and then use topicalization of the airway, just as we do for an awake fiber optic intubation, and then see if the surgeon is able to do his scope, his rigid scope, and do the biopsy without the patient going off to sleep. That would be my choice.
Okay, so it's a flexible bronchoscope, but so you're saying do it awake, like a normal awake intubation, but just not intubate.
Yeah, don't intubate.
Okay, cool. Let's go to Hans next.
Yeah, I would prevent intubation as well. I think I've done cases like this, but for example, putting in ILMA, intubating laryngomask airway. If you topicalize the airway very well, patients tolerate the supraglottic airway with a little bit of propofol, and then they can go with a flexible scope through the ILMA, and you've got a protected airway. The case can take as long as they want. And you have a bit more security than only with sedation, as Chris suggests. But I think sedation is an option as well. Do we know where the lesion in the trachea is situated? Is it very?
It's mid-tracheal.
Sorry.
It's halfway down the trachea, but also one in the left and right main bronchi as well.
So I think if you prevent intubation, you won't end up in any problems with that lesion. So I would go for a supraglottic airway after topicalization. Yeah, and so you prevent GA. Yeah.
Okay, Ellen.
I think I'd agree with Krish, and I would do as for an awake fiber optic intubation.
But yeah, okay. So thrive, topicalize, and do it away.
And then
And what's the backup if the patient starts to desaturate?
An LMA. I mean, the patient should hopefully tolerate an LMA well, and you've topicalized, so you can use an LMA.
Lovely. Ram?
Yes, Imran, I'd just like one more investigation before we go on. Like to know how bad the interstitial lung disease is. So whether patients requiring a continuous supplementation with oxygen. And in any case, I think in addition to what Krish and Ellen and Hans have said, I would definitely consider some method of continuous oxygenation on this patient. But I think in interstitial lung disease, that's a major issue. Now they breathe well, but the oxygen doesn't get across the alveoli, as we know. So I would definitely concentrate on some method of continuous oxygenation, good topical anesthesia, and I think it's only a biopsy, so I don't think there'll be. And as Krish said, do it like any intubation, but pass the fiber scope. Of course, you have to have a very, as Ellen mentioned, I think you have to have a very understanding surgeon. You know,
Yes.
I think good teamwork is very important. So if you really know your surgeon well, I think this is a piece of cake.
Yeah.
Yeah, lovely, excellent. So, I think this case highlights it's not a patient with a difficult airway. It's a patient who needs access to the airway and oxygenation support during the procedure. And so we're using our skills as airway anesthetists to provide those conditions, but avoiding a general anesthesia, which is the key thing here. So I did basically what you suggested. So I topicalized the airway, bit of sedation. We actually used a supraglottic airway right from the offset. We had that in right from the beginning. And the advantage here was that I was able to, the patient could breathe spontaneously. We'd give some PEEP, we'd give some CPAP if we needed to, and we passed the flexible bronchoscope through the connector, as you can see here. Once the patient is awake, we turned the optical flow off, and we were just ventilating spontaneously through the supraglottic airway. Use that as a conduit, and the surgeon was then able to access the trachea, do the biopsy, and if the patient desaturates, we could just give a little bit of PEEP or do some pressure support ventilation. Very simple technique. Something that we often forget is that putting in a supraglottic airway awake is an option, and it does allow us access as a conduit. So I just thought I'd share that, just for us to think about. That was something we don't think about very often.
Imran Ram here. Just a question. So this was done by the bedside, maybe?
Okay. So my next case. I'm just going to stop whenever. I've got about 10 cases here, so I'll just stop when I need to stop. So Sajid, just let me know. We're a 64-year-old male. He needs a pan endoscopy and biopsy for an oral tumor. Okay. The imaging was done a few months ago, and he's got a reasonably sized basal tongue tumor. He can swallow liquids, but struggles with solids. When I assess him in the morning, he has no other respiratory symptoms, and the plan was for me to do a sleep intubation with a microlaryngeal tube, so the surgeon has access and then can biopsy the area of interest. Put the patient to sleep, and this is what I found. This is what I saw. So that's the uvula. There's a big, massive, large tumor there. Okay, so unexpectedly, that's what I found. Patient's asleep now. So what would you do now? Let's start off with Hans.
I think this is an impressive tumor, difficult to put something in. And how did you put the patient to sleep? What did you use? Can we wake the patient up?
No, I gave a big dose of muscle relaxant, atocurum, and
oh boy.
I would like the patient to wake up and do an awake tracheostomy.
Yeah, so I've committed myself to a general anesthesia. I was not expecting that view.
Okay, what I maybe would do as a rescue or plan B, if the patient has had used atocurum, I would probably use video laryngoscope and try to do a VAVI, a video laryngoscopy assisted flexible intubation, to see if you can maneuver and find something like a black hole or something with air bubbles and try to intubate the airway. I think that would be a viable option. If you're lucky, if you're fluent in the technique, it's often a very good rescue technique.
Yeah.
And if you can back mark ventilate, you can do that, and then put the video laryngoscope in and try to find the hole with the flexible.
And you need two anesthetists for that.
Yeah, you need an extra hand. So what I always do is you put in the video laryngoscope, and you can ask anybody to hold this like I do, and then you get the flexible scope, and you can use the flexible for yourself. So actually, you need an assistant, not two anesthetists.
Okay, Ellen.
I have a huge lot of experience with the Bonfils, and because I worked in Liverpool as well. And I would. There's a technique you go paraglossally, which comes just to the larynx, and that looks like you could get under it just at that point. Funnily enough, what we did a lot is put the gloved hand in the mouth just to push the structure a little bit to the left. If you come in from the right paraglossal side, it's a very nice technique, and your tube is there once you're in. And even if it bleeds a bit, because it's a rigid Bonfils scope, it works very well. But I think you have to have experience with the Bonfils, or else you wouldn't be trying that. But that's what I would do now in that case.
Okay, Ram?
Yeah, Imran. I'm sorry, I've got to go back a bit onto the history. I'm sorry. So was there any postural variation is what I would like to have known, because there seems to be a kind of a disconnect between the clinical findings that you gave us and what you really saw on table. There seems to be a huge disconnect. So was anything seen on oral examination? Did you see a part of the tumor? Was there any possible variation? All these things would probably help us again if it's a pedunculated tumor, we don't know, whether that would change. But certainly, otherwise, once you landed in this kind of trouble, I think the only thing is try to get past the mass as atraumatically as possible. Since we cannot back off now, as you told Hans, you can't back off at this point. Continue oxygenation and try to get past it with either a Bowfields or maybe even a flexible scope at this point. Again, a hybrid technique. You could possibly use a flexible scope so you know exactly where you're going, and probably less traumatic also.
Okay, good.
That's what I would have thought of. Yeah.
You would criticize the anaesthetist for not doing a thorough history and examination.
Not really, Imran, but I think that's important. There are a lot of residents listening on to this program. So I'm sure that we have to emphasize that. Yeah.
You're absolutely right, actually. And this was a Saturday list. The surgeon was a registrar, ENT registrar. There was no other consultant surgeon around. I was doing the list with him, fortunately, and there was a big disconnect. You're absolutely right, between the clinical between the history and what we could see to actually what we found when you put him to sleep. Completely, I was not expecting this at all. And that's why I shared it.
Huge surprise. I feel it's a huge surprise to you. Yeah.
Not this at all, and that's why I want to know, what would you do at this point? So, Krish, over to you.
Yeah, I think you're able to see the mass as that. So, thinking on your feet, because you have time, is not on your side at this moment. You can't do too many things. Be asking for a fiber optic scope or mobilizing people at that particular stage. This is an unexpected, sudden problem. So, one thing is the view is clear in front of you. You know the mass. The first simple thing is to see if you can get a bougie down that just above it. Mobilize it and get a bougie down. Very often you can. And if you cannot, then the other option is to have some kind of a rigid stillet, just like the glide ride stillet. Get it closer and just pass the mass and see if you can insert the tube in that way. So often I'm just saying what you would immediately do. There are so many options available to you. What would you do at that particular moment? My option would be the simplest option of using a bougie and see if you can get around that and get the tube in. Otherwise, you may have to do other things that others have suggested.
Yeah. Okay, good. Yeah. So it's unfortunately, obviously, at that moment in time, I don't have any videos because it was a bit hectic and very unexpected. So what I did was I did try and intubate the patient with a video laryngoscope. And I was very worried about bleeding, and he did start to bleed a little bit just by placing the video laryngoscope in, because it was very friable. But I had a flexible bronchoscope nearby, and so with a lot of jaw thrust, we did an asleep oral intubation using the flexible bronchoscope, and we decided to do a tracheostomy because the registrar was not keen on doing anything in the upper airway because he was not experienced enough and there's no consultant available. And we phoned the surgical consultant up. We all agreed that we should do a tracheostomy, cover the airway, and bring him back, and then deal with him later. So that was that case. So yeah. So fortunately, I was able to do a fiber optic intubation while he was asleep. But I think a rigid scope like the Bowfields, like the ProView, would have been something maybe more useful, because you can just sort of almost gently manipulate yourself around the mass. I don't know how much time we've got left, but I'll just carry on until I get stopped. This is case number 5.
About 15 minutes more, Imran. I've got the timer going here.
Okay, lovely.
Yeah, so 15 minutes to go for the 45 minutes. Yeah.
I have 2 more cases.
Yeah.
2 more cases. Okay, this is a 33-year-old lady. She has spinal muscular atrophy and she is completely wheelchair bound. She is now only able to move her right arm, but even that's getting progressively weaker. And she has presented because she's 36 weeks pregnant, and the plan is to how do we deliver the baby? On assessment, she has difficulty with swallowing, and especially solids. So she can just about swallow liquids. She has obstructive sleep apnea. She has extensive spinal surgery in the past for scoliosis, and has got rods running down the whole of her C-spine down to her lumbar spine. Very difficult to position because of all the contractures that she had, and she has much worsening respiratory function over the past few months with the pregnancy progressing. So the plan is how do we safely deliver this baby for this sort of patient? This is her airway assessment, and this is her mouth opening, which is that. We had to help her lift her hand up to see how many finger breaths it is, but it's obviously about one. She assured me that if her partner extended her neck a bit more, then her mouth opening is much better. So we did that. And that was how much better it got. So it's still about one finger mouth opening. Okay, so Ellen is an obstetric anaesthetist, so I might start off with you, Ellen.
I'm just going to ask, what is the obstetric plan? I mean, are they planning to section her at this point? She's 36 weeks.
Yeah, so the reason why we got involved is because they want us to know, ask us what to do. And we all opted for an elective section because of the high risk of her airway in case things went wrong. And the fact that regional anesthesia was going to be so difficult in her because of the spinal surgery that she's had.
Yeah, so basically she's going to have a cesarean section electively. She cannot have a regional, so she has to have it done under general anesthesia. I would personally, looking at her there, obviously I wouldn't attempt an oral fiber optic, but I would do a nasal fiber optic. I know some people say that's contraindicated in obstetrics. I don't think it is really, as long as you use vasoconstriction to the nares. So I personally would attempt an awake fiber optic intubation on this lady, plan the section and do that. Again, using high flow, which because of the oxygen need, and particularly in obstetrics, I always use awake fiber high flow for my awake fiber optics in obstetrics. And counseling the lady, she looks cooperative and she's not in any distress. So I would really, particularly doing awakes in the obstetric patients, I think you need to discuss it with them and tell them exactly what you're doing. With regard to sedation, I tend to use remifentanil, low dose remifentanil for these, about 1 to 2 nanograms per mil. Again, tell the obstetric and the neonatologist that you're using remifentanil. We haven't had issues with that. So I'm not sure what your plan B would be, but we might plan A. Yeah.
Lovely. Okay, let's go down. I'm going to go to Ram.
Yeah, Imran, thank you. Thank you first for, after having blocked all avenues, you at least made the cesarean delivery optional, So you left that decision to be a combined decision between the obstetrician and the anesthesiologist. And I'm glad you gave us that option because once he's reached 36 weeks of gestation, then the fetus is mature. And I think we should do an elective planned cesarean delivery. My plan was to go for a good topical anesthesia, planned awake fiber optic nasal intubation, and because the mouth opening was restricted. Once the tube is in, I would probably use less of smaller doses of maybe rocuronium, because you know that the patient also has a spinal muscular atrophy. I would definitely keep this patient in the ICU, possibly a few hours of elective ventilation because we don't know how good her respiratory musculature is. So I would go very cautiously at the point of extubation, maybe even extubate over a tube exchanger if required. And I take care of her postoperative pain by maybe using a tap block or an erector spinae block so that we don't have to use too much of sedatives in the post-op period. Minimize relaxants, minimize sedatives. I think that would be the mantra, so to say, and care for the patient in the ICU. And extubation strategy should be as extensively thought out as an intubation strategy. Thank you.
Hans?
I think all has been said, and I would go for an awake nasal intubation. As Ellen has said, I think it's not contraindicated in a pregnant patient if you use vasoconstrictors. And I think you should be prepared to do an emergency surgical airway if all things go wrong. I think if you prepare well and use high flow nasal oxygen, this case can be done with an awake nasal intubation.
Okay, awake nasal. Okay, and Krish?
Well, there is mouth opening is limited. And I know well that in pregnancy, they don't really like nasal intubations because of the congestion and the bleeding it causes. That is an option available in a difficult scenario. So the problem is, I get a tube in this lady, either using a fiber optic orally, nasally, or if permits, with a bit of video laryngoscope and a stillet, if there is room for that orally. I would try, if oral tube intubation can be done, I would prefer that in this patient rather than nasal. But the problem of intubation or airway management in this patient is only a fraction of the problem. The problem is management of this patient as a whole, ventilation and post-operative care. That is a major problem here. Airway is a smaller issue. You can do any of these. I have done one of these cases. The spinal is ruled out because you will have rods in the back and straightening, and you can't access the spinal. You'll be wasting your time. I have found in the patient that I did was to put the patient in the left lateral position, and we could intubate, do the fiber optic better in that. So what happens is, if you attempt a fiber optic in this patient in the usual way that you do, either standing in the front or the head, and if you don't succeed, worth trying a different position, putting the patient in the left lateral position. And sometimes that is successful. That's what happened in a patient that I did, where I actually could do a fiber optic with the patient in the left lateral position. So consider all those options, but managing the patient overall ventilation is the challenge.
Yeah, I totally agree, and it is a very challenging case. What we ended up doing was, as you all suggested, is I actually opted for an oral awake intubation because I wanted to avoid risk of bleeding from her nose, because I knew that it would be a risk, and then if she does bleed, then she does have a tricky airway, and then managing the airway it would have been more challenging than it already was. I'm not going to share the whole video, but it took me 3 attempts because she had lots of secretions there, and it was quite difficult to, even though we put a hyacinth patch on overnight to see where we were. But just to say, in the end, we were successful on the 3rd attempt to do an oral awake intubation using flexible bronchoscope, secured the airway, put the patient to sleep, did the elective section, and then we extubated her after having done rectus sheath blocks, as Ram suggested. But that was a real case, and options were very limited in that situation. Okay, it's going to move on to our final case. Unless we do this one very quickly, we may have be able to squeeze one more in. This is a 45-year-old male who he's got progressively enlarging rhinophyma. He's otherwise completely fit and healthy, no airway compromised. He needs surgery for his rhinophyma. This is his airway assessment. And you can see it's quite a large rhinophyma, but when you look into his mouth opening is actually quite good, and his tongue protrusion is okay. But that's essentially his, there you go, there's his mouth and that's his nose. Okay, he needs excision of that lesion. How would you manage the airway? Let's go to Krish first.
Well, sit him up, let him open his mouth wide, spray the mouth, do an awake video laryngoscope standing in front of the patient, and get the tube down, send him off to sleep.
So awake oral VL intubation, and then off to...
Standing in front of the patient. You can do that training at the top end, but I think it is a lot easier to see with that kind of a mass. Even if you stand at the top end, you rarely are going to see the mouth opening. You're better off standing in front with the patient in a incline. Certainly, we were discussing the channel, the non-channeled, something like a Pentax airway scope or an air track, or even a King Vision with a tube already mounted would be a fantastic video laryngoscope for this procedure, standing in front of the patient.
So a King Vision, if you're facing the patient, you won't be able to see the screen.
If you incline the patient sufficiently enough, you can do that. If you have Pentax airway, you can adjust the screen a little bit. So I have used a Pentax before, but AirTrack also works with a distant monitor. Yep. AirTrack would work fine. So anyway, I mean, it's a question of being there on the ground and thinking what is feasible. I'm just thinking here, sitting in my chair.
Yeah. How would you oxygenate, Krish? There's no nose. This is no nose airway. There's no nose.
Well, there's a nose we cannot see, but there is a nose, I'm sure, which works. So you can either put oral high flow oxygen through the mouth and then going from there. The chap is alive. He doesn't need us when he's eating and sleeping.
So we have to remember that he is oxygenating well enough. So just supplement oxygen.
Yeah. Okay, Ellen.
I would actually do the same. I've quite a bit of experience of air tracks from the front. And I think that works very well because you kind of bring it in and it won't get in the way of the rhymophyma. I might put a little buccal oxygen with just a little ray tube on the side. Buccal oxygen can be useful for that as well. Or just your bog standard awake oral fiber optic.
Would anybody do it on the laryngeal mask airway?
That's the other option, yeah. I mean, I agree with Imran. I think we don't use those enough. I use in all my trauma cases when there's trauma to the nose. I did one recently, even with blood in the airway, you can put an LMA in nicely with a bit of local on. And I think either an iGel, but even a classic LMA, some local, put that in and then intubate through it.
Okay, why would you not do that asleep?
You couldn't oxygenate, for this gentleman, you mean? Because you can't really, you could chance it, but your plan B then is if you lose the airway. If this falls down over his airway, it might be more difficult. So it's always safer to do these things awake.
I agree. In fact, the biggest problem here is his impossible face mask ventilation.
Yeah.
Which is why I've highlighted the case. And the plan for the anaesthetist on the day doing the list was to put in a laryngeal mask airway because he felt that actually it won't be a problem to put it in and we can ventilate. But my worry was
Imran, I'd like to say something. Sure. Would you consider doing the entire surgery with a supraglottic airway or just as a bridge to anesthetize the patient? And then I would add that as my second option, place in a supraglottic airway device and then use a hybrid technique, maybe use an entry catheter. But I would definitely be comfortable with a conventional tube in place so that there's going to be a lot of bleeding when the surgeon operates and we don't want any problem with aspiration of blood. So as a bridge technique, I agree, but I would definitely go for a more definitive airway.
Yeah, so I agree. That's what I meant to bridge. I would not intubate this guy.
No, I think from Imran's question, I misunderstood. He said, would anybody go with a supraglottic airway? So I presumed that, no, I'm sorry, Ellen.
No,
yeah.
Sorry.
I mean, that's a genuine question. Would anybody consider doing this just under a supraglottic?
Not me. No. Not me.
I've lost everybody.
Yeah. You can still see everyone.
Yeah.
As a bridge, as a rescue, yes, but not as a definitive airway.
Fine. I seem to have lost everybody, but I'm just going to show you what I did. Sorry, Hans, I'm just going to move on, and I want to show you what I did.
How to share the screen.
We're down the last 3 minutes. They must be indicating to us that we are done.
Awake intubation.
Imran, you have to share the screen. We can't see your screen anymore.
Yep.
And that was done successfully. We secured the airway with a reinforced tube, and then I put the patient to sleep, and then we did the case, which is quite
I can't see your screen, Imran.
You have to share your screen.
Sajay, can you?
I seem to have been kicked out.
Yeah.
Okay.
Your time's up.
Yeah. Okay, let me share. Sorry, I beg your pardon. Here we go. Share again.
For the honorary boot.
Yeah, there you go.
Okay.
I can see you now.
Okay, so I did do an oral awake intubation with a flexible bronchoscope, but I completely agree we could use a video laryngoscope. I just want to show you this little clip here. This was my first attempt. Can anybody tell me the mistake?
Yeah,
the Murphy's eye. The
Murphy's eye. Yeah.
Can you see?
That's a great picture. That's a great picture. We've all done that once.
Happened to me as well.
Yeah. So always check your kit before you start. It's very simple little things can cause you big problems. So I always show that just to show, even those of us do it on a regular basis can get stuck sometimes. How are we for time?
We've just got 1 minute.
Okay.
Take your time. No, it doesn't matter. Finish off this, please. Yeah.
This one's done. I think this case is done now. So I'll stop there because we can go on for ages now.
Can I just bring in Professor Mushabi because she wanted to make a comment on the obstetric case?
Yes, please, Mary.
Hello, can you hear me?
Yes.
I'm sorry, I couldn't resist that. I really needed to just comment on it. Absolutely fantastic case. And I'm not trying to advertise our paper, but actually the way you presented it really followed the decision aids that we recommended. You know, if you look at the initial recommendation of multidisciplinary decision of deciding do you go for labor or cesarean section, etc. And also, just for obstetric anaesthetists out there, one of the things we included in the paper was a resource of the 150 cases, all summarized to the pathology and how they were managed. And if you ever want to look up a case that you have and you don't know how to manage it, it's available and it's all online linked to that paper. And in fact, there was one case with a patient with exactly the syndrome you just described there. So thank you very much. And one of the other things that they mentioned is, or that was obvious, is that there are a lot of people who've done awake nasal intubation in obstetric patients.
Yeah, I think that's a myth that, Mary, that needs to be debunked. Unless they have platelet issues. A lot of people avoid it and they struggle more because patients have big tongues, there's more edema, and a nasal goes right down the back and up the... So I think we've been all taught that, but I don't think there's any evidence behind it.
Yeah. Thank you. Thanks for allowing me to comment.
Thanks, Mary.
I never claim myself to be an obstetric anaesthetist.
Thank you very much for the wonderful...
But you have a case there. You got one case on those 150.
Lovely. Okay, so Sajay, are we?
With that note, this was a very wonderful session and it was a wonderful day, and I hope people, the delegates and other speakers and chairs enjoyed as much as I did. And I have to thank all the wonderful and eminent speakers and chairs who spared their time on this Sunday in the middle of this COVID pandemic. And I know you are all very busy. Thank you from the bottom of our heart on behalf of the organizers. And the delegates have joined us from 43 different countries and nearly 2,500. We had to stop the registration at the end because the platform couldn't handle more than that. So thank you everyone who joined it. Thank you for the organizing committee for helping out with this. And the technical team, Avon Logics, did a wonderful job. And the conference was live streamed by Anesthesia TV on their channels, YouTube channels and Facebook channels. And thank you them. And you can see on the right hand side, there is a provision for putting your feedback. Once you fill in the feedback form, there'll be an option for you to download your certificate. Probably we'll have to come back after an hour or so to see the correct form to submit. And once again, I thank everyone who spent their time during the conference, and thanks a lot.
Thank you, Sajay. Thanks, everyone.
Thank you.
Thank you, Imran. Thanks.
Nice
Thank
day.
you. Bye-bye.
Thanks, Imran, for leading us through this wonderful discussion, and thanks, Ellen, Hans, Krish. As well.
Nice seeing you and you
It's a
guys.
pleasure. Thank you very much.
Take care.
Thank you. Bye. So I'm logging off. Goodbye.
Goodbye.
Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of innovative infusion system solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with FreeFlex, a state-of-the-art, award-winning innovative patented bag like none other across the market. Fresenius Kabi has TGA, WHO, FDA Taiwan, and MDA Uganda approved plants, which export to Australia. From the makers of Innovative Infusion System Solutions, we offer you a range of fully closed system bags. Together, we can create an infection-free world with Freeflex, a state-of-the-art, award-winning innovative patented bag like none other across the market.